Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing, and that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
To be able to go and even have direct individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up to date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hi everyone, I'm Alex Scholz with the PCRI, and today I get to be your host of the 2026 Moyad and Scholz Mid-Year Update. A couple of things about this conference is that this is our 11th year hosting it. PCRI has been around for 30 years this year, and we've spent 30 years spending all of our energy on creating educational content for prostate cancer patients and caregivers all around the world. And this year we get to present this conference again virtually and for free, which is amazing. I would right off the bat like to thank our sponsors Bayer and Dendreon, who help make this conference free for all of you. But before we get into all the incredible content that we are going to be presenting today, I want to have a short invocation from Pastor Tim Clark, so I will be right back.
God, we come before you and we recognize that you are the God of all healing and all wisdom. And we're really grateful that you've given humans the ability to understand how the human body works, that medical science really is a miracle, and that you today are going to be communicating through the speakers the realities of how we can align to your purposes for our bodies. I pray that people, wherever they're coming from, whatever situation they're in right now, would be blessed by the information given today, and that they would be able to go away and apply it to their lives. Lord, give everybody wisdom today as they seek to understand more. And it's in your name that we pray. Amen.
Thank you, Pastor Tim. Now, a couple of things I just want to point out is that we have an exhibit hall with a ton of information on our website. It's a virtual exhibit hall, so you have these digital booths you can go up to and interact with them. You can click on the links, you can download the PDFs, and there's a lot of free education for all of you, specifically designed for prostate cancer patients and caregivers. So if you're already on our website at PCRI.org, you already are on that page, and all you have to do is scroll down. And if you're on our YouTube channel, you can visit PCRI.org/2026 mid-year update, and you'll find a ton of information there. I would encourage you to go see what our sponsors are providing, but also all the resources that PCRI has to provide for you guys. I want to highlight a couple really cool things about this conference. Number one, this is our 11th year, which I'm really excited about because I was around for the very, very first mid-year conference that we had. The entire reason we gave birth to this conference is because we realized prostate cancer education is just changing so quickly, and we wanted to be able to update people in depth, not just once a year like our September conference where we are in person, but twice a year. And then we thought of men's health. There's just so many other topics that are important for prostate cancer patients and their families to pay attention to. So we created the Men's Health Conference we'll be having in June. Also, the PCRI conference is pcri.org/conference. This is our big September conference where we are in person hearing from world-renowned experts. But the power of that conference is really the community. So many hundreds of people come to this conference, and I have met some incredible people along the way. But the greatest thing is they meet each other. They hear about their experiences, they make friends, and they feel like you're not alone. That's the entire theme of what we do, is that you are not alone. Our job is to make sure you're not alone when it comes to education and when it comes to community. And the best way to support PCRI is to come to that conference, share your story, and have an impact with other prostate cancer patients, as well as learning from world-renowned experts and getting your questions answered in person. So please join us in September at pcri.org/conference. You can sign up. It's only $30 to attend for a 3-day conference. And I promise you there's so much you will get out of it. And I would really look forward to meeting you as well, and just reminding you that we are here for you and being able to experience PCRI's resources in person. The moderator for all 3 of our conferences is Dr. Mark Moyad. He moderates this conference today. He moderates our Men's Health Conference in June, and then also our in-person September conference. A couple of things I really appreciate about him is the fact that he brings levity to the situation. We talk about cancer all day long here at PCRI, but we want to remember that we're human beings. There's so much more to us than just the situation. And so with that, he's able to bring clarity. He's able to break down really complicated concepts into simple bite-sized kind of moments, even in the Q&A. And I really appreciate that he'll even kind of, have a back and forth with these speakers if he thinks that something needs to A, be clarified, or B, needs to be maybe explained a little further and put into context. He's just one of those doctors who understands the full picture, and he advocates for all of us when he does these breakdowns and when he does these Q&As and these master classes that he does with these speakers. So we are so grateful for him. He is the Jenkins Poe Kempner Director of Urologic and Alternative Medicine with the University of Michigan. And he has been with Michigan for quite a long time. He's published, at this point, hundreds of papers, written multiple books. He is just absolutely incredible in the work that he's done to advocate for patients. And we are so honored that he is moderating our conference today. So we really appreciate him. So make sure you give him a shout out in the comments because he's worked very hard with all of our speakers on presenting this information. Now, our first speaker is incredible. It's Dr. Jonathan Epstein. Now, some of you already may know who he is, but Dr. Epstein is I would say, the most famous urologic pathologist in the world. He has published over 1,000 papers. He's written dozens of books. He has over 21 book chapters. He is somebody who's worked for 40 years with Johns Hopkins Medical Institute, and now he has his own lab where it's Urologic Pathology of New York. And it's so cool because he's somebody who knows urology and knows pathology and has combined it together. He actually has a staging system, the Epstein staging system, named after him. And you even see the Epstein score on pathology papers now, along with the Gleason score. The great thing about today is that he's breaking down what pathology looks like in prostate cancer in 2026. He has probably looked at more prostate biopsies than anybody I know. And the great thing about him is he's making things understandable for us. He's going to speak to us on a patient level, so we really appreciate that. And then he comes in with Dr. Mark Moyad, and they really do a 7-part masterclass on the different parts of prostate pathology, again, making it understandable for us, but also asking questions that we have had submitted to PCRI for years. So without further ado, here is Dr. Jonathan Epstein.
Yeah, today I'll be discussing what you need to know about your prostate biopsy on needle biopsy. It's a great pleasure to be able to speak to the group. And I'm currently at Advanced Uropathology of New York, Global Consultation Services, and we'll discuss later how you can reach me out to send a consult. So first we'll talk about prostate cancer. Probably the most important thing for the pathologist is grading of cancer. The Gleason grading system was named after Donald Gleason, who was the chief of the Department of Pathology at the Veterans Hospital in Minnesota. And it's important to recognize that it originated a long time ago, 1967 to 1973, over 50 years ago. Obviously, a lot has changed in prostate cancer knowledge since then, leading to significant modifications of the Gleason system. So this is the original Gleason system, where Gleason came up with 5 architectural patterns, one being the most differentiated or most indolent, less aggressive, ranging up to 5, which is least differentiated and most aggressive. And what Gleason noticed was often tumors had more than one pattern. So what he came up with, which was unique for grading systems, was to say what's the most common pattern. For example, if 4 was the most common pattern, and then say what's the second most common pattern. Let's assume it was 3, and adding them together. So in that scenario, you would say 4 is the most common. It would be 4 plus 3. If a tumor is all one pattern, for example, 3, in order to keep it in line with the other grades, you just double it. So if a tumor is purely 3, it ends up being a 3 plus 3 equals 6. So in Gleason's time, tumors could range from a 1 plus 1 equal 2, a pure 1, to a 5 plus 5 equal 10, a pure 10. Just one example to show how much the grading system has changed over the years. Even in the 1990s, 22% of prostate needle biopsies had as the highest grade a Gleason of 2-4. Currently, there should be no prostate biopsies graded as 2 through 4, and virtually none graded even as a Gleason score of 5. So the two major consensus conferences that changed how we grade prostate cancer was first in 2005, one that I led, and then in 2014, also one that I was involved with. And so on the left is the grading system I just showed you that was Gleason's. On the right is kind of the current schematic diagram of how we grade prostate cancers. Even though there is this 1, 2, and 3 on the right, for the most part, 3 is the lowest grade we give. And in terms of pattern 3, in Gleason's time, 3s were more complex. They included cribriform glands, and I'll talk about cribriform glands shortly, but these glands that look almost like Swiss cheese on the far left. And what you can see in the current schematic system, grade the Gleason pattern 3 is very uniform, very simple. It looks like a bunch of little donuts. And it's basically just individual well-formed glands. And think of a gland as almost like a beach ball, and if you cut it, you'll have a hole in the middle, and that's what makes these little glands. Gleason pattern 4, back in Gleason's era, was mostly these irregular cribriform glands or irregular Swiss cheese. And currently, it's more complex in our current system. Some of them are these cribriform structures. Some of them are fused glands where the glands kind of merge together. And some are glands that are just not very well formed or poorly formed glands. And we'll talk about these different patterns of Gleason pattern 4 shortly. Again, different types of pattern 4, poorly formed glands, fused glands, and cribriform glands, which comes from the Latin word of sieve. Now, amongst these patterns, it's been shown that reproducibility amongst pathologists is lowest for poorly formed glands. So one pathologist may say, yes, I think there are poorly formed glands in pattern 4. Another pathologist might look at it and say, no, they're not that poorly formed. We're going to call it pattern 3. So that's a problem. It is highest reproducibility amongst pathologists for cribriform glands. So when somebody sees a cribriform gland, one pathologist sees it, typically another pathologist will agree. Gleason pattern 5 is the most poorly differentiated, where the tumor really doesn't make any glands anymore. You either have solid sheets of cells or individual cells. And the only thing I'll talk about with Gleason pattern 5 is that we've done several studies to show that when I think there's Gleason pattern 5 present, often it is underdiagnosed by the outside pathologist. I think there's a hesitancy by pathologists to give patients the worst potential grade possible, even when it's present. And I think it is important that when Gleason pattern 5 is present, to note it in the report, because that's going to be important for treatment and prognosis. So some of the problems with prostate cancer grading. So routinely, and every day I'm looking at many prostate biopsies, many sent in from other institutions. So when I regularly review prostate cancer biopsies, either sent in by patients or clinicians, I will often change the grade, either from a 6 to a 7 or maybe a 7 to a 6, which, as we'll talk about, is critical for active surveillance. But also, even if you're not on active surveillance, I also frequently change higher grades as well, which can impact treatment and prognosis. Probably the most important thing on that pathology report, in addition to making sure there is cancer present, is that the grade is correct. And that's the foundation for optimal treatment for prostate cancer. Just to show you a problem with grading, there was a large study done looking at 2 different patient cohorts. And what they found was about 8% of biopsies that were called a 3 plus 4 equals 7, when the radical prostatectomy was done, the whole tumor was looked at, they couldn't find any 4. It was all 3 plus 3 equals 6. And what they concluded, and what I agree, is most likely this resulted from the biopsy being overgraded. And in fact, the biopsy was probably a 3+3 also. And that led to overtreatment, because if that patient had a biopsy of 3+3, very likely in today's practice, they wouldn't have had a radical prostatectomy. So this emphasizes the importance of accurate biopsy grading. So why is there discrepant grading? Most pathologists are good diagnostically and most will grade accurately. However, a significant minority will not, either due to inexperience, lack of skill, which can result in blatantly in error. But some cases, grading can be subjective. And in these cases, if there's a borderline case, again, you want to rely on a pathologist with the most experience. Let me briefly touch upon an issue where there's been controversy about calling Gleason score 6 cancer. And that's relating to the fear of term in the word cancer. So potential is that cancer, if you're diagnosed with cancer, can drive overtreatment. Fear of death from cancer likely does play some role. And if you could remove the label of cancer, maybe that would reduce unnecessary treatment for low-grade prostate cancer. Just to show you fact which emphasizes this point, in the past, about 8% of men, when I was at Johns Hopkins, on active surveillance, opted out, underwent definitive therapy, whether it's radiation or surgery, even though they still qualified for active surveillance, just due to anxiety associated with living with cancer. So these proponents who say this fear of cancer drives overtreatment has basically been proponents to say we should rename Gleason score 6 as non-cancer. And this is an ongoing debate. These are just some of the articles and studies I've been on where this debate has gone on in the literature, but this debate continues today. So let me explain why my personal opinion as a pathologist is that we should call Gleason score 6 cancer. First of all, under the microscope, and even in terms of its molecular findings, Gleason score 6 is cancer. Gleason score 6 looks like has higher grade cancer under the microscope. It has many of the molecular hallmarks of prostate cancer. When you look under the microscope, Gleason score 6 is locally invasive. It creeps around the prostate, which benign glands don't do. It can even spread out of the prostate and rarely invade the seminal vesicle. All hallmarks of more aggressive disease. But probably the most practical reason why I favor keeping Gleason score 6 as cancer is the problems of upgrading of Gleason score 6 on biopsy. So 20 to 30% of the time when Gleason score 6 is diagnosed on biopsy, and let's say a radical prostatectomy is done, the radical prostatectomy shows higher grade tumor. So it's upgraded. Even if you look at low risk prostate cancer, which is just 1 to 2 cores, no core has over 50% cancer, the PSA is low, there's a 15% risk of having worse cancer that was missed on the biopsy. Even if you look at lesions that weren't even seen on multiparametric MRI, PIRADS 1 and 2, and you have a Gleason 6, there's still a 20% risk of upgrading over time. So the problem, if you do not call Gleason score 6 cancer, is there's potentially 20% or so of the time, you risk mislabeling a patient who has unsampled more significant cancer. These patients, if we rename Gleason score 6 as not cancer, would be told they don't have cancer. And in my opinion, there would be a greater risk of them not being followed closely with repeat biopsies, repeat imaging, and follow-up visits. The other reason why I think we should still be calling Gleason score 6 cancer is I think patients are becoming more knowledgeable about the disease and don't just have this knee-jerk reaction that all cancer is horrible cancer. And I think that has been shown with a couple of studies, over 150,000 patients, where we see the number of radical prostatectomies with Gleason score 6 decreasing over the last decade or so, from almost 50% to 14%, another study down to 8%. And this is, I'm sure, decreasing even more with more recent years. So I think patients are now recognizing more and more that active surveillance is the preferential treatment for Gleason score 6 cancer, even though we're calling it cancer. The other important thing is Gleason score 6 is not the only important parameter to look at. For example, you can have a Gleason score 6 with a PIRADS 5 lesion on MRI, which is very worrisome, a Gleason score 6 with a very high PSA, a rapidly rising PSA, a BRCA2 mutation, which is associated with aggressive disease. if we call Gleason score 6 not cancer, would we call all of these not cancer, even though these are at even higher risk for more aggressive disease? So I think we still should call Gleason score 6 cancer. But I agree, we have to change what patients think when they hear that they have a Gleason score 6 cancer. And that's mainly up to the urologists. They're kind of the gatekeepers, the first ones to talk to patients when they're diagnosed with prostate cancer. They have to reassure patients, educate patients. But as pathologists, I've been a big proponent to modify how we report prostate cancer to more accurately reflect their behavior. So as I mentioned, currently Gleason 6 is the lowest grade we give to prostate cancer, even though the scale theoretically goes from 2 to 10. It's confusing to have a grading system where 6 is the lowest grade. Every other grading system in the human body for every other tumor, grade 1 is the lowest grade, and that's intuitive. Gleason score 7, if you just tell somebody they have a Gleason score 7, that's also misleading because, as I mentioned at the onset, Gleason score 7 can be a 4 plus 3 equals 7 with more 4 than 3, and that has a much worse prognosis than a tumor with more 3 than 4, which is also a 7, but it's a 3 plus 4 equals 7. Gleason score 8 through 10 are often just lumped together as high-grade disease, which, as I'll show you, is also incorrect. So in 2013, we came up with a more patient-centric group grading group system, where you break grades into 5 groups. Grade group 1 is the best grade, most indolent. Grade group 5, the worst, most aggressive. Grade group 1 is less than or equal to 6. So anything from a 1 plus 1 equal 2 to a 3 plus 3 would all be grade group 1. Grade group 2 is 3 plus 4. Grade group 3, 4 plus 3. Grade group 4 is Gleason 8, and grade group 5 is 9 through 10. And that was based on data. And that showed that if you have a grade group 1 and you have a radical prostatectomy, you have a 96% cure rate. You might wonder why it's not 100%, because as I'll tell you shortly, if you have a Gleason 6, it's incapable of spreading out of the prostate. But some of these Gleason 6s had positive margins. The surgeon couldn't get around the tumor for various reasons, and that's why 4% of them recurred. Grade group 2 or 3 plus 4 equals 7 still has an excellent cure rate, 88%. If we think of any other cancer of the body, an 88% cure rate is amazing. Grade group 2, 4 plus 3 equals 7, even though they're both Gleason 7, drops significantly down to a 63% cure rate. Grade group 4, Gleason 8, 48% cure rate. And grade group 5, 9 through 10 has basically twice as bad a prognosis as grade group 4 with a 26% cure rate. The grade groups have correlated not just with follow-up after radical prostatectomy, but basically every other parameter that we can think of to measure prognosis in prostate cancer. So the grade groups, I think, do a better job than the Gleason system and how we report prostate cancer. Grade group 1, as opposed to a 6 out of 10, it's intuitive, excellent prognosis, no metastases, gets away from the whole problem of grade groups 2 through 6. It's all just grade group 1. Grade group 2, as opposed to a 7 out of a 10, 7 out of 10 sounds not that great. It's closer to a 10 than, for example, a 1. But grade group 2 is closer to a 1. It has a very good prognosis, rare metastases. Grade group 3 forces people to separate out 3 plus 4 versus 4 plus 3. Similarly, grade group 4 forces to separate out 8 versus a 9 through 10. And then grade group 5, whether you have a Gleason score 9 or 10, really doesn't make a difference. They all behave quite aggressively. It's been recommended to use the new grading system along with the Gleason system, at least for the current time period. So the way we would report, for example, 4 plus 3 equals 7, is we'd say, adenocarcinoma of the prostate, Gleason score 4 plus 3 equals 7, but then put in parentheses after it grade group 3. The thought is eventually we may just report grade group 3, but currently that's not the practice. Now, even though that's, I think, an improvement over what's been in the past, we can do better. And the major pathology societies have recommended to report percent pattern 4 when you have a Gleason score 7 on biopsy. So in the past, for example, it was very simple. You might just say there's adenocarcinoma of the prostate, 3 plus 4 equals 7, and you say how much cancer there is. But now, let's say if you had a 3 plus 4 equals 7 with just a little bit of 4, you would report it as adenocarcinoma of the prostate, Gleason score 3 plus 4 equals 7, and note, for example, 5% or 1% Gleason pattern 4, and then the volume. But you can also have a 3+4=7, almost up to 50% pattern 4. And in that case, in a different case, you would report it as adenocarcinoma of the prostate, Gleason score 3+4=7, close to or approaching 50% Gleason pattern 4. So why is it important to give the percent pattern 4s when you have a 3+4=7 or grade group 2? And the reason, even more and more nowadays, is that active surveillance, while becoming almost standard therapy for Gleason score, is increasingly being used for selected favorable intermediate risk patients, typically low volume grade group 2, so low volume 3+4=7, depending on a lot of factors, life expectancy, other clinical and radiological factors. And in this setting of a 3+4=7, when you're thinking, can this patient go on active surveillance, reporting the percent Gleason pattern 4 can be critical. So let me show you two scenarios where one, you might recommend active surveillance, the other not. So if you had a 3+4=7 with less than 10% pattern 4, that today could be a good candidate for active surveillance, again, factoring in other parameters. But if you had a 3+4=7 with close to 50% pattern 4, that's a borderline 3+4 and 4+3. In my opinion, for most of the vast majority of the patients, that wouldn't be a good candidate for active surveillance. But if you just reported it as 3+4=7 like we used to, and still some pathologists do this, you have no idea which type of 3+4 you have. There's also a rationale for reporting percent pattern 4 when you have grade group 3 or 4+3, and that's mostly for radiation therapy. So if you have a grade group 2, which is 3+4, that's considered favorable intermediate risk. Most of those patients do not get hormone therapy prior to radiation. But if you have a grade group 3, that's considered unfavorable intermediate risk, 4+3=7, those patients often get hormonal therapy, again, depending on other parameters. So take, again, two different patients. One has a 4+3 with 90% pattern 4. That's a 4+3 bordering on a grade group 4, 4+4=8. That patient you would treat aggressively with hormone therapy prior to radiation. But if you had a 4+3 with 60% pattern 4, that's a grade group 3 bordering on a grade group 2. Typically, you probably would not give hormone therapy in that setting. So I've emphasized grade, which is the most important thing. The other thing that you will see on your pathology report is a quantification of cancer. So one thing you typically will see will be the number of positive cores. The only time you might not see the number of positive cores, if cores are all fragmented, sometimes you can't be sure how many cores are positive. And in that scenario, what I will say is the tumor occupies 20% of the fragmented tissue. So even though you try to give the number of positive cores, sometimes it's not possible. The other way to give, in addition to the number of positive cores, you try to give a measurement either how many millimeters of cancer there are or the percentage of cancer per core. There's no real right way, one way or another, to do that. A lot of studies have shown they're about equivalent, but you may see different reports, one doing millimeters of cancer, the other doing percentage of cancer per core. Again, both are fine. But what I would emphasize, in general, the extent of cancer is not nearly as critical as the grade. So for the most part, when you're reading your pathology report, don't focus too much on the extent, look more at the grade. Now, another issue that I'll bring up, because it can lead to a discrepancy that's confusing to patients, is when the cancer is discontinuous. So that red that I'm showing here is a core, which is basically a thread or of tissue that the needle takes out. And I've shown that in this particular example, there's only two tiny spots of cancer represented by the blue dots. And this is not that infrequent to see cancer not just as a sheet going all the way up and down the core, but there can be intervening benign tissue in between the cancer. In this, you could come up with two different ways that a pathologist would report this case. One, they could look at how much cancer is involved in the total area of that core. And if they did that, you'd say cancer is involved in 5% of the area of that core. You divide the blue by the total red. But the other way to say it is that there are small foci of cancer, small little bits of cancer, discontinuously involving 80% of the length of the core. meaning you measure from one end, one blue dot to the other and saying that's 80%. We've done studies and other studies have shown that in the majority of cases, when you see something like this, two spots of cancer separated by a lot of benign tissue, and you look at the whole prostate in that setting, in the prostate, it's one big tumor that the needle biopsy is just sampled an area where there's cancer, benign cancer, but overall, it's a bigger tumor. So based on that, the way I report these findings is that this is 80% of the length of cancer, not 5% of the total area. Another thing you'll see on a pathology report is whether there's perineural invasion. It is a predictor to somewhat of prognosis. It can predict exoprostatic extension. It's not 100%, but it has some prediction at radical prostatectomy, and it has some prediction of progression following external beam radiotherapy. It is more reproducible than grading. It is recommended to include it on your biopsy reports. But just like with measurement of cancer, what I would emphasize is that perineural invasion is not that critical for patient management and typically will not affect eligibility for active surveillance. Now, I'm going to introduce another term and describe this, which is very important and is more aggressive than, for example, perineural invasion. And that's intraductal cancer. So first of all, let me just explain kind of what a duct is in the prostate. One way to think of the benign, the non-cancer prostate, is think of it as a bunch of pipes, a bunch of hollow pipes that have a bunch of branching all over the place. And all those pipes branch, and at the end of those branches are basically little grape-like units, which are the glands that I talked about, little balls that are hollow. So you have this duct system, these pipes in the prostate. And then cancer basically is in between these pipes and in between the grapes, creeping all around. That's prostate cancer. But what can uncommonly happen is that the creeping cancer, the invasive cancer, can literally break into these tubes, break into these pipes, and start growing into those pipes. And that is what we call intraductal cancer. However, uncommonly, intraductal cancer can only be within those pipes. Where you have no invasive cancer anywhere else, it's kind of a precursor to cancer, what we call an in situ cancer. Very uncommonly, you get, for example, a whole prostate out at radical prostatectomy, and there's only intraductal cancer. There's no invasive cancer. In that setting, those patients are 100% cured because the cancer that is confined within those pipes doesn't have the potential to spread anywhere outside the body. Most cases under the microscope, when we see that intraductal cancer growing within the ducts, growing within those pipes, we'll also see next door to it under the microscope invasive high-grade cancer. In that setting, when we see intraductal cancer associated with invasive high-grade cancer, which is most of the time, we grade the intraductal cancer, we consider it large cribriform glands of Gleason pattern 4. Many pathologists will just lump intraductal cancer and cribriform cancer together, not even try to prove if intraductal cancer is present. However, and this is what is the current practice where I am, some clinicians want to know if intraductal cancer is present, even if there's more aggressive cancer somewhere else. And that's because that can affect whether to do surgery or radiation. And our radiation oncologists tell us that if intraductal cancer is present, that will actually affect how they do their radiation and what dosages they give. Now, in the rare case that a biopsy, if you get back a biopsy report and it says just intraductal cancer, it doesn't say anything about invasive high-grade cancer. In that setting, we don't grade it. We don't consider that as large cribriform cancer. It's all this precursor cancer confined to the ducts. If you get a case which shows only intraductal cancer, there's no invasive cancer, most cases you'll undergo a repeat biopsy to try to see if there is unsampled higher grade invasive cancer. But sometimes, even if you don't find a higher grade invasive cancer, most experts, myself included, would recommend treatment. And that's because even if that intraductal cancer right now is confined within those pipes and ducts and can be cured 100% of the time, it has a higher risk of breaking out of those ducts and invading, at which point the prognosis becomes poor. So let me go a little bit more into active surveillance. So when you talk about criteria for men for active surveillance, one is age to some extent. The older the person who has a shorter life expectancy, you feel more comfortable doing active surveillance on, even if they may have somewhat more aggressive disease. Somebody who's relatively young in their 50s, who has 30, 40 years of life ahead of them, you want to be more stringent probably for the criteria that you allow for active surveillance. Something that I have found, obviously talking to patients, is patient preference. There are patients who really strongly want active surveillance and are very engaged in it and are comfortable with it. And then there are other patients who basically say, I just want this cancer out of me. I don't want to wake up every day thinking there's a cancer in me. Maybe my father died of cancer, my relative died of cancer. I just want treatment. So patient preference obviously is important. How extensive that cancer is based on imaging or clinical stage is important. Needle biopsies, we talked about, I'll talk a little bit more. And then the other important thing is PSA. PSA can be kind of a global indicator of how extensive the cancer is, because sometimes the biopsy or imaging may underestimate the cancer. And if the PSA is very high, that's giving you a clue, a signal that there's probably more cancer there that was just missed by the biopsy or the imaging. And you'll see the word PSA density a lot. I'll briefly describe that. It ends up being a better measurement of PSA in some cases than regular PSA. So it seems like a long time ago, but in 1994, I was part of a study that was the first study to basically try to come up with well-defined criteria to predict cancers that could undergo active surveillance. And at that time, and you have to recognize 1994 was quite a long time ago, the thought of active surveillance not treating prostate cancer was a radical concept. Many experts, probably the majority of experts in the field, majority of urologists, for example, did not want to do active surveillance and thought it was the wrong way to go, that patients were going to be dying left and right by doing active surveillance. So when we came up with a model, preoperative model, to predict who would be the best candidates, we call it very low risk, for having active, which would be good candidates for active surveillance, we tried to come up with the most stringent criteria where virtually every one of these patients would have good cancer for active surveillance. We wouldn't subject almost anyone to risk of being on active surveillance. So first of all, our criteria were the patients had non-palpable disease on rectal exam, which is the most common way that prostate cancer presents today. Gleason score 6, only 3 cores or 1 or 2 cores with cancer. No core had a lot of cancer. And then the PSA density, which is you take the PSA divided by the gland weight, which can be done on ultrasound or other imaging. It was less than 0.15. And the reason why PSA density is a better measurement, even benign prostate tissue makes PSA. So if you had a 100-gram prostate, a huge prostate, you could have a PSA of, that's 10, and your PSA density would be 0.1, 10 divided by 100. So the PSA density is low, which means don't worry about cancer. But just the PSA 10 by itself, if you didn't do the PSA density, would be worrisome for cancer. So PSA density is helpful when the prostate is either very small or very large. So when we try to predict who's going to be a good candidate for active surveillance, we talk about what's going to happen in the future. And if on the future they have worse pathology on the subsequent biopsy, we call it reclassification. We don't use the word progression. The reason why, progression implies that, for example, if you go from a 6 to a 3 + 4 = 7 on your second or third biopsy on follow-up, progression implies that that 6 became more aggressive. It progressed from a 6 to a 7. The disease changed in some way. But in fact, the vast majority of times when a 6 on the first biopsy ends up showing up as a 7 on a later biopsy, it's not that the tumor changed, but that 7 was there at the time of the first biopsy, it was just missed. So it's more sampling than anything else, why you have higher grade on a subsequent biopsy. And we call that reclassification. So one of the things you'd like to do is, can we predict when somebody's diagnosed and we're thinking of doing active surveillance, can we predict what's the chance of them having worse disease down the road? You could look at PSA on follow-up and say, does that help? And unfortunately, it really doesn't. So even though it's standard for all kind of follow-up on active surveillance to do PSAs, in general, PSA can bounce around a lot. So PSA can go down a little bit, can go up a little bit, but over time, the patients who have worse disease on follow-up don't necessarily have higher PSA later. The one importance of doing PSA for a man on active surveillance is to look for rapid rises of PSA. In that setting, when it's rapidly rising and continuously rising, that's worrisome that there may be something worse there. But if it goes up a little bit, goes down, goes up and stays a little bit at the same time, again, that's in a sense noise. It doesn't really have that much significance. Now, I'm not saying PSA is not useful. PSA is useful to help diagnose prostate cancer. Once you've been diagnosed with prostate cancer and being followed on active surveillance, PSA, with the exception of a rapid rise, isn't that helpful. We came up with a tool to try to predict who's at more increased risks of having worse disease if they're diagnosed with, for example, a Gleason 6. And the things that we found were important is if you were diagnosed before 2005 with a Gleason 6, you have a significant chance of having worse disease over time. And the reason is, if you remember, that first consensus conference and when we changed grading was 2005. So prior to 2005, things that were called Gleason 6 today, we would often call them higher grade. And that's why if you've been diagnosed with the low-grade cancer before 2005, it may not be accurate. Turns out the older you are, the greater the risk of having worse cancer. No one knows why. And it's not saying that every man with older disease has worse cancer, but there is a correlation. Your PSA density at the time of your last biopsy also plays a role. If you have a higher PSA density, you're at increased risk of having worse cancer down the road. If you have cancer bilaterally on both left and right side of the prostate, that increases your risk of having worse cancer. Low risk versus very low risk. Very low risk is, again, Gleason 6 with just a little cancer. Low risk is Gleason 6 regardless of how much cancer. That makes a difference. And then another thing that's very important is how many times you've been biopsied still with a Gleason 6. So if you're on active surveillance and you've had just your first biopsy of Gleason 6, that's not telling you that much because you haven't sampled the prostate that much. There could be worse cancer somewhere else in there that you'll find on the second biopsy, which we call a confirming biopsy, or on a later biopsy. But if you're somebody who's had, you've already had 3 biopsies, you've had 4 biopsies, they're all Gleason 6, what that's telling us is that, yeah, that's true. You probably truly have a pure Gleason 6, and there's not worse cancer there hiding somewhere. And what we found is you can give points to all these. So you say, let's say you're 70 years old, you come up here and you get, 28 points. You look at your PSA density, you go up there, you see how many points that is, when you're diagnosed, et cetera, et cetera. You add up all the points, and then you come down here and you say, what's the chance on a subsequent biopsy of having worse cancer, higher grade cancer? And what we found is that when we use this tool, 60% of the time we can predict that in 60% of the times, we can predict that somebody's going to have a low risk of their grade changing. And what that means is that in 60% of the time, using this calculator, we can reassure patients that they have a high probability that they'll stay on active surveillance based on their not being reclassified to worse disease. And then also, we can start spacing out the repeat biopsies. So one of the things that we're now trying to do with active surveillance as we're following men longer and longer is initially, you get a biopsy, it shows, let's say, Gleason 6. We do what's called a confirming biopsy about a year later to try to see, to the best of our knowledge, if that's accurate, that it's truly a Gleason 6, there's not worse cancer there. And then, depending on what your urologist feels, depending on the imaging, your PSA, multiple factors, you try to start lengthening out the biopsies, maybe to 2 years, to 3 years as you go on. Now, in addition to biopsy findings and all the other factors that I mentioned to decide whether to go on active surveillance, there's also molecular tests. And I'm just talking about one of them. There are others out there. I'm not trying to be a proponent of one test or another. But a test that is commonly used is the Decipher test. And in this study, What it showed was that using the Decipher test can help predict who has a chance of having a higher grade tumor on a subsequent biopsy, especially when you had a grade group 1. What it did show, however, or didn't show, was that if you had a 3 + 4 = 7, let's say, and you're on active surveillance, at least in this study, it wasn't that helpful to predict who's going to develop a 4 + 3 later on. So I'm often asked, should I get these molecular tests? How would you use them to help in decision making? So the way that I conceive of it, let's say you have favorable pathology, Gleason 6, and then you decide, okay, I'm still a little uncomfortable maybe going on active surveillance. You do one of these molecular tests. Molecular test is also favorable. It's one more piece of information that hopefully can be reassuring for you to go or stay on active surveillance. On the other hand, if you have favorable pathology and the molecular test comes back high, unfavorable, that's basically a red flag. But there's kind of a disconnect between the pathology and the molecular. It doesn't always mean the molecular is right. I've seen it when it's wrong. And it doesn't always mean the pathology is right, but it does give you pause to say, can we do something further to try to say what's going on? And in my opinion, what you would do in that situation is prompt additional biopsies, maybe more frequent biopsies, maybe do another molecular test from a different company that looks at different parameters. But it again gives you additional information to make a decision. Now, one of the kind of most important aspects nowadays is active surveillance for Gleason score 3 + 4 = 7. Is it safe? When can we do it? As I mentioned earlier, more and more men are undergoing active surveillance for some 3 + 4 = 7s. Well, when at the onset of active surveillance, it just wasn't done. So are there subgroups of 3 + 4 = 7 who would be good candidates for active surveillance? And you try to look at all the parameters you have: the extent of cancer, the percent of Gleason pattern 4, the nature of the Gleason pattern 4, is that cribriform pattern versus a non-cribriform, and then even if it's cribriform, there's different types of cribriform. So let me break some of these down. So the National Comprehensive Network, which is a group that makes recommendations that many institutions follow in the United States, has used the term favorable intermediate risk. What they define as favorable intermediate risk is that it's a 3 + 4 = 7, grade group 2, less than half of the cores are positive, and then either the rectal exam is not that bad or your PSA is not that high, either one of them. Now, when you look at outcomes for men with intermediate risk on active surveillance, this is from the SEER database. It's basically looking at all, as we can see here, over 100,000 patients from different pathology reports. The strength of the SEER data is that it's huge numbers. The weakness is they're just getting data off of pathology reports. So it's not being reviewed by experts necessarily. It's just whatever pathologists were at different institutions, and whatever they reported, that's what the SEER uses. So there are, again, pluses and minuses of SEER data. What we look at is on the top is low-risk patients. So these are Gleason 6, grade group 1. And you see there's a red curve and a blue curve. And you can basically, hard to make out the red and blue because they're literally overlapping. And the reason they're overlapping is the blue is low risk on active surveillance, and the blue is low risk on treatment, and the red is low risk on active surveillance. So what we can see is that the red patients on active surveillance have the same exact prognosis as the patients who are being treated, all in support of doing active surveillance. When we come down to favorable intermediate risk, again, 3 + 4 = 7, not as much cancer, either not a bad rectal or not a bad PSA, you can see these curves diverge. And what we can see is that the active treatment now in blue does much better. These patients are progressing more. Their survival is actually decreasing with the favorable intermediate risk, out 5 years and greater. So if you look at just this, gives you pause about doing active surveillance for favorable intermediate risk. But can you try to find a group within the favorable intermediate risk group that's maybe better prognosis? So we looked at this, and If you look at low risk and very low risk, that's Gleason 6, and then they have radical prostatectomies. Back then, when I was at Hopkins, a lot of these men were still undergoing radical. We could see about 6% of them had bad pathology at radical, adverse pathology, that in retrospect, you say that's good the prostate came out. However, favorable intermediate risk, 25% of them have bad pathology. So if you were on active surveillance with favorable intermediate risk, 25% of those patients potentially have serious disease that you wouldn't want to be treating with active surveillance. Even if we try to take that favorable intermediate risk and say they only had 1 or 2 cores positive and not a lot of cores, cancer in core, still almost 20% had bad pathology or radical prostatectomy. Again, raising questions about doing active surveillance for favorable intermediate risk. You can argue, what if they had a multiparametric MRI guided biopsy? Maybe that would be better at finding the aggressive cancer and finding who's the best candidates for active surveillance. And this study showed that even if you had a favorable intermediate risk on a multiparametric MRI guided biopsy, there was a 12% chance of having bad pathology. So again, maybe you would have been undertreating 12%. Not as bad, but still, it's a risk. What hasn't been looked at as much is there a cutoff for percent Gleason pattern 4 to help identify which men with a 3+4 can undergo active surveillance. And even if you did come up with that, there's different ways for pathologists to calculate that. What is lacking is long-term follow-up studies looking at the percent pattern 4 with men in active surveillance. And that's what we really need. The other thing is the issue with cribriform glands. So the vast majority of studies on prostate cancer with cribriform architecture shows that these are basically a bad pattern 4. It's associated with aggressive outcomes, molecularly they're bad. And so if you had a 3+4 = 7 and there was cribriform glands, should that rule out active surveillance? Number one, a lot of pathologists do not report whether there's cribriform glands present or absent. They should, but they're currently not. But also, even if there are cribriform glands, the size of the cribriform glands can affect prognosis. Most of these studies on cribriform glands have shown that the larger cribriform glands are the ones with the worst prognosis. So on every report, when I see a 3+4 = 7 or a 4+3 = 7, even higher grade, I will report whether there's large cribriform glands present or absent. But again, that's not the case in many pathology reports. But as I emphasized, we do need longer follow-up studies, also with cribriform glands and large cribriform and small cribriform on active surveillance. What about other findings? Let's say you have cancer, Gleason 6, or maybe even a 3+4 = 7, and you're on active surveillance. Elsewhere in your biopsy, or maybe on your repeat biopsy, you'll see the word atypical or ASAP. Basically, ignore that. Once you have cancer, ASAP or atypical means nothing. Similarly, you may see on another core, or even on the same core that you have cancer, you might see the word high-grade prostatic intraepithelial neoplasia, HGPIN. It's confusing because when you see the word high-grade, you think that's horrible, something bad, because you think of high-grade cancer as bad. Turns out high-grade prostatic intraepithelial neoplasia means nothing once you have cancer. So despite the term high-grade, ignore it if you're on active surveillance already with cancer. Now, as I mentioned, a finding that does affect active surveillance is intraductal cancer. Typically, as I noted before, it's often associated with high-grade invasive cancer. So let's say you have a Gleason 6, you're on active surveillance, but one of the biopsies shows intraductal cancer. That's telling you that probably elsewhere in your prostate, there's unsampled high-grade cancer, and consequently, you should not be undergoing active surveillance. So intraductal cancer typically is a contraindication for active surveillance. You may also see the term atypical intraductal proliferation, or AIP. Those are glands that have some features, but not all of intraductal cancer. So it's important, if you're on active surveillance and one of your biopsies show AIP, to talk to your urologist and say, can you find out from the pathologist, is this an AIP suspicious for intraductal cancer, or is it an AIP not suspicious for intraductal? Because there is a spectrum. If it's an AIP suspicious for intraductal cancer, And otherwise, you have all the good criteria for active surveillance. What I would typically recommend is a repeat biopsy before undergoing active surveillance to try to see, is there in fact intraductal cancer somewhere, which again would then typically not be an indication for active surveillance. Briefly, I'm going to just mention a new grading system that came up with at the Cleveland Clinic system. You may hear of it. You may look into it. So just to be familiar with it more than anything else. What this new system comes up with is just general categories. So it's not numbers. You're not going to see Gleason, grades 1, 2, 3, 5, etc. They have basically unfavorable histology, favorable histology, and something in between. Unfavorable histology, some of them we've already talked about, like any Gleason pattern 5, that's the worst grade. That makes sense. Large cribriform glands, we've talked about, that's bad. Intraductal cancer, again, we've talked about that. I haven't talked about, there's an unusual type of prostate cancer called ductal adenocarcinoma. It's confusing because it is different than intraductal cancer, but that's uniformly agreed to being an aggressive cancer. So again, not a problem, including that as unfavorable histology. The next two are a little bit more controversial. Complex anastomose and cord-like growth is something that I kind of have a hard time knowing exactly what the authors of this grading system mean. So I question how reproducible that would be. Also, our studies showed that if prostate cancer causes the normal stroma in the prostate to be very reactive to it, we call that stromogenic cancer, those are aggressive features as well. I also have questions, though, because most pathologists are not familiar with quantifying or saying how cancers react with a stroma and given a grade 3 versus, let's say, 1 or 2, how reproducible that would be. So I have some concerns about this new grading system, how it would work in practice, even though I think there are some good points to it. I'm not sure it adds that much to doing our current system and then noting that there's large cribriform glands or intraductal cancer or a lot of stromal reaction or ductal adenocarcinoma. So, currently I would note all those on a current report. So that would be in a current report regardless. But nonetheless, that's just something to be familiar with. And then what they call kind of in-between histology, between favorable and unfavorable, is small cribriform glands, something that's kind of another type of small cribriform glands, which is glomeruloid, and poorly formed glands. So basically, other types of Gleason pattern 4 they call in between, and then Gleason 6 would be favorable histology. The new grading system has only been shown to be predictive of prognosis after radical prostatectomy. So it needs more studies. You have to study it on biopsy. You have to study it with radiation therapy and other types of treatment. There's been no studies outside of the Cleveland Clinic to say how do other pathologists do with this grading system, how reproducible it is. So currently, other than I think in the Cleveland Clinic, maybe one other place, this is not a grading system that's out in practice. But again, it may be something that catches on. You may hear about it. So again, just a little bit to be familiar with it. I'm going to end with a little bit about artificial intelligence and prostate biopsies. So what is the good points, the promises of AI? It can avoid potentially undiagnosing small cancers. And that is because the AI is set for maximum sensitivity. Find anything that's abnormal on that biopsy. So if the AI looks at a biopsy and says, I don't see anything abnormal, that can reassure pathologists that a case is benign. I think that's good. Again, another promise of AI potentially is better standardization of grading. Studies have shown it's equivalent to pathologists, but it has greater reproducibility. What it has not been shown is whether it's more accurate grading than, for example, experts. Another promise is now AI is starting to shift from diagnosing prostate cancer and grading to more prognosis. And I think that's probably the wave of the future for AI, because AI can capture things that the human eye can't. So it probably shouldn't just try to reproduce what a human does in grading and diagnosing, but look for things that we can't do. Look for subtle changes in the stroma, the nuclear features, spatial orientation. That, again, just too complex for the human brain and eye to do. And so I think in the future, AI will complement grading and clinical risk systems by adding these independent prognostic values, capture novel, potentially patient-specific morphological signals. Limitations, again, AI is trained, that's what it's supposed to do, to detect anything abnormal. So it's not going to be that specific. It's going to overcall a lot of things as cancer because it doesn't want to miss any cancers. The problem with AI is that there's also a lot of mimickers of prostate cancer that AI will probably call cancer. And some of these variants of prostate cancer are too unusual, and if they haven't been trained with AI, then AI is not going to recognize them. Also, it's important to recognize that every lab has a slightly different staining. When you cut them, there's all these artifacts, and the question is, can AI account for all this variability? There's a lot of costs to do AI equipment, and so a lot of labs do not have the ability to even do it if they wanted to. Also, all these AI software basically says, this is a test, you use it, but we're not liable for it. So you cannot sue the AI programmers if there's a diagnostic error. There's literally no responsibility. So ultimately, the reporting pathologist must be responsible for either accepting or rejecting the diagnosis proposed by AI. My concern is that some pathologists are going to rely so much on the AI, thinking, "Oh, this is AI; it's 100% accurate. It's amazing," and potentially there will be diagnostic error. So in summary, I've shown you, hopefully, that there's a wealth of information that can be obtained from the biopsy report. The report is only as good as accuracy of the pathologist. Critical to have high-quality pathologists to get the best diagnostic and prognostic information for you as patients. Thank you.
All right, I told you off camera before we started the Q&A, I've never seen you move so quickly through a slide set. So I'm going to use the chemical scientific name for it. I'm convinced you had a lot of 1,3,7-trimethylxanthine, which is also known as caffeine this morning. Am I correct?
Actually, I have internal caffeine. I don't drink that much coffee. I'm just normally kind of warp speed.
That's fabulous. All right. So what I want to tell the audience is that Dr. Epstein is everywhere. We all agree he's the Michael Jordan of our time, or LeBron James. We can all agree on that. But what we need to do is he's in a lot of different places. I want to try to break down my Q&A into 7 parts. And we're calling this Q&A a Master Pathology Review class. So notice how I gave you big wording like Doc J. Epstein. Remember Dr. J? You're like the other Dr. J. And then I put my name in small letters because I just wanted to show some humility there when I'm with the King of Pathology, or the Emperor of Pathology, or whatever you want to call it. All right, you ready for my first question?
Sure.
Let's see if I can throw you off in the first question. I did this for Dr. Kwan at the Mayo Clinic. He got it right, and I predicted he was going to get it wrong. Who played in the national championship college basketball game a few weeks ago? And what 2 teams? And do you know who won the national title in basketball this year, 2026?
1 second. Jeepers.
And remember, take your time. This is like Jeopardy, that song. I ask these questions because I'm convinced that some of the top people in cancer don't have time to watch TV or basketball, so they generally get these questions wrong. So it's always a deferential question.
I would say UConn versus, and I know UConn lost.
Yes, they definitely lost to the greatest team ever.
Right. And
that's your hint. The greatest college team ever assembled.
Michigan.
Exactly. All right, you win. I'm going to send you a hat along with the other gift I'm going to give you at the end. Wear it proudly, my friend. Wear it proudly. Okay, excellent. All right, what I'm going to do is something differently. Over the past 15 years, I think, as I've seen you and interviewed you, we always mention how to reach you at the end. I find that doesn't work. For people have the most attention span at the beginning of the Q&A. So I'll go through this, and you can interrupt me at any time, or I'll ask you a question. And I know you didn't ask for this, but I think this is part of the value of the Q&A. You are at Advanced Uropathology of New York. There is the website. Monday through Friday. You can be reached. It's easy just to go to advanceduropathology.com if you're looking to do a second opinion, right? I think all that information is correct.
Absolutely.
Okay. However, when you go on there, there's a form. And a lot of patients, as you know, want their own second opinion, but didn't necessarily hear from the doctor that the doctor wants a second opinion. So this form is a little bit, I mean, I don't say it's confusing. I just think for a patient who gets on there, what's the bottom line information if they want to be the impetus? They want to help drive the second opinion that gets to you. Can you just give us some basics of how they can do that? They're supposed to contact their doctor and the doctor's supposed to fill this out, this form out, or what are your thoughts there?
Yeah, so what I tell patients, the easiest thing is to email me. It's J Epstein, Jepstein,
Yeah.
at IMPPLLC.com. It's on the website also.
Okay.
If they email me, that's my work email, not my private email. If they
Yes.
email me at jepstein at IMPPLLC.com, I reply back with the forms, but also an instruction how to fill out the forms.
Oh, it is there on the website. Okay. So you want them to email you, and I'm going to talk to the team, and they can hear me loudly that when this goes live, we want them to throw that email on there, and you are going to regret it because you're going to get tons of emails now, and you're going to say, why did I give out that email so easily?
It's okay. What I find out is ultimately, I want to make it easy for patients, number one.
Yes.
Number two, I don't want things to fall through the cracks. And I found that at least if they have my contact information with my email, if there's a problem, if something doesn't work on their end, they can reach back to me and I can try to straighten it out.
Okay. Now I'm going to run through the rest of this kind of topic, and bear with me. Does someone ever send you, I mean, let's just set it up this way. Have you ever even estimated the number of pathology slides or the number of cases you've gone through in the terms of the thousands? Have you ever even tried to ballpark it? It's got to be the most in the world, but are we talking in your career thus far? Because you still have a long way to go. That was a compliment. And then we talking over 15,000, 20,000, 10,000?
Hundred thousands.
Hundreds of thousands.
Yeah.
So this is why we call them the LeBron James or the women's hockey team or USA women's hockey team, whatnot, hundreds of thousands. You ever get a biopsy or samples from someone that had it done years ago? So let's say 5-6 years ago. I understand it's most often used in the immediate time. Okay, you got a biopsy or you got surgical pathology, you get it sent as a second opinion. But do you ever get someone that's 3 or 4 years ago got a biopsy, maybe active surveillance 3 or 4 years ago, and they just want to know whether that original biopsy from many years ago is what it is?
Yep, absolutely. As you said, it's not as frequent, but
Yeah.
those slides are there. They never go anywhere, so it's possible to do it.
One of the greatest fears in the second opinion process or first opinion process, because when I say second opinion, let's say you're the first opinion. Sometimes the first opinion is good enough, right? I mean, sometimes if you were to get the first opinion, you wouldn't be called a second opinion, but sometimes the first opinion is good enough when you go to a world-renowned expert. Anyway, one of the biggest fears I see on the internet today is someone's worried that their samples going to you is not actually them, that it might have been misclassified. I don't know how bad a problem this really is, but it made me think of this in our introductory series of questions. Do you recommend that patients ask or pay for what's called DNA-based verification of their slides? So the slides they're seeing or you're seeing are clearly that person, that it's been matched up, say, with a buccal swab. So, I've seen some of your reports. You have some DNA-based verification that's done, or some people have done. Is that something you recommend, or you're not sure yet, to match the patient up with their actual slides? What are your thoughts on that?
It happens extremely rarely that there's a swap in the specimen. So it's kind of a mixed bag when you're deciding. Number one, it's rare.
Yeah.
extremely rare. But number one, when it does happen, it's obviously can be devastating.
Yeah.
So if it were me getting a biopsy, I'd probably do it, but it's
Interesting.
hard to recommend for everybody to do it because it is so rare.
I wonder if that's covered by insurance, though, if someone wants to get it done.
That I don't know.
It depends. Okay, now we go further on. See, this is how we're going to go further into here's my thought, and then I want you to comment on why, before I talk to you, I actually feel this way after 35 years. Moyad says second opinions of pathology should be the rule now often and not the exception. Okay? This is my conclusion for the audience. I think it should be the rule, not the exception. And I'm going to tell you why, and tell me if I'm wrong or right in any of these. Why I think the second opinion is so important. Can we admit that when you look at Gleason grade, this is reason number one. When you look at Gleason grading or any of these variants you've been talking about in your lecture, we're still talking about this is based on not a computer. It's based on morphology. In other words, AKA, it's based on subjectivity. It's based on the experience of the person reading the slides. So these critical markers and variants that you're talking about is still based on humans. And you're giving so much power to a first opinion that it's almost scary. So do you want to comment on that number one reason why I feel so strongly about second opinions?
Yeah. Nope, I totally agree. But the main thing is also you don't know who's reading your slides. Even if it's like a top act, you might think, oh, it's going to Mayo Clinic, Cleveland Clinic, Mass General. I'm just naming, Hopkins, whatever.
Yeah.
But in those places, there are some very good pathologists, and there are some that are not as experts or not as good. Somebody could have been just out of their training. You have no idea.
You have no idea. I've told some friends recently to get their pathology report, see who the pathologist was, and if the pathologist says, I'm the master of all trades, I'm a general pathologist, I look at all types, I tell them to be a little bit more nervous about that. If you see a uropathologist, someone with experience, maybe less nervous, but that is a really good point. Now, we also know Gleason and everything you talked about is a primary predictor of current and future treatments. Now, second opinions, yes or no, insurance often covers it.
I would say almost all the time it does.
Almost all the time, making my point 3 stronger than ever. Turnaround time on a second opinion, let's just say in your case, this is not something you wait for 4 months on. It's usually fast. How fast is the turnaround time on average, for example, when you do it?
With me, once I get the slide, 24 to 48 hours, typically less than 24 hours. The rate limiting factor is the outside institution getting the slides to me. Sometimes they're quick when you ask them to do it. Sometimes it's like pulling teeth.
And for those people who are pulling teeth and it's taking time, don't you agree? I'm trying to help you be PC here. Don't you agree that it's okay for the patient to nudge that recalcitrant institution a little bit and say, can you get my slides there, please, by FedEx? I think it's okay for patients to call and say, what's the status of my slides getting over to Epstein or somebody else? Don't you agree that they should be involved?
100%. Those slides belong to you. It's your on the line. Your treatment diagnosis is on the line.
Yes.
Some places will try to, have the kind of almost egotistical opinion. Well, why are you asking for a second opinion from our place? We're like such and such place. We don't, we're good. And the answer is that's your choice. You want a second opinion. You ask for it, and you might have to bug them or have your urologist bug them.
That's right. Okay, I'm 4 for 4 with you. The fifth reason I think everybody should at least consider this. And keep in mind, I have no association with Dr. Epstein. I'm not involved with him. Any of these companies in pathology. This is the reason, the conclusion I came to after 35 years. I have found there's a POM with a second opinion or a really good first opinion. POM meaning peace of mind now and later. You know that you did it. And part of that peace of mind is something people don't realize. When it comes to you, and I know some other pathologists that do this too, if patients want to talk to you by phone, and understand their results, and you kind of give your thought about the results, why they are what they are, and some of your thoughts, you do that, right? You get on the phone and you talk to patients also. You're a pathologist that actually interacts with the patient. Is that right?
Absolutely. If any patient wants to, I have a long commute on the way home, so that's like the perfect time. I don't rush them. We can have a nice talk about it.
And how much more does that cost for the phone call?
Nothing. That's just, I do it as part of my consult.
How'd you like that softball question? That's my fifth reason. I give 5 strong reasons, peace of mind, and you actually you can have a discussion with the pathologist. There was another friend of mine the other day who was another pathologist in the Midwest. I said, call him. Maybe he'll talk to you, walk you through it. He called him and walked him through it. He felt so much better. So for those reasons alone, people should always consider a really good first opinion, Dr. Epstein or another world-renowned expert. All right, here's a question I've never seen anyone ask you in all the conferences I've ever attended, okay? And maybe they have, but it's better if you tell the audience what your thought is on this. What type of second opinions do prostate pathologists do, including you? See, everyone just talks about prostate biopsies, right? Or surgical pathology after a radical prostatectomy. But what about if you have lymph node dissection? What about a prostate biopsy after radiation? We're going to talk more about the biopsies and things after treatment, but can you just walk us through what kind of second opinions you do on what kinds of tissues? Is it everything head to toe or that might have cancer or prostate cancer? How do you even tell somebody the range of biopsies that you look at?
Yeah, so number one, I was a general surgical pathologist also for decades, so I have that experience as well. So I will look at biopsies, radicals, TURs, open prostatectomies, lymph nodes, bone specimens, lungs, if there's, and not just prostate, obviously I do, even though we're talking prostate today, but bladder, kidney, testis, penis, scrotum, etc.
Yeah. So even after BPH procedures like transurethral resection, you mentioned TURs, you'll take a look at those and see if some of that tissue has cancer in it.
Yeah, absolutely. Yep.
See, I think sometimes the broad brush is painted that, hey, Dr. Epstein just looks at these biopsies that come from the prostate, not realizing that all around the world, people take biopsies of tissue all over the place looking for prostate cancer. Some you can agree with or not, but you look at all those.
Yep, that's a good point. Yep. First time I asked that question. You're right.
Holy mackerel, made my day. See, maybe I'll send you 2 Michigan hats. So that'll be good. Your family can share on it. What do you think of this? Should a patient keep a copy of their final pathology report their entire life? Do you think this should be like taxes taxes, they say 7 years, but records for 7 years. But is this one of those things in your medical record that's so critical you should just put it somewhere in a filing cabinet the rest of your life?
I would. Yeah, absolutely. Yeah. Or have access to it online or however, but yeah, you should.
I've never heard you answer that. All right, now I'm going to give you some quotations as we finish part 1, and then we go into part 2. These are the largest parts, and then the rest of the parts are easy. But then again, we've only been going 20, 25 minutes. We're going through these much faster. Here are some quotations, and if they weren't assigned to you, please let me know. That always stuck in my head, and I made posters of them. First one is, you said, correct grade is critical and the foundation for the optimal treatment of prostate cancer, right? You said that.
Absolutely.
Okay. Then you said,
but then you could have the best surgeon in the world, the best radiation oncologist, but if you have the wrong diagnosis, the wrong grade, you'll get the wrong treatment.
Touche. This is what you also said. 25% of Gleason 6 on biopsy are Gleason 7 or higher due to sampling error. Is that still true?
It might be 20%, 18%. It's still ballpark significant.
Okay. So all of this was making me think, why don't I just ask Dr. Epstein the bottom line question? And I'm not asking you to be specific, and I'm not asking for references. I'm asking for ballpark because it always almost makes me fall off my chair. In your opinion, what percentage of pathology second opinions, let's just say with you, or just ballpark, are upgraded, downgraded, and no change. So when you get a biopsy or you get some kind of tissue, what percentage of those second opinions do you upgrade? Do you downgrade? Gleason is less, or do you not even change at all? Do you ever think about that?
Yeah, I would say overall about 30% of the time I would change the grade, and it's almost equally upgrade and downgrade, 15% each, and then maybe 70% no change.
Wow. Okay. So almost 1/3 of the time.
Right.
But equal in terms of downgrade and upgrade.
Yeah, it depends a lot on the pathologist. Like I know there are certain pathologists that I consistently get specimens from, like the clinicians ask me to look, that they consistently, downgrade it. They'll call everything a 6 and it might be everything is 7 or vice versa.
Yeah. Have you ever, I'm sure the answer's got to be yes. Have you ever received a sample that said cancer and actually when you looked at it, you didn't see cancer?
That happens uncommonly, but it happens enough that yes. And that's one of the reasons why, again, if I were ever diagnosed with cancer out there, I'd want a second opinion. Just number one, make sure I have cancer.
So it happens enough that someone's told they have cancer and then that must be the oddest moment of your career. I mean, it must be the most joyful, but you're saying, then you send, I can't even imagine that note that comes back that goes, I don't see cancer here. And does that happen every year? Once a year?
I would say once a year at least. Absolutely. Yep.
Holy mackerel. What about vice versa, as we say? What about you see a sample that came into you? Because I've always argued that when someone sends their samples to you, they need to send all of their samples, not just the ones with cancer. They need to send the ones that don't have cancer because they're having the guru look completely across the board. Why not just send all the samples? You might not like that I'm saying that, but I think if I'm going to have you do my second opinion, I want you to see the samples that say benign tissue, not just the ones that say cancer, right? Okay, let's think vice versa. Have you ever seen a benign? This came in as a sample that said no cancer. And then when you looked at it, you said, well, wait a second, that's actually cancer.
What I see not infrequently is a specimen that's sent in with cancer. That's why they're asking me to look at it.
Yes.
And some of the benign parts have cancer that was missed. What that leads me to believe is there are plenty of benign specimens out there that cancers were missed. Those don't get sent to me because if somebody gets a benign biopsy, usually they just don't send those to me.
Yes, which goes back to the Moyad point of send everything. And you're saying that maybe it's once in a blue moon, but you have seen situations where you've looked at something that's supposed to be benign and actually it's cancerous.
Right.
Yes?
Yep, no question.
Man, Dr. Epstein, you are making me look incredible today, not just you. All right. Another paper, I'm not even going to go through it, just another paper I'm inundated with by saying how good MRI is at picking up aggressive pathology. So after the MRI says this is PIRADS 5 or whatnot, it seems to be doing a good job of picking up aggressive pathology after you look at it in its biopsy. Do you have any comment on that? I mean, that makes me feel good, but we're getting a ton of these papers lately.
Yeah. So I see every day a large number of MRI guided biopsies where they'll have their routine and then they'll say target area. 80% of the time, 85% of the time, the target area has the worst cancer, but then 15 to 20% of the time, the target might miss the cancer totally, or it misses the worst cancer. So it's not foolproof by any stretch, and that's why you do the systematic biopsies in addition to target. MRI has been a game changer, no question, but I've heard some people say, why don't we just do the MRI guided biopsies only, just do the targeted areas.
Exactly.
And 15, 20%, you're going to miss the worst cancer or cancer in general.
15 to 20% is not insignificant. Interesting. How did you feel about part 1 Q&A? You ready to go to part 2?
Yeah, go for it.
Okay, this is the largest part and the other parts are much smaller. So bear with me as I decide how much we're actually going to go through. I call part 2 Gleason scores amount of 4 and aggressive variance with Dr. Epstein, and then my name is much smaller. Okay, so we're going to go through part 2 now. Can a Gleason 6 turn into a 7? vice versa? This is just a basic question. Can a Gleason 6 itself change or turn into something more aggressive? Or if done correctly, does the Gleason stay the same throughout your whole life?
So there's no way for us to 100% know. What I would say is the vast majority of cases, the Gleason 6 stays the same. We do see some cases where somebody's had a Gleason 6, 6, 6, and then all of a sudden there's an 8, like 5 years later, 8 years later. We have no idea whether that 6 turned into an 8 or that 8 was there, or it's a new cancer, a new 8. So we can't be sure, but what I think is reassuring for patients, the vast majority of the time, that 6 stays a 6.
Would you say that's the case also on a relapse and recurrence? That let's say a 6 or a 7, and then it comes back after radiation or after primary therapy? Is it often that the morphology is similar upon recurrence, or you can't say that as a generality? It could be very different Gleason-wise.
Yeah, it's hard to say. A lot of times occurrences are higher grade, but that could also just be sampling as well.
Interesting. See, I wish I would have asked you this years ago. Here's a quote that you said that I wrote down. You said Gleason 7's not homogeneous. 4 + 3 = 7 has a much worse prognosis than 3 + 4 = 7. Do you remember saying that?
Yep, absolutely.
Okay. So this brings me now to the part of the Q&A that I'm going to try not to get stuck in the mud, because people get stuck in the mud here. This gets a little sticky. I've been watching a lot of lectures from pathologists talking about the amount of pattern 4 in the biopsy, and you've talked about this. The amount of pattern 4 is one of the greatest predictors of recurrence and distant metastatic disease, right? The amount.
Right.
And you agree with that. You've mentioned it. And they've even in studies put the amount or the volume of Gleason pattern 4 up against risk scores and other algorithms and things, and it still is one of the strongest predictors. Okay, so the amount, knowing the amount is a game changer, but can you again summarize, how do you report the amount? Do you report the total amount of Gleason 4? Do you say 20%, 30%, or are we supposed to assume that the amount is reflective in the primary and secondary grade? So if the 4 comes first, there's obviously more than 50% there. How do we put our hands around this amount of 4 and why I should be so consumed by it?
Right. So yeah, so as I kind of went through the talk, you get a rough idea of the amount with the grades. 4 + 3, you know it's over 50%. 4, 3 + 4, it's under 50%. But that's it. That's all you know. You don't know with the 3 + 4 if it's 1% or almost 50. With the 4 + 3, you don't know if it's 55% pattern 4 or 90% pattern 4.
Exactly.
And so that's why every time I say 3 + 4, I would put in parentheses, 5 + 5% pattern 4. Or if it's a 4 + 3, I'll say parentheses 90% pattern 4, which is pretty much, a smart patient told me, that means I'm close to a 4 + 4. And I say, yep, you're right. So now I do it for every part. I don't at the end of the case try to do some grand summary, because one of the things I don't know as a pathologist, there could be 2 different lesions. I don't have the MRI with me. So I don't know. I don't want to be adding 2 different lesions together potentially incorrectly. So I just give each part what that is, percent pattern 4.
When you say you don't have the MRI with you, but do they send you the MRI report also at times?
No, typically not.
Why not?
Don't know.
Don't know as in I wish they would, or don't know it doesn't really matter. I am who I am.
It probably wouldn't make a significant difference how I'm reporting it at this point.
Wow. Okay. Then why do I see people talk about the amount of 4? You can still be an active surveillance candidate if it's less than 5%. Then I saw another paper that said less than 10%. And now I'm seeing some papers that say, oh no, 20% is the cutoff. If it's less than 4, is 20% or less your active surveillance. How am I supposed to even put my head around it? Is it less than 5, 10, 20? What is this?
And the reason is, which is what I said, we don't have studies. So the problem is you need 10 years follow-up of men on active surveillance, at least, with all these percent pattern 4s. And we've only started putting in percent pattern 4 in the last 3 or 4 years. So we don't have data. So I think people are comfortable with the 5 to 10%. Less than that's pretty good.
Okay.
20% is like, maybe it's good, but we have no data. But, some people say, well, let's try 20, but it's guesswork at this point. The 5 to 10% is low, so you can kind of feel a little bit better with that. But again,
yes. So single digits is more subjective. It feels good. Once you go into double digits, it might be worse, but we don't know.
We don't know. Yep.
Wow, man, you put the can in candid. That's excellent. I appreciate that. Then I've also been reading there are different types of 4. Now we're going to start moving on into the variants. This is the toughest part for me, but as someone who wanted to go into pathology and then I suddenly didn't, and I should have done it. I loved pathology so much, but this is what I need you to define. There's different types of Gleason pattern 4, and you mentioned 3 of them, but 4 come up often in the literature. So can you tell me? There's cribriform, right? That's the one that you talked about. That's the most aggressive. That's the worst of the types that can come up. There's poorly formed glands, fused glands, and glomeruloid, which is like kidney-like, I guess. That might be the best. So am I just looking for this one really as just or what? Do you have anything to say about it?
So what I would say is having no 4 is better than any 4. But if you have 4, the poorly formed, fused, and glomeruloid are probably the least aggressive of the pattern 4s. And there are some studies suggesting that if you have only those types, in some cases, it behaves like a 6, like as if you didn't have any 4. So I think those studies are remain to be done with long-term follow-up, et cetera. That's one of that whole, what I alluded to at the end with that unfavorable, favorable grading system.
Yes.
So in that system, the poorly formed, fused, and glomerular would kind of be intermediate risk in a sense, whereas cribriform would be unfavorable risk. But then again, there's different types of cribriform. There's kind of worse cribriform and not as bad cribriform too. So it is confusing. Cribriform is definitely something that's bad. Large cribriform, definitively bad. No question about it.
So these 3, I don't have to be as nervous about. This one is the one that's far more concerning in terms of its aggressive component. And then we'll talk a little bit more about that in a second. That's right?
Correct.
These three just sound...
Also, if I had, let's say, a 3 + 4 = 7, no cribriform, 5 to 10%, 10%, Gleason pattern 4, I would tell a patient, you're still a good candidate for active surveillance. You still have to be watched carefully, but I wouldn't tell them, not to do active surveillance.
So if they had 5 or 10% and they had glomeruloid or fused or poorly formed, you would feel more comfortable with that on active surveillance.
Correct. Yep.
Cribriform, such an interesting word. I brought it up first. I think 6-7 years ago when we did an interview, I had to get my hands around it. It was kind of a newer term, but in Latin, cribrum, it actually means, and you're talking about a lot, means sieve or hole-like. So I just thought, I don't know, I'm sure you were a nerd in school like I was. I thought sieve, here, this is my wife's sieve. She let me borrow it. It's a very large sieve. Why was cribriform named sieve-like? Why does this remind me of a kitchen utensil?
Right. So if you were to zoom in on that sieve, it's basically something with little holes in it, little punched out holes in it.
Yes.
And so that's what it ends up being. I like the analogy of Swiss cheese in a sense, because that's what it kind of looks like. It's a solid sheet with like somebody took little things and punched out little holes in it. Here, they're tiny little holes. It doesn't quite look like that, but yeah.
I'm just trying to show you the dedication that I have, toward being a moderator.
Or colander, think of it like that, exactly.
Yeah, I mean, truthfully, sieve, Swiss cheese, I could have brought Swiss cheese, but then my wife would be upset if I use that. But the reality is that, I don't know if you remember, sieve is the name we use for hockey goalies when you score a lot of points on them. Remember that? They would throw sieves on the ice. Okay, so sieve. So is it fair to say if you have cribriform exists, and so you have Gleason pattern 4, let me ask you this. Can you have cribriform on a Gleason 3, a pattern 3, or does this only exist on 4 and above?
Only on 4 and above.
Okay, so if some pathologist said you are a GG1, you're a 3+3, and you have cribriform, something's not right there.
100% wrong. Yep.
Interesting. So if you have cribriform, and let's go through this again. You're not you're not necessarily a good candidate for active surveillance if you have large cribriform versus small, or is that just, I'm simplifying that too much?
Yeah. So large cribriform, 100%, I would recommend not active surveillance. Small cribriform, I would say we're not sure.
Well, but who decides large versus small? Because you showed the Cleveland Clinic new guidelines and they say it's 0.25 greater than 0.25 millimeters or something. I'm like, well, who decided that cutoff? Did you decide that cutoff of large versus small?
So there have been several studies with different definitions, and several studies have used the 0.25 millimeter definition to show its prognostic. So that is the definition I use as well. It is objective. And so there are other criteria there that are not objective. So I think it's as good as criteria as we have.
Okay. Wow, that's really interesting. All right, we're moving through the largest part. All right. Now here comes the other dangerous word. What about if you have intraductal carcinoma of the prostate, IDCP? Does that eliminates you as an active surveillance candidate? Is that right?
100%. Yep.
Where would I see intraductal carcinoma of the prostate? I wouldn't see that on I wouldn't see that on 3+3. I'm only seeing that in 4 and above, right? When a 4 is involved, or not.
Vast majority of times, but you can see a Gleason 6 with the IDC uncommonly. But the same thing with grading subjectivity. I just had a case last week where somebody had Gleason 6 and it was called intraductal cancer with the Gleason 6. The clinician had the biopsy sent to me and it wasn't intraductal cancer. It was just high-grade pain, which is nothing. And so, all of a sudden that patient went from an aggressive report, no active surveillance, to you're a good candidate for active surveillance.
That's why you proved the Moyad 5 that everybody should consider a second reading or get a really good first reading, because I've been reading in pathology lately that a number of pathologists, I'm not saying what the number is or the percentage, they're confusing high-grade PIN with intraductal carcinoma of the prostate. Is that right?
Yeah, so just like there's subjectivity with grading, there's a lot of subjectivity with diagnosing intraductal cancer, either overgrading, overcalling it, or undercalling.
Here we go. We're about to get really into the mud of intraductal carcinoma of the prostate. I don't think that gets enough love or attention. So if you have intraductal carcinoma of the prostate, because you can have intraductal carcinoma and or cribriform, correct?
Correct.
People are always mashing them together, and that's incorrect. These can be separate. These can be separate entities, right?
Absolutely.
Okay. If I have intraductal carcinoma of the prostate, which should be its own lecture, do you think I should get a BRC or germline genetic test?
I think it's reasonable. We do that reflexively. Yes.
You do?
Yes. I would say we make the recommendation to the clinician that they should consider it. Correct.
And is it true as the grade gets higher? I've seen some of these studies now and some of the retrospective looks. As the grade gets higher, as the Gleason becomes more aggressive, as you go from GG2 to 3 to 4, the chances of being diagnosed with intraductal moves up.
Oh, absolutely.
It increases. Okay.
Yep.
Okay. You said a BRCA2 on an intraductal? Oh man, am I going to be using that? Now it gets even more interesting with intraductal carcinoma of the prostate. It's not the same as ductal. If someone says you have ductal adenocarcinoma, it's not the same, right?
Very confusing terminology, but not the same. Correct.
Completely confusing. Here were the points I've taken from your lecture and other lectures. You just said that it's often associated with high-grade disease, right? It's an independent prognostic factor. Is that true?
Correct.
You said that you should probably BRCA test or do a germline test. They're not an active surveillance candidate, but here's the thing that doesn't get enough attention. These have been less responsive on certain types of treatment too, right?
Correct.
There is a concern about intraductal carcinoma being less responsive. Tell me where I'm going too far with this. There's been some, I know there's a mixed bag. There's been some to suggest it's less responsive to ADT, to chemo, and to certain types of radiation. And you said that in your lecture. You said that some of the radiation oncologists want to step it up, maybe provide a boost to the area if they see, if you mentioned intraductal carcinoma of the prostate. What part of that did I not get right? Is that right?
I think you're 100% right. I mean, it is less responsive to our hormone therapy. I think it's relatively less responsive to radiation, and that's why they, again, boosting up the doses in those patients. But then there have been some studies saying that patients do better with radiation in those boost up doses than surgery. So it's hard to say. But I think what you can say is because it's more aggressive, it may be treated differently. Again, there's a lot of variability amongst radiation oncologists to how they, individualize therapy. But my whole philosophy is always give them the most information possible so that they can make, the best decision. So that's why I always want to separate out whether there's intraductal versus just cribriform pattern 4.
And the new guidelines say the intraductal has to be mentioned in cancer grading, right? It has to be. It should be.
But it's not so easy sometimes to tell unless you do sometimes special stains. And some places just don't do that.
I'm seeing very large case studies. This one just came out in European Urology from some friends of mine where they looked and they saw intraductal and they were clearly much higher chance of getting recurrence or having metastatic disease. So they were suggesting that you need to hit them from multiple pathways. You got to do multiple treatments when you're dealing with intraductal. This is really a topic to me that's kind of taking off that I didn't think much about. Can you explain this one more time? I'm so glad I made a sign of it. Intraductal carcinoma of the prostate. You're saying AIP is another marker suspicious for IDC for intraductal carcinoma of the prostate. Can you just once more repeat this? This is making my head spin.
Right. So the term AIP covers a wide range of lesions. Some of them not that close to intraductal, but worse than PIN, and some that are basically intraductal, but just don't quite fit the criteria exactly. It's that latter group where you want to get a repeat biopsy because there probably is full-blown intraductal somewhere else. Yeah. But there are other AIPs that are not that worrisome. And so that's kind of why if you're diagnosed with AIP, you want to get some indication from the pathologist where on that spectrum. So what I do, if it's AIP suspicious for intraductal, I will put that in there, saying AIP suspicious for intraductal carcinoma.
Okay, great. Last one in this, and then we move to the other 4 parts fairly rapidly. We're 45 minutes in. I feel like we're doing well. Feel free to take a sip anytime. I know these are some curveballs you've never been thrown, but that makes it fun. What did Gleason pattern 5? You said 50%. Was this a different lecture? 50% of the time outside pathologists did not call it, first of all, and no gland formation. We know what a 5 is based on your setup, but can you repeat that again? That people don't like a Gleason pattern 5. People don't like to call it a 5. Why would that be? Because you're just making too strong a statement and having too much confidence in your reading. Can you explain that?
Yeah, I in my opinion, I've never asked pathologists, but there is a fact that in my experience that pathologists undercall pattern 5 significantly. Yeah. And the only reason I can come up with is they're just hesitant to give the patient that worst diagnosis possible. They figure to just back off a little bit.
Okay, but if I give it a 9, you're saying 9 and 10 are now
9 and 10 the same. Yep.
Same grouping.
9 and 10 are the same.
Same grouping.
Yep.
All right, you ready for part 3? Here's another term I've not seen in pathology in lectures. I haven't, and I'm taking it on as a pseudo pathology guy. I'm seeing incredible importance on this, but I'm not seeing the importance out there. Part 3 is called LVI. I call it another aggressive but unsung pathology feature, LVI in our master class. Let's talk about LVI because they are on pathology reports. It is called Lymphovascular Invasion on biopsy, okay? Maybe you want to kind of just explain what Lymphovascular Invasion on biopsy is because you see them on pathology reports, and let's just say you have that. The European urologists are now saying you're not a candidate for active surveillance, okay? So that's a 2-part question. What is lymphovascular invasion, and why are the Europeans now saying, urologists saying in guidelines, you're not a good active surveillance candidate? Why aren't we hearing more about LVI?
So we have little blood vessels throughout our body, and some of those are lymphatic, some of those are small little capillaries. One of the ways that cancer spreads, let's say going to the bone, going to the lung, liver, brain, etc., is when the tumor breaks into those little vascular spaces, and then they can go anywhere in the body, just follow the blood and set up shop somewhere else. which we call metastatic disease. Prostate cancer, when we see lymphovascular invasion, it's almost always with high-grade disease, like Gleason 8, 9, 10s.
Okay.
You never see it with 6. I would say almost never see it with a 7, even a 4+3. So it's important to note it when you see it, but typically you're already in that setting have bad disease with other parameters like grade. So yes, it would rule out active surveillance, but you're already ruling out active surveillance because you have high-grade disease. So you're not going to see a 6 with LVI, for example.
Okay. But they're mentioned on pathology reports. They're not skipped. So I think people should know what it is.
Yep, no, absolutely. Yep.
And so I call them friends. I got a million friends out there. One of the surgeons who's done the most radicals in the history of prostate cancer is Vip Patel. He's in Florida, and he's got a good database. And he just published a paper with over 10,000 men, 10,000 radicals, and they found that the combination of LVI and PNI, perineural invasion, which we could talk about in a minute. Anyway, it was an independent predictor of biochemical recurrence following complete resection. And I just thought, that's a huge database. So am I making too much of this LVI, or is this going to be a big deal in the future?
Again, in radical, different than biopsies. So it's hard to say. But again, what I'd like to look at that paper, again, those cases of LVI probably were, again, relatively higher grade cancer. Yeah.
But then they threw their magical statistics in there and found out that it was an independent predictor. So, it's interesting.
So the only thing I would say about independent predictor, you have to be careful because it could be, let's say grade gives you 95% prediction, LVI gives you 96 prediction, so the grade falls away, but ultimately how much more did the LVI give versus grade? It may not be a lot, for example.
Yeah.
So you have to get into the weeds to find out.
That's a good point. It's like relative reduction in epidemiology versus absolute risk reduction, right? Sometimes the reduction or the impact truly clinically could be clinically trivial, not clinically significant. Right. Good point. We're already into part 4. That was part 3. Part 4 is you write about this. And I love when you talk about it, but can we talk about it? I only have a couple of things to say. I call it TRE, treatment-related effects in Gleason. That's our part 4, treatment-related effects. And here's what I've learned from you through the years, and tell me where we are. That depending on the treatment that you got, if there's going to be another biopsy or another reading by you, whether it's ADT or the second generation anti-androgens, chemo, focals, radiation therapy, in some cases, the pathologist is saying, hey, you don't grade those. So what does that mean? You don't grade them. You just say that you believe there's cancer there or not. And then they say in some cases like focal, you can grade them. And can you put your head around this? Because this kind of makes my head spin.
So some types of therapy, the cryo and the HIFU, basically just cause the cancer to die. It's basically mechanical. It's not really doing anything to the cancer in terms of altering the cancer. It's just hitting it with a hammer and killing it. Okay. And so if you see cancer in somebody with cryo or HIFU, it just means a hammer hasn't killed those cancers. But the cancer that's still there looks just like regular old cancer. You can grade those. Radiation and hormone therapy, after radiation and hormone therapy, some cancers don't respond that well to hormone or radiation, and the cancer could look just like regular cancer, meaning if I didn't have that history of radiation or hormone, I would never have guessed it. Those cancers I do grade, even if there's a history of hormone or radiation. If I see cancer, but under the microscope, it looks like it's unaffected, just regular old prostate cancer, you give it a grade. But sometimes hormone and radiation can alter the cancer. And in those settings, you don't grade them. You just say this cancer with radiation effect or cancer with hormone therapy effect. And the reason why we don't grade them is that radiation or the hormone therapy can make the cancer look like a Gleason pattern 4. Can make it look aggressive. But in fact, those cancers have responded well to therapy and they're just quiescent. They're just kind of sitting there, not growing. So if we were to grade it, it would give a very misleading grade that these are aggressive cancers, when in fact, what we should be saying is this cancer's, doing well. It's responded to the hormone therapy, the radiation, and that's why it looks funny, basically.
Yeah. So it really depends on the individual situation.
Yeah, absolutely. Yep. So
Wow.
not all treated cancers you treat the same in a sense pathologically, right?
Well, we still know that finasteride and dutasteride for BPH, but not just BPH. All the attention of these 5-alpha reductase inhibitors come with large prostates and BPH, and those drugs come with some controversy. But you can't ignore the fact that a lot of men today are on Propecia or 1 milligram finasteride for hair loss. But the bottom line is a lot of people take this drug or another drug. What's the impact on you reading a sample or a prostate cancer pathology if someone's been taking that drug for a short or long time? Because
Yeah,
it's hormone therapy. It's kind of a hormone therapy, you got to admit.
Yep. Most of the time, it does not affect what we see under the microscope, but then occasionally I'll see a case that say, I'll look at it, I don't have any history, and say, wow, that's pronounced hormone therapy effect. I contact the clinician, and they say it's not on ADT or anything, but he is on, finasteride or Propecia. And then there are some patients who just have low testosterone, not due to drugs. And you can actually, the cancer can look different and can alter it. So I think what we don't necessarily always think about is each patient is unique, and patients can respond differently, and their body and their cancers can respond differently to the same drug. Right. Some patients just may be more sensitive to finasteride than another, or the cancer is more sensitive. And again, those can look different than somebody else who's taking the drug and doesn't affect their cancer at all.
But you should know, the pathologist should know if they're on any of these meds.
Yeah. In the past, I would say 99% of the time, we don't get that history. So I would say that the pathologist has to be aware and always on the lookout. Is what they're seeing just the cancer biology, or is what we're seeing potentially due to treatment effect? And they do look different. But again, you need experience, because you're not going to get that history 90% of the time.
But what if you're a pathologist that hasn't seen many prostate samples of men taking finasteride for hair loss and or BPH?
Yeah.
Are they supposed to know that?
They probably are not. Most pathologists don't have experience looking at cancer or radiated treated cancers either, or hormone treated cancers. So, and they're probably going to overgrade them, because they do look higher grade.
Oh man. Well, in about 10 minutes, we'll be at an hour, 5 minutes. So I'm going to move through the last 3 parts. So it's not very long. This is part 5. I call part 5 MIM Ops, miscellaneous important Moyad path stuff. That's what I call it. It's going to be a new acronym that's going to sweep the country. I'm doing part 5 just so Epstein fans will say that Moyad covered it. And I'm just trying to get your pithy, it can be a quick answer or not, but I'm also interested in these answers. And the first one's a little daunting. The first slide I have, or the first picture, and the rest of them are pretty simple. But let's just go through miscellaneous past stuff people inundate us with. Any comment on location of the tumor, anterior versus posterior tumors when you're looking at them?
No, I mean, it's been shown they behave the same. It's just a matter of detection.
How about apex versus base? People don't realize in the prostate, maybe you can tell me, why did they name the apex the bottom of the prostate and the base the top? The base is supposed to be at the bottom and the apex is supposed to be the top, and in the prostate, the apex is the bottom. But anyway, that's a whole other problem I have with the naming. Any comment on apex versus base prostate cancers? Are you more worried about moving into the bladder and the ones that are in the base, or bladder neck involvement?
The only thing is, if you're up in the bladder neck, you have the issue of potentially getting into the seminal vesicles. Yeah. But in terms of their aggressiveness or morphology, they're similar.
You mentioned something about laterality, that bilateral on both sides of the prostates are more concerning than a unilateral, right? Is that what
it's one more factor. It's not a rule out or rule in active surveillance, but it is one more factor.
And what's extraprostatic extension visually? Extraprostatic extension, I can tell you in my 35 years, sounds different to different people. Is this essentially something growing on the outside of an orange, but is it not necessarily touching anything else? It's like a spot. How do I visualize an extraprostatic extension, and should I be worried about that word?
Right. So I probably should put that in my lecture. I'm glad you mentioned it.
I'm going to be your agent.
Absolutely. So you can see on a pathology needle biopsy.
Yes.
The only way you can diagnose extraprostatic extension is if you see tumor in fat, because with rare exception, you don't have fat in the prostate. So if I see cancer glands in the fat, I know it's out of the prostate. And that also would, to me, be a contraindication for active surveillance. If that tumor is already out of the prostate, you don't want to let that sit there for another 10 years growing out of the prostate to the point that if you decide to treat it, it's not going to be treatable at that point.
So it's cancer that's in the fat. So the periprostatic adipose tissue or fat, it's moved into that. They're not an active surveillance candidate. It doesn't mean you necessarily are going to have spread everywhere, but it is a different scenario.
Right. You can still be, I think patients often get confused, like if the tumor is out of the prostate, that's it. I'm done. I can't be cured. And that's not true at all. Vast majority of patients with local tumor out, not talking about metastatic disease to a different organ, but if you just have some tumor creeping out of your prostate, vast majority can be treated with radiation. It might be higher doses. With surgery, it might be getting a little bit wider margins, but you can still cure the majority of those cases. But you don't want to be just sitting on active surveillance with tumor going out of your prostate and growing and growing and growing.
Oh my gosh, that is pure gold. What the HE double toothpicks is an index tumor. Why do some people use it and some people don't use that terminology?
Yeah, I'm not a big fan of it. So prostate cancer is often multifocal, meaning you have more than one tumor. Yes. A lot of times you have one major tumor and then some tiny little ones. And so we tend to call the major tumor index tumor, but usually that's the highest grade, the biggest tumor. But sometimes you might have a higher grade, a big 6 and a small 7. I would call the index tumor the 7 because to me, grade is more important than size. Somebody else might say, well, the big, I'm going to call the index tumor. So the term itself, probably not that great.
Margin status. When someone says it's margin status positive or negative on pathology, do I lose sleep over that? What's margin status?
That's only going to be in a radical prostatectomy. You can't do margin on biopsies. Margin means the surgeon hasn't been able to get the tumor out, the entire tumor out. Some of these cases with the margin positive is an artifact where there's barely like 1 or 2 glands there, and probably when you get healed and all this tissue gets killed after the surgery, it's going to wipe out those couple tumors. So it probably doesn't mean anything. But sometimes it means that there's an increased risk that tumor is going to come back, that you've left tumor in the patient. So it's important on a radical, not just to say margins positive and negative. You want to say how much tumor is at the margin and what's the grade of the tumor at the margin. So a little bit of 6 at a margin, I wouldn't say you need radiation or any other treatment. But if I had a little bit of 8 at a margin, I would say get radiation after surgery. Or if I had a lot of 6 at the margin, I would say get radiation after surgery.
So the margin should be more individualized. Do you feel that way about extraprostatic extension too, since you said it's in the fat now, or not necessarily?
Not really, because I wouldn't necessarily treat based on extraprostatic extension. Whereas margins, you're trying to decide radiation or not.
Why do people think of perineural invasion as binary? It's in one sample. Isn't it possible that more than one sample can have perineural invasion? Why? Yep. I think people think it's all or nothing. So in other words, if I have 6 samples that have perineural invasion versus 2, is that more concerning? I mean, is there, in terms of the amount of perineural invasion, or is it just whether you have it or not in the pathology?
Yeah. There hasn't been good data to say more perineural invasion is worse than limited perineural invasion.
I've never asked this question of anybody. No one's ever taught. Seminal vesicles, there's 2. There's 2 seminal vesicles. So it's not a seminal vesicle, it's seminal vesicles, right? You have 2. If you have disease, I don't even know if anyone's ever been asked this. This is my mind on sometimes caffeine. If both seminal vesicles are impacted by cancer in a pathology report versus one, is that more concerning or not necessarily so?
They're both bad. So from the standpoint of any kind of prognosis, it's probably not that different. Bilateral seminal vesicle invasion, when it's both, it's usually just even worse disease, but they're both bad.
Finally, on this one, total tumor. Why is it that a lot of cancers out there, tumor volume is everything? Just the gross amount of tumor that exists there. But total tumor volume, I mean, you talked about with this Gleason pattern 4, but total tumor volume, is that going anywhere? Just the total amount of cancer. And I'll tell you where I get most confused by this. You'll see a paper, or you'll talk to someone that has Gleason grade group 1. They have a 3+3, and they have a little bit of it, no big deal. But then there's other surgeons that say there's a ton of Gleason 3+3, and sometimes that's not the same as having a little bit of 3+3, and that kind of volume or amount is more concerning, even though they're active surveillance. So do you have any comment on that?
Yeah, so the only issue is if I had a crystal ball and I saw somebody had a big Gleason 3+3 in there and it was pure, I wouldn't be worried about it. But there is a correlation that the larger the tumor, the higher the risk there may be some pattern 4. So if you have somebody with like 1 core of 5% pattern 3 versus somebody with 10 cores of 3+3, you worry about that 10 core 3+3 that there is 4 somewhere in that prostate. But again, if they can go on active surveillance, and if they keep on having only 3+3, then it's okay.
These are the last miscellaneous ones. Then there's just one thing on part 6 and one thing on part 7, and we're done. Are you hanging in there?
Yep, I'm good. I can hang out until about 2:20.
No, I'll be done before 2:20. Famous last words, but I will be done because this is the most I've ever sat down with a pathologist and got the tertiary Gleason score. I thought the primary and secondary was good enough. Do I have to ask for a tertiary Gleason score, a third report? What the HE double toothpick does that mean? And should everybody report a tertiary?
So that's only on a radical. You should never see that term on a biopsy.
Okay.
In a radical, you can have, for example, a 3+4 with just 1% pattern 5, and same thing, a 4+3 with 1% pattern 5. So in that scenario where the 5 is so little, we don't want to call it a 4+5 or a 3+5. So we say 3+4 with tertiary 5 or 4+3 with tertiary 5. It worsens the prognosis somewhat, but not as bad as like if you had a lot of 5.
Okay, so it's a little bit of a hint of a slightly worse prognosis. Yeah. And that's mostly utilized if it's a more aggressive component there on the tertiary.
And that's only in radicals.
And that's only in radicals. As we jump around here, never heard anyone ask you this. Every other cancer I'm reading, whether it's friends going through it, other people I'm dealing with, you hear this term called tumor infiltrating lymphocytes. It's getting a ton of attention in aggressive breast cancer. You'll see these immune cells that just come into the tissue. And it's supposed to be a good prognostic indicator, for example, of someone that might respond to immune therapy. But it means the immune system is recognizing this as cancer. They call them TILs. Do you deal with any of this stuff, or do you think this has any place in prostate, or is prostate too cold immunologically?
Yeah, that's basically what you just said. Prostate just doesn't seem to attract those TILs, and consequently, it is relatively cold immunologically, and that's why immunotherapy is not, a major, treatment for prostate cancer.
You still watch the old shows. People get frozen section analysis during surgery. Do you still do what is frozen section analysis that pathologists get, or do they still have value today in your job?
They potentially have value. What the whole purpose of when you have surgery, we're not talking about a biopsy typically. You're talking about, let's say, a radical prostatectomy. You might have to wait 2 days, 3 days, a week to get the report. But there are sometimes the surgeon wants to know something right while they're doing the surgery, which may affect how they do the surgery. So you can do a frozen section analysis where basically you take the tissue, from the specimen, you freeze it, literally make it hard with ice, liquid nitrogen, and you generate a section. I would say it's not that commonly done. It used to be done that if there was a positive lymph node at frozen, they would stop the radical. Now they often would go ahead with the radical, even if they saw a small positive node. So unless they see something very unusual, most of the time they don't do frozens. But there are some exceptions. I mean, there's a couple institutions that do hundreds of, tens of frozen sections looking for margins. Entire margins they'll do with frozen sections. But that's rare. I would say most places are not doing frozen sections for prostate.
Here, the last word on this part, and then boom, we'll definitely be done by 20 after. Here's a term I've never seen in a pathology talk, and I understand it for patients, but I think it's time for patients to understand your opinion on it. And I always feel like, since I know you're probably bubbling inside, it says, what is this guy about to throw at me? But I think this is a very softball question. But what I'm finding before I show you what it is it's incredibly subjective. I'm sure some of it is not, but this has become sort of a wild, wild west of pathology. It's called immunohistochemistry. So you're using all these stains, and you're looking at markers or antigens, and you're staining the sample, and you're trying to decide this and that. And I've seen some that say, well, this is a metabolic stain and this does this. Can you just break down why immunohistochemistry is used much in pathology, and is there standardization, or how should a patient look at this?
Yeah, so what I would say for the patient is, for the most part, ignore the stains. Just look at the diagnosis. Having said that, the stains are used to help make the diagnosis, but the stains have a lot of pitfalls. And again, an inexperienced pathologist can use the stains incorrectly and to arrive at a wrong diagnosis, either calling something cancer when it's not, vice versa. So as a patient, again, you don't have to worry about the stains, but just recognize that stains are critical sometimes and have to be interpreted correctly.
Part 6 and Part 7 are basically the end. Part 7 is the end. Part 6 is, you mentioned this briefly in other talks, neuroendocrine prostate cancer. I think there should be some awareness by patients for it, because now with the use of a lot of different hormone type therapies, the second generation, I would guess that the number is going to increase. And can you just give a quick background on, this is a very aggressive variant of prostate cancer, and you also look for this when you do second opinions or you look at other samples, right? But can you give us sort of the Epstein thought on neuroendocrine prostate cancer? Because it's something, of course, nobody wants.
Right. So you'll hear the term neuroendocrine cancer. You'll hear the term small cell carcinoma of the prostate. They're basically similar. They're the worst form of cancer that you can have. You don't grade them. You don't give them a Gleason grade. It's there. Once you say that term, small cell carcinoma, then you basically know that these are extremely aggressive. The other thing is that they don't respond to hormone therapy. As you mentioned, you have to treat them with chemotherapy like you would use for a lung small cell cancer or a high-grade neuroendocrine cancer. It's a relatively rare, even though we're seeing it with greater frequency now than we used to, they're still rare.
But you're seeing it pick up, but it's still in the rare category.
Right.
Yeah. Because you mentioned in a lecture that a lot of them have a short interval to be, they become androgen independent, for example. And a lot of them make very little PSA. Isn't that true?
Right. So yeah, they're very different actors than usual prostate cancer. They spread to different sites. They don't make PSA.
Okay.
But again, in the active surveillance realm, you're never going to see that for sure.
Okay. The last one I have is that, all these GLP-1 drugs, these weight loss, before I go into the gift and the quiz, these GLP-1 drugs, I have to talk to them a lot. I published a review article in urology. It got a lot of attention because I just am trying to have urologists just catch up with the idea that these GLP-1s are here to stay. Have they studied yet the impact of these weight loss drugs on prostate tissue, or you haven't seen that?
I haven't seen that. It'd be interesting, but I haven't seen it.
It would be really interesting, wouldn't it? It makes me always think, if you had $100 million, someone gave you $100 million for research, I always wonder what research study you would want to do the most. Do you want to answer that before we go to the end? If you got $100 million, you could pick one research study that you wanted to really do to get an answer to a question. What would that be?
Right now, I'd probably do the Gleason 7 long-term follow-up active surveillance, looking at every parameter you could potentially look at to see who's a candidate and who's not.
Oh, good answer. Part 7 is the final part. Free for all, fun quiz, gifts, and conclusions. We made it. I had a goal of going through 7. This is why I call it the master class, the Epstein and Moyad master Q&A class. This will be legendary. All right, you ready? I'm going to finish off with a quiz. You don't have to answer it, but I'm a big history buff. It's called Dr. Moyad's first time ever Donald F. Gleason quiz. True or false? Ready? Here are my true or false questions. This is for the audience. It's not just for Dr. Epstein. I wouldn't necessarily expect you to know any of these. True or false? Dr. Gleason moved to Paris because he really wanted to be a painter before he went on to practice medicine. True or false?
If I had to guess, I would say true, just because it sounds so crazy.
It is absolutely true. And don't you find it interesting that after he decided he couldn't make any money, he wasn't very good, and his wife said, you're really not good either, apparently, they moved back to Minnesota, and then he got into his practice. But it makes you wonder what he learned to help him draw the Gleason patterns, right?
That's wild, yeah.
Yeah, so he did.
I always think of pathology as, you have to be extremely visual. I mean, I love photography. I mean, that's like my art form. And it's the same thing as painting in a sense. It's different, but it's visual. So obviously Gleason was a very visual person, and he translated that into his observations and his drawings. So yeah, that's amazing.
That is amazing. And he was also apparently a big time cook. He loved to cook and he loved to sail. And he would bring a lot of the stuff that he cooked to the residents and the students. So it's such an interesting history. True or false? Dr. Gleason lived across the street from his medical office so he could work all the time and just come home and eat and then go right back to work so he could work all the time.
I'd probably say true too.
That is absolutely true. All right, number 3, the hardest of all. Dr. Gleason, by the way, they say Dr. Donald F. Gleason. F is Floyd. I'm not going to ask you that question. That's too difficult. Because I don't know I know your middle initial. I've never known what your middle name is. All right. Last true and false question, then you get your gift sent to you. And you have made my day on this. I have literally covered everything I've wanted to cover in the history of our relationship. True or false? Dr. Gleason died or he passed away from prostate cancer at the age of 88 in 2008 in Edina, Minnesota. Is that true or false that Dr. Gleason passed away from prostate cancer?
I know so many luminaries who have died of prostate cancer, but I'll say true.
You're going to say true?
Yeah.
It's actually false. He died of cardiovascular. I'll tell you why. I'll tell you why I put this question in. I don't expect anyone to get it. It's because it kind of pushes my preventive medicine mantra. He died of cardiovascular disease. Apparently he had a heart attack. And I find it ironic, interesting that we always say heart healthy is prostate healthy, right? I always try to say that heart healthy is prostate healthy. And the grandfather, the emperor of Gleason himself, passed away from cardiovascular disease, which should give you cardiovascular awareness as well as prostate cancer awareness. But at the same time, you know, he was 88. He worked like a dog. I mean, but you know, you did well. Actually, I didn't know you were going to get any of those right. So as a gift, just to show you how much I listened, I talked to you on the phone a couple months ago when we agreed to do this. And you said something to me that resonated. So I thought there's only one gift we're sending to you. So we're sending this to your place. We're sending you a cup that says the best pathologist and even better father. Do you know why I'm sending you? Because at the last second, because you're always on the run and you're going to have to run here in 2 minutes. You said, I love being in New York. I love this new life. He said, I think you said, correct me if I'm wrong, I'm going right now to my kid's swimming practice. I could have never done that before.
That's what I'm doing at 2:20. I'm running to get my son to take him to swim practice.
Really?
Yep, 100%.
So then I thought, who says that? Who puts that? That was so endearing that it stuck in my mind. So PCRI and I have spent forever looking for best pathologists and even father. So don't throw it away. That's coming to your place. We have your home address. Listen, without sounding maudlin or sounding like an Oscar speech, thank you. I mean, you didn't know any of these questions coming at you for an hour and 15 minutes. We discussed no questions beforehand, what I was going to tell you, what I was going to review, and it was just masterful. It was outstanding. And I hope as people go to the website, look at his email, we'll put the email up there and how to get a second opinion from Dr. Epstein. So thank you so much for doing this again. I really appreciate it.
It was wonderful. Totally amazing. I appreciate it.
Thank you, Dr. Epstein, and thank you, Dr. Moyad. Now, if you would like some more information about Dr. Epstein and the presentation that he had, you can go ahead and go to our website. Again, if you're already on it, just scroll down. But if you're not at the website, pcri.org/2026 mid-year update. And this is just chock full of information. We're going to have Dr. Epstein's email and his phone number for his practice where he does consultations for prostate cancer pathology. And we're also going to share some other resources that we really feel are important when it comes to pathology. There's just breakdowns, there's handouts, all sorts of things that will be beneficial to you. So again, check out the website because I wouldn't want you to miss out on these resources. Now, I would also like to just remind you that this conference was made free because of our sponsors, Bayer and Dendreon. And we also have a lot of information from them in the exhibit hall, so make sure you check that out as well. You can see it in the links in the comments section, in the description of the video. If you're on the website, again, just scroll down. But it's an honor that they join us in these forces because they are incredible people that work at these companies, and they are really taking this money and bringing it to us so that we can produce things things like this for free. And that's not always the story with a lot of companies. So it's so cool that they do this, and we really appreciate them. Now, it is so cool that we get to present this for free to all of you, but I'm going to ask you to do me a couple favors. Number one, like this video. Number two, subscribe to our channel if you're not already subscribed. Now, you may hear this from other YouTube channels like and subscribe, and it seems like a very cliche thing to say, but there's a difference when we say it. When we say it, it means that our channel goes up in the YouTube algorithm, and then what that means is that these videos get pushed out to other prostate cancer patients and caregivers all around the world who are searching for these topics and searching for these titles. These are people who may have just been diagnosed. Maybe they're looking at treatments. Maybe they're having side effects and they just need to know how to mitigate them. You can help support PCRI by joining our cause and subscribing to this channel, because the more you do that, the more we're able to reach prostate cancer patients who are in need. Now, if you would also like to support us financially, you can do so at pcri.org/donate, and that is always welcome. We really appreciate any donations, because we have 87% actually of every dollar goes to prostate cancer resources for patient. Our overhead is like 13%. We work on it very hard every year to make sure it is low, and we want to make sure that we are pushing so hard that the money that you give us, we take very seriously, and we push it to resources, because that is our passion. We want to make sure that we are reaching people and that they are getting help in really desperate times. Cancer is already overwhelming by itself. Learning an entire language is already overwhelming. Learning the nuances and what to do and where you are, and we want to be there as a help and as a resource. And when you join PCRI by either donating or subscribing or liking the video, sharing it, commenting, whatever it is, that is just a great way to support other prostate cancer patients, especially the caregivers and the families that are working so hard to help their loved ones. Now, our next speaker is Dr. Eugene Kwon. We have a lot of names for him here at PCRI because he has been such a legend for us. He's spoken for us by now over 20 years. He is just somebody who really cares about patients. And the proof of that is the fact that he has hundreds of thousands of views on the series that he has done for us here at PCRI, which is the DIY Combat Manual. And what he did is he basically took all of his knowledge and put it into these talks. And you can watch his series on the front of the PCRI YouTube channel, and I'll link it in the description and in the comment section for this video, and also on our website. But he is just incredible. He has been working on this talk that he's giving today for over 6 months. And he has called Dr. Moyad and called me and said, what about this and what about that? Because he cares so much about presenting education to patients from a big picture perspective, but also getting into the details that we want to know. He's just somebody who not only just cares about patients, but is willing to put in so much time for free for all of us. And so I would encourage you, go watch his previous talks. I'm so excited on what he's presenting today, because when it comes to a recurrence and that PSA rising, and maybe you've been in a stable situation for a while, and then all of a sudden the PSA is growing, and what do you do next? He answers so many questions that we get submitted to PCRI every single day through our YouTube channel, through our social media, through our helpline, through these conference portals. And he just went through and answered so many comments. And he even read the comments from the previous videos on things that he was like, oh, I could add that in. He's so passionate about patient care. He's the professor of immunology and urology for Mayo Clinic, and it's one of the biggest cancer institutes in the world. And he has come to PCRI once again to present. He's also going to have an extended Q&A with Dr. Mark Moyad. They've had a great relationship. It's so much fun getting to watch them together, because I really feel like because of their relationship and how well they know each other, they're able to really just present so many great details that are important to patients. So without further ado, here is Dr. Eugene Kwon.
I'd like to thank the PCRI once again for inviting me to speak. As always, I feel that it's such an honor to have this opportunity and forum to assist men and their families as they navigate through the frustrating and scary uncertainties of dealing with prostate cancer. I do completely understand how agonizing it is to try to get all of your questions about prostate cancer answered, especially during one of the most challenging moments in your life. As I've mentioned before, it is my sincerest hopes that my presentations in some small way will help deliver you to a most optimal outcome as you move forward on your journey to defeat your cancer. For disclosure, I need to mention that Mayo Clinic and I have received licensing payments for PD-1 and PD-L1 related technologies. So today I hope to cover the topic how to recognize and treat prostate cancer recurrence after undergoing initial definitive therapy for localized forms of prostate cancer. By the way, my presentation is broken into 3 parts, kind of like a 3-course meal with a little appetizer, a huge entree, and a heavy dessert that you might want to skip because you feel so bloated after listening to me for so long. In 2025, roughly 300,000 new cases of prostate cancer were diagnosed in the U.S. alone. In the U.S. alone, between 90,000 to 100,000 of these men underwent some form of surgical treatment for their prostate cancer. Another 65,000 men received some form of radiation treatment as first-line therapy for their prostate cancer. However, over time, up to 50% of these men will experience some form of prostate cancer relapse due to failure of their initial surgery or radiation treatment. So, who's this lecture for? This lecture is for any man with localized prostate cancer who has previously undergone treatment using some form of minimally invasive treatment, some form of radiation therapy, or some form of surgical prostatectomy. In terms of objectives, with today's presentation, I hope to help you better understand details pertaining to the therapy or procedure you previously underwent to treat your localized prostate cancer, help you determine if you're truly free of cancer, help you recognize if your cancer might be returning or relapsing, and finally, help you understand what treatment options you might have if your prostate cancer is relapsing at its original location or somewhere nearby inside of your pelvis. In this presentation, however, I will not discuss which forms of initial prostate cancer treatment for localized disease are most effective versus which forms of treatment are least effective. Sorry. So before we get started, let's clarify some terms that I'll use in this presentation. For instance, definitive therapy typically refers to forms of treatment that are intended to wipe out prostate cancer that is mostly confined to the inside of the prostate or spread just slightly outside of the prostate. Relapsing prostate cancer refers to a recurrence of prostate cancer that takes place after an initial attempt to wipe out prostate cancer has failed. Localized prostate cancer typically refers to a form of prostate cancer that is entirely confined to the inside of the prostate or within an anatomical boundary where the prostate used to reside. And finally, regional or juxtaregional prostate cancer typically refers to forms of prostate cancer that have spread to nearby areas such as pelvic lymph nodes or other areas within the pelvis. Anyway, throughout the world, there are many breathtaking venues to enjoy exciting concerts, shows, presentations. In contrast, for today's presentation, the venue is the pelvis. So let's talk a bit about the pelvis. The pelvis is essentially defined by a ring or perimeter of bones called the pelvic bones. Within the ring of bones resides the true pelvis, which is essentially like a cylinder, not much bigger than a large coffee mug. Within this cylinder resides the various structures and organs of the pelvis. This includes the left and right iliac blood vessels that split off from the aorta and vena cava. These vessels deliver blood to the legs and to the pelvic organs. In addition, lymph nodes inside the pelvis typically follow alongside these iliac vessels. Just in front of the iliac vessels are the colon and rectum. In addition, the left and right ureter can be found in front of the iliac vessels. These ureters deliver urine from the kidneys down into the bladder. Immediately in front of the rectum and ureters are the bladder, the prostate, the seminal vesicles, and the urethra. In fact, the back surface of the prostate, seminal vesicles, and bladder rest directly upon the ureters
and the front surface of the rectum. Finally, it is within the prostate that prostate cancer first appears. It is important to note that cancer growth inside the prostate can be tiny or it can be extensive and associated with one or more sites of growth within this otherwise very ugly and annoying little gland. So now let's talk about definitive treatments that are available for management of localized prostate cancer. There are three general categories of localized prostate cancer treatment. The first category of therapy is referred to as minimally invasive or non-surgical treatment of prostate cancer. Minimally invasive treatments include HIFU or high-intensity focused ultrasound, which uses sound waves to heat up and destroy cancer cells inside the prostate. Cryotherapy or cryoablation, which freezes cancerous tissues inside the prostate. Focal laser ablation, which uses laser energy to destroy cancer inside the prostate. And finally, TULSA-PRO, which uses directional ultrasound from within the urethra to destroy tumors in the prostate. So exactly what should you expect after undergoing minimally invasive procedure for management of localized prostate cancer? In general, this is a very difficult question to answer because it's hard to predict and define what a favorable treatment response is. Specifically, indicators of favorable response are highly individualized for patients that undergo minimally invasive therapy. At a minimum, over time, you should expect that your PSA value will remain lower than the PSA value that you started with prior to undergoing your minimally invasive procedure. In addition, you should see no evidence of cancer recurrence on follow-up imaging, especially prostate MRI over time. Moving on, a second broad category of treatment which is often used to treat localized prostate cancer is radiation therapy. Radiation therapy includes low and high dose brachytherapy. Low dose brachytherapy often uses radioactive seeds that are permanently implanted into the prostate to deliver radiation over time. In contrast, high dose brachytherapy employs temporary catheters which are used to deliver high intensity radiation into the prostate for roughly 5 to 10 minutes. Another form of radiation treatment that is used for localized prostate cancer is proton beam therapy. Proton beam therapy delivers radiation to the tumor while minimizing effects on adjacent tissues and organs, such as the rectum and the bladder. IMRT, or intensity modulated radiation therapy, is perhaps the most commonly used and well-known form of radiation for treating prostate cancer. IMRT shapes radiation to the prostate while generally sparing healthy tissues around the prostate. IMRT is usually delivered daily over 6 to 8 weeks, but not on weekends, since radiation apparently doesn't work on weekends due to the strange behavior of physics in the medical world. In contrast, SBRT or stereotactic body radiation therapy can be used to deliver high-intensity levels of radiation to the inside of the prostate in approximately 5 sessions rather than 30 to 40 sessions for conventional IMRT. SBRT is pinpoint accurate and is increasingly popular as a treatment for localized prostate cancer. As an aside, it should be noted that radiation therapy can be used to treat either a very small or a very large field within the pelvis. For instance, brachytherapy is typically used to treat only the prostate and not the seminal vesicles. Brachytherapy is usually administered to men with relatively low-risk small cancers within the prostate. In contrast, IMRT, SBRT, and proton beam therapy can be used to treat men with low, medium, or high-risk prostate cancer, and the extent of the field being treated can vary depending on the patient's anatomy and aggressiveness of disease. For instance, men with low-risk cancer, i.e. small volumes of disease and low Gleason score, might not receive extensive irradiation of their seminal vesicles, whereas men with higher risk disease with larger volumes of cancer and higher Gleason scores might receive more comprehensive irradiation of their seminal vesicles and regions around the prostate. Likewise, men with very high-risk cancers and/or early spread of cancer might receive a more extensive field of radiation. This form of radiation therapy is called whole pelvic irradiation, which treats the entire prostate, seminal vesicles, and pelvic lymph nodes. In summary, there are multiple forms of radiation therapy that can be used to treat localized prostate cancer. Additionally, it is important to note that radiation therapy is highly individualized and that treatments can vary substantially from patient to patient and doctor to doctor. For this reason, you should always know details about your radiation treatment. Always keep a copy of the radiation plan or the radiation map for your personal records. So how can you determine if you're responding after radiation therapy? In order to assess whether you are responding favorably to radiation therapy, most radiation oncologists use the PSA nadir +2 rule. We'll discuss this in detail shortly. In addition, you should generally expect low and stable PSA values over time. Likewise, you should expect no evidence of cancer recurrence on follow-up imaging, which should include prostate MRI as well as PET imaging when indicated. With regards to the PSA nadir +2 rule, most men who receive radiation therapy for localized prostate cancer will also receive hormone therapy for 12 to 24 months. While on hormone therapy, a PSA value of less than 0.10 nanogram per ml or undetectable is expected. The lowest PSA value that is achieved during or after radiation is called the nadir. Therefore, for most men who receive radiation while on hormone therapy, the PSA nadir will be less than 0.10 nanogram per ml. After halting hormone therapy, however, PSA values will typically start to rise again. This rise in PSA often occurs when normal prostate tissues regain activity. Therefore, assuming that a man achieves a PSA nadir of less than 0.10 nanogram per ml following completion of radiation and after halting hormone therapy, a PSA value of 2 or less would be considered an acceptable value. Conversely, however, a rise in PSA above 2 would suggest relapsing cancer. For men who did not receive hormone therapy, however, PSA might not achieve an undetectable value, and thus a nadir value of X might represent the lowest PSA value achieved after radiation therapy. Therefore, a PSA value below X +2 might reflect a favorable response therapy, whereas a PSA value above X +2 might reflect relapsing cancer. Okay, so that was painful. To be honest, I'm not sure that I trust any metric of response that requires measurements of the position of the sun as Stonehenge or the use of mathematical formulas to calculate. Even worse, many radiation oncologists now feel that the Phoenix criterion should be amended to a PSA less than nadir +1 as opposed to nadir +2 to signify potential cancer relapse. At any rate, let's move on. The third and final broad category of treatment for localized prostate cancer is prostatectomy. Prostatectomy and lymph node dissection refers to the surgical removal of the prostate and lymph nodes from the pelvis. As with other forms of localized treatment, there are multiple different forms of surgical prostatectomy, including open radical prostatectomy, laparoscopic prostatectomy, and robotic prostatectomy. As the name implies, surgical prostatectomy involves the removal of the prostate. This surgery, when conducted properly, results in the removal of the entire prostate, seminal vesicles, and a segment of urethra. In addition, pelvic lymph node dissection involves the removal of some lymph nodes around the prostate. This cartoon shows what a surgical specimen should look like after surgical prostatectomy. Note that the seminal vesicles, which look like bunny ears, should be removed completely while still attached to the prostate. Also note that part of the urethra, called the prostatic urethra, is removed with the prostate because this part of the urethra actually runs through the center of the prostate like a straw through an apple, as is depicted in this cross-sectional cartoon. Anyway, after surgical removal, the site where the prostate and seminal vesicles used to reside are now called the prostate fossa or bed and seminal vesicle fossa or bed. Also, please note that removal of the prostatic urethra actually leaves a gap that needs to be closed in order to complete the surgery. To close the gap in the urethra after prostatectomy, the bladder neck is stretched downward and then sewn to the early part of the penile urethra. This surgical connection is called the vesical urethral anastomosis, or the VU anastomosis. As with other forms of treatment for localized prostate cancer, surgical prostatectomy is highly individualized. Surgical prostatectomy can vary substantially from patient to patient and doctor to doctor. For instance, some surgeons remove no lymph nodes or only a few lymph nodes at the time of surgery. In contrast, some surgeons will remove up to 40 or more lymph nodes during surgery. Likewise, some surgeons will only remove lymph nodes from the pelvis corresponding to the side of the prostate where the cancer was found, whereas other surgeons will remove lymph nodes from both sides of the pelvis, irrespective of location of cancer within the prostate. It is important to note, however, that no surgeon can ever remove all of the lymph nodes from the pelvis, which will be relevant when we talk about relapse. Anyway, it's for this reason that you should always obtain a copy of your surgical and pathology records to keep with your own personal medical records. So how do you know if you're staying cancer-free after prostatectomy? In stark contrast to a minimally invasive procedure or a radiation-based treatment, the expectation following surgical prostatectomy is quite simple. Specifically, it is expected that you will have an undetectable PSA after your surgery forever. And as always, follow-up imaging should not show any signs of prostate cancer relapse over time. In the next section of this presentation, I'm going to discuss how to recognize and manage prostate cancer relapse after failing initial treatment for localized cancer. In general, after a patient has undergone a treatment for localized prostate cancer, a rise in PSA over time would likely indicate a recurrence of cancer. Alternatively, follow-up imaging might reveal one or more sites of prostate cancer relapse after localized treatment has failed. In terms of symptoms, it is important to note that most men will not have any symptoms to indicate that their prostate cancer is growing back after treatment. Therefore, the development of symptoms is not a reliable indicator of prostate cancer relapse after localized therapy. On the other hand, a few men will develop symptoms that herald a recurrence of prostate cancer. For instance, some men might develop problems with urination. This could include painful urination, or a weak urinary stream, or the sensation of incomplete elimination of urine. This typically occurs due to blockage of the bladder or urethra due to recurrence of prostate cancer. Conversely, some men will experience a new onset of incontinence. This typically occurs due to invasion of the urinary valve or sphincter or bladder neck by relapsing prostate cancer. Another symptom of cancer relapse is gross hematuria, which refers to visualizing blood in the urine. This typically occurs due to invasion of the bladder or urethra by recurrent prostate cancer. One ominous symptom of cancer relapse is the onset of problems with bowel movements. When a man starts to feel like he has to push harder in order to pass his stools, this could indicate invasion of the patient's rectum and anus by recurrent prostate cancer. Likewise, the appearance of blood in the stool could also indicate relapsing cancer involving the anus or rectum. Another sneaky but serious symptom of prostate cancer relapse is the sensation of pain in the pelvis. This could include pain radiating to the penis or perineum or rectum. On occasion, this could also present as pain that radiates to the groin, testicles, or legs. Typically, these types of pain are due to invasion or compression of pelvic nerves by lymph nodes that are enlarging due to cancer invasion. In some men, cancer can actually be seen invading directly into the nerves of the pelvis. The bottom line is that you should demand regular and long-term follow-up after undergoing treatment for localized prostate cancer. An absence of symptoms is no guarantee that your prostate cancer is not relapsing. Follow-up should be provided at regular intervals and should include both regular PSA testing as well as some form of imaging. Related to this discussion, it's important to note that there is never a time where you can declare yourself completely free from the threat of prostate cancer relapse. The concept that being free of prostate cancer for 5 years means that you are cured of your prostate cancer is simply mythical. In our clinic, we routinely see patients who have failed definitive treatment of localized prostate cancer even 10 years or more after treatment was given. So, if your prostate cancer recurs, what pattern of relapsing prostate cancer might you see? Of course, one possibility might be local recurrence, in which your prostate cancer grows back at or near its original location, kind of like a dandelion growing back by its roots after it's been picked. Another possibility is that your prostate cancer could come back at one or a few discrete sites, either nearby or far away from the original site. I typically refer to this type of recurrence as focal or oligometastatic prostate cancer recurrence, little spots forming outside of the pelvis, for instance. Another possibility is that your cancer might recur at multiple sites within a zone or compartment or region of your body. These zones could include the pelvis, the retroperitoneum, or the chest. I typically refer to this form of recurrence as zonal recurrence. And finally, your prostate cancer could relapse in a widespread fashion throughout the body. I refer to this as diffuse recurrence of prostate cancer, which is also referred to as systemic metastatic disease recurrence. Incidentally, in case you are curious and want to investigate more, I've included some internet links that will direct you to some of our previous lectures that touch upon the management of local, focal, zonal, and diffuse forms of prostate cancer relapse. For today's presentation, I will only be discussing management of local relapse, as well as a specific subset of zonal relapse that is called regional or juxtaregional relapse of prostate cancer within the pelvis. However, before I jump into a full-blown discussion about management of local and regional prostate cancer relapse, I'd like to make a couple of general comments. Okay, for some men who experience prostate cancer relapse after primary local treatment has failed, simple observation might represent a reasonable option for management. Specifically, it might be reasonable to simply monitor a tiny site of recurrence, especially if the tiny focus of recurrent cancer remains relatively stable over time, meaning that it doesn't grow or generate increasing levels of PSA. This might also be true for a minor recurrence situated in a location that doesn't threaten any of the major structures in the pelvis, such as the urethra or a ureter or the rectum. Also, if a patient is frail or has other serious health issues, simple observation of recurrent disease might make the best sense for that patient. However, observation of relapse is only reasonable if a patient is willing to undergo very close follow-up with repeat PSA testing and repeat imaging, preferably every 3 to 4 months. If you're interested in more information regarding recommendations for follow-up and proper imaging of prostate cancer, please use these links to view additional lectures pertaining to these topics. Another general consideration pertains to the use of hormone therapy for treatment of relapsing prostate cancer. This table shows various forms of hormone therapy that are available, conventional and androgen receptor pathway inhibitors, or ARPIs or ARPs. Hormone therapy can be used for management of relapsing localized prostate cancer, irrespective of whatever form of therapy the patient initially received. However, it's important to note that when hormone therapy is used alone, all by itself, it is purely suppressive or palliative in nature. Also, it's vital to note that prolonged use of hormone therapy alone will inevitably lead to the development of resistant forms of prostate cancer that can be even more difficult to treat down the road. Kind of like treating rust on an old Camaro with spray paint. Looks good for a bit, but then yikes. For these reasons, I think hormone therapy should only be used as a single modality of treatment in patients who have no other options for treating their relapsing prostate cancer. I also think that hormone therapy is reasonable for individuals who are not healthy enough to undergo other forms of more aggressive intervention. However, I strongly advise against the use of hormone therapy alone to treat young, healthy individuals who have other more definitive treatment options available to them. One circumstance where I do think that hormone therapy should always be used is when radiation therapy, specifically IMRT, is being given to treat local or regional relapsing prostate cancer. It has been clearly demonstrated that hormone therapy increases the effectiveness of radiation therapy. In general, 12 to 24 months of hormone therapy should be administered during and after the administration of radiation therapy. Finally, hormone therapy can be used either continuously or intermittently. With regards to ARPI agents that I have listed here, I believe that ARPI agents should only be used in patients who are resistant to regular hormone therapy. These days, I personally feel that ARPI agents are being overused to treat patients with relapsing localized prostate cancer. Also, if a site of relapse has been identified, it's generally a good idea to pathologically confirm that cancer is present at the relapse site by pursuing a biopsy. It's also a good idea to rule out other sites of relapsing disease, such as metastatic sites, using MRI and PET imaging. Finally, for patients who have not had their prostates removed, it is always important to thoroughly assess the prostate itself prior to providing treatment of relapsing disease, especially if the relapsing disease is at a location outside of the prostate. Okay, one final general comment. I'd like to point out that managing relapsing prostate cancer can be both extremely complex and extremely risky. As such, I think that you should always make a major effort to find a physician who is highly specialized and experienced with managing relapsing disease. Virtually anyone can hold a hammer and a chisel, but very few people can carve Michelangelo's statue of David. In other words, not everyone can do a great job of handling relapsing cancer. As such, I think it is imperative that you find an expert if you're going to tackle relapsing prostate cancer. By the way, for you guys out there who are saying, hey, Quan, that isn't a chisel, that's a center punch, I already know that. I just didn't have a chisel in my toolbox to prep this photo. Okay, back to our main topic, localized prostate cancer relapse. So how do you know if you're experiencing relapse after minimal invasive treatment? Well, relapse after minimal invasive treatment is typically identified when PSA values are rising over time and or when evidence of disease recurrence is seen on follow-up imaging. Overall, the most common form of prostate cancer relapse that occurs following a minimally invasive procedure tends to be intraprostatic relapse. This means that the prostate cancer is actually growing back inside the prostate itself. So what options do you have to manage intraprostatic relapse? For many patients, some form of radiation therapy may be the best option for treatment of intraprostatic relapse. MRT, SBRT, or even brachytherapy all represent forms of radiation therapy that can be used to treat intraprostatic relapse. Prior to treatment, a prostate biopsy is almost always required to confirm relapsing disease. Also, you should always undergo a PET scan to make sure that the cancer has not spread outside the prostate prior to undergoing radiation therapy. Unfortunately, however, sometimes SBRT or brachytherapy may not be feasible due to pre-existent damage to the prostate, which makes focal forms of radiation more hazardous. In support of this, here's an example of a patient with intraprostatic recurrence after HIFU treatment. This patient's prostate was heavily damaged by HIFU, which actually caused the hole to appear in the right side of his prostate, as is seen inside the red circles here. That white spot is a hole in the prostate. Fortunately, this patient's relapsing disease was on the left side of his prostate. Ultimately, this patient was successfully treated with stereotactic radiation by one of our skilled radiation oncologists at Mayo. For some young and extremely healthy individuals, intraprostatic relapse might be best treated using salvage prostatectomy. Salvage prostatectomy represents a comprehensive way of treating intraprostatic relapse. Prior to prostatectomy, a biopsy is always required to confirm presence of cancer. Also, a PET scan should be obtained to rule out metastatic disease beyond the prostate. At the time of salvage prostatectomy, a pelvic lymph node dissection should be performed to rule out or remove any regional metastatic disease that might be lurking in the pelvic lymph nodes. Finally, some patients might be a candidate for a second form of minimally invasive therapy to treat their intraprostatic recurrence. However, be warned, this type of treatment should be undertaken with extreme caution, since the risk for recurrence and complications is extremely high. Moving on. So how do you know if you're experiencing relapse after undergoing radiation therapy for localized prostate cancer? Well, as I mentioned before, relapse after radiation therapy is typically identified when PSA achieves a value of 2.0 or higher above the PSA nadir, or when disease relapse is evident on follow-up imaging. As with minimally invasive procedures, the most common form of cancer relapse that is encountered is intraprostatic relapse. In general, this form of relapse can be very tricky to diagnose and frequently requires outstanding imaging with MRI and sometimes PET evaluation to aid in diagnosis. A targeted prostate biopsy with expert pathologic interpretation is frequently required to confirm recurrence. As I previously mentioned, there are multiple forms of radiation therapy that are used to treat localized prostate cancer. Here's an example of a patient who is treated with brachytherapy. In this x-ray, you can see multiple iodine-125 seeds that have been placed uniformly into the patient's prostate using a needle. Here's an example of a patient who has prostate cancer growing back in between the brachytherapy seeds. Using MRI, you can easily visualize the location of the brachytherapy seeds since they appear as black holes in the prostate itself. Okay? Relapse of prostate cancer after brachytherapy can be tricky to diagnose and treat, especially due to scarring that occurs after brachytherapy seeds have been placed. By the way, doesn't this prostate with all the black holes remind you of Bonnie and Clyde's car after they were ambushed in the movie, or Sonny's car in The Godfather? Anyway, here's an example of a patient who suffered prostate cancer relapse after proton beam therapy was used to treat his localized cancer, recurrence. Here's an example of a patient with intraprostatic relapse after conventional IMRT therapy was used to treat his localized prostate cancer. The whole prostate's filling up with cancer again. And finally, here's an example of a patient with a very ominous form of prostate cancer relapse after failing conventional IMRT therapy. In this case, the patient and his physicians assumed that the patient was doing just fine since the patient's PSA was undetectable after his radiation therapy. Unfortunately, this patient experienced a relapse of prostate cancer that didn't produce any PSA at all. And this whole thing is relapsing disease, okay? All of it. In this case, recurrence was found only using C11 choline PET imaging. Biopsy of the recurrent cancer revealed a very poorly differentiated form of adenocarcinoma of the prostate. Non-PSA producing neuroendocrine and small cell cancers can also be encountered after any form of failed therapy for localized prostate cancer. To learn more about non-PSA producing cancers, prostate cancer heterogeneity, and various forms of PET imaging that can be used for prostate cancer evaluation, you can watch these prior PCRI videos or presentations by our group. So what options do you have for treatment of intraprostatic cancer recurrence after failed radiation therapy? Well, everyone has heard the statement that once you are treated with radiation therapy, you cannot receive any more radiation therapy. Surprisingly, however, this statement is not absolutely accurate. For select patients who fail definitive radiation therapy for localized prostate cancer, some forms of radiation therapy may still represent reasonable options for treatment for recurrent disease. For instance, for patients with a small and discrete lesion, or individuals who were irradiated many, many years ago, or patients who originally received a less than aggressive initial dose of radiation, SBRT or brachytherapy might represent reasonable options for treatment of intraprostatic relapse. Here's an example of a patient who failed radiation therapy from many years ago. He was treated using high-dose brachytherapy. For some young and extremely healthy individuals, intraprostatic relapse might be best treated using salvage prostatectomy. As I mentioned before, salvage prostatectomy represents a very comprehensive way of treating intraprostatic recurrence of disease. At the time of salvage prostatectomy, a pelvic lymph node dissection should also be performed to rule out or remove any regional metastatic disease that might be hiding in the pelvic lymph nodes. Here's a young individual who experienced a rise in his PSA from undetectable to 5.7 after undergoing definitive radiation therapy for localized prostate cancer. Following a biopsy which confirmed the recurrence of prostate cancer, the patient underwent salvage prostatectomy. Following surgery, PSA dropped to undetectable levels, and the patient did extremely well. Okay? Finally, some patients might benefit from a minimally invasive procedure to treat their intraprostatic cancer recurrence following failed radiation therapy. In general, this type of treatment should be undertaken with extreme caution since risk of complications and recurrence of disease is high. In general, prior radiation can compromise healing. Therefore, overly aggressive, minimally invasive procedures can lead to the development of chronic wounds that can worsen over time, leading to complications like fistulas, which we'll discuss later on. Here's an example of how cryotherapy was used to eliminate relapsing prostate cancer within the prostate of a man who failed radiation therapy for treatment of his localized disease. This is his disease before with a PSA of 10. After cryotherapy, PSA dropped to 0.31. No disease is there. Patient did well. Okay, deep breath here. Finally, let's talk about relapse after surgical prostatectomy. How do you know if you're experiencing relapse after undergoing surgical prostatectomy for localized cancer? Well, as I mentioned before, prostate cancer relapse after prostatectomy is typically identified when PSA values go from an undetectable level to a detectable level greater than 0.10 nanogram per ml. Alternatively, recurrent disease can also be discovered on follow-up imaging. Following prostatectomy, intraprostatic recurrence is obviously not an issue since the prostate is gone. Instead, cancer can relapse within tissues where the prostate was once in contact with the various structures in the pelvis. These sites include the VU anastomosis, as well as the surgical beds of the prostate and seminal vesicles. Here's a patient who experienced a VU anastomotic recurrence of prostate cancer following prostatectomy, that tiny little dot there. Here's a patient who experienced the relapse of his cancer in the prostate bed. And finally, here are two different men who experienced localized seminal vesicle bed recurrence following prostatectomy, one on the right side and one on the left side. So what options do you have for treatment of cancer recurrence in the prostate fossa, seminal vesicle bed, or VU anastomosis after undergoing prostatectomy? Once again, without question, radiation therapy represents one of the most effective methods to treat cancer recurrence at the VU anastomosis or within the surgical beds of the prostate or seminal vesicles. IMRT or SBRT represent the most common forms of radiation that are used to treat localized cancer recurrence following prostatectomy. In addition, hormone therapy is often administered with radiation treatment, especially when IMRT is used for treatment of locally relapsing disease. As I mentioned before, roughly 12 to 24 months of hormone therapy is typically administered with IMRT radiation. One of the most common questions that's asked in my clinic is, well, why can't surgery just be used to cut out locally relapsing disease following failed prostatectomy? In general, surgery is not an option because the cancer that is relapsing in this situation is typically residing within the connective tissues and the scar tissues that comprise the prostate and seminal vesicle beds and the VU anastomosis. Surgically removing cancer from these areas would be akin to removing the cement that holds together a brick building. The only exception to this situation might be when a portion of the seminal vesicle or a big chunk of the prostate remains in place after prostatectomy has been performed. Finally, a minimally invasive procedure can sometimes be used to treat recurrences after failed prostatectomy. In general, if the site of relapse is small and very discrete, a minimally invasive procedure might prove effective for eliminating recurrent disease. What about treatment of other forms of localized regional cancer relapse? For instance, in men who have previously undergone either a minimally invasive procedure or a radiation-based procedure, the seminal vesicles themselves can represent a site for localized prostate cancer relapse. Here's an example of prostate cancer recurrence within a seminal vesicle after treatment with radiation therapy for localized prostate cancer. See that? Seminal vesicles filling up with cancer. For many patients, radiation therapy may represent a good treatment option for relapsing cancer involving seminal vesicles. This is certainly true for patients who have previously failed a minimally invasive procedure. For patients who have failed prior radiation therapy, however, further radiation treatment will depend on several factors, including whether or not the seminal vesicles were aggressively irradiated before. For select patients, seminal vesicle recurrence might be best addressed surgically. Seminal vesiculectomy can be used to remove recurrent disease, especially when the site of recurrence is small and singular. Finally, in some patients, an isolated seminal vesicle recurrence can be destroyed using a minimally invasive procedure. Freezing procedures such as cryoablation can be used to eliminate small recurrences in the seminal vesicle. Relapse of cancer within the pelvic lymph nodes also represents a fairly common occurrence after any form of localized treatment for prostate cancer. Recurrence of cancer in the lymph nodes is usually referred to as regional or juxtaregional cancer relapse. Here's a patient who experienced bulky recurrence of cancer within several of his pelvic nodes after failing cryoablation procedure. You could see these almost golf ball sized lymph nodes in the patient's pelvis. Here's a patient who experienced relapse prostate cancer in multiple pelvic lymph nodes after undergoing prior prostatectomy. And this patient did have a pelvic lymph node dissection, but he still had pelvic lymph node recurrence of disease. So what options do you have for therapy for patients with pelvic lymph node recurrence of cancer? Once again, for most patients, radiation therapy may be the best option for treatment. This is certainly true for patients who have previously failed either surgical prostatectomy or a minimally invasive procedure. For patients who failed prior radiation therapy, however, salvage radiation of the pelvic lymph nodes will depend on several factors, including whether or not the patient received radiation treatment of his lymph nodes before. For select patients, pelvic lymph node recurrence might also be addressed surgically. Pelvic lymph node dissection can be used to remove recurrent disease, especially when only a few lymph nodes are involved. This is an example of a patient who experienced prostate cancer relapse within several pelvic lymph nodes. These lymph nodes were removed by one of our highly experienced salvage surgeons here at Mayo Clinic. This is kind of an important slide. So PET has become very popular, and a lot of people are finding little lymph nodes filled with cancer all over the place. So a lot of these patients are going to their surgeons and they're saying, well, can you take out these lymph nodes? What you have to remember on a PET scan is that because of the bloom of the imaging agent, the lymph nodes look bigger than they really are. And unfortunately, there are a lot of patients that we see in our clinic who have been taken to the operating room in an effort to remove the involved lymph nodes, and lo and behold, the lymph nodes are still there because the surgeon couldn't find the lymph nodes. So if you're going to use salvage pelvic lymph node dissection to treat this form of disease, you really need to be very careful, and you need to go to someone who's highly experienced. Otherwise, you might have an operation and find out that the lymph nodes are still there after the surgery. Okay, it's a little sidetrack. Finally, in some instances, an isolated site of pelvic lymph node recurrence might be treated using a minimally invasive procedure. Here's an example of a patient who underwent cryoablation of a left perirectal lymph node after failed prostatectomy and irradiation therapy for localized recurrence. So there's the little lymph node there next to the arrow. It was frozen, and this patient did extremely well. His PSA dropped right down to undetectable levels. So what about other forms of pelvic prostate cancer relapse? Prostate cancer relapse involving the rectum occurs much more commonly than one might expect. This likely occurs since the back of the prostate essentially rests against the front surface of the rectum. At any rate, cancer relapse involving the rectum can be very serious and can actually lead to obstruction of the rectum. Treatment of rectal recurrences often requires a combination of systemic therapy, such as hormone therapy, along with radiation therapy. Unfortunately, for some patients, complete treatment is not feasible, and occasionally some patients will require surgical removal of the rectum or anus with some form of colostomy drainage. So this is the cancer invading into the rectum of this patient here. Recurrence of prostate cancer inside of the bladder also occurs much more often than one might think. Since the bladder is contiguous with the prostate, it's not hard to envision how prostate cancer sometimes crawls up and invades into the bladder. Identifying bladder involvement by relapsing prostate cancer can be extremely challenging. PSMA PET imaging is very poor for detecting recurrence of disease involving the bladder. In most cases, MRI, cystoscopy, C11 choline PET scan imaging might be required to identify relapsing disease within the bladder itself. On occasion, prostate cancer can also relapse within the penis. Here are two patients who experienced penile relapse of prostate cancer. Recurrence of prostate cancer within the penis is regarded as a systemic form of disease recurrence. Most often, this form of recurrence requires treatment with hormone therapy in combination with radiation therapy or cryoablation if possible. Here's a small recurrence at the tip of the penis. This is a large recurrence involving the entire penis. Prostate cancer can relapse within the urethra itself. As with penile recurrence of prostate cancer, urethral relapse of prostate cancer can be treated with hormone therapy, sometimes given in combination with radiation therapy. This is a cystoscopy which shows these barnacles or these things growing into the urethra. That's prostate cancer growing right into the urethra. You can see it on the PET image here. Occasionally, we do see patients who have relapsing prostate cancer within their testicles. For isolated relapse of cancer within the testicle, surgical removal of the testicle can prove to be curative. Here are two examples of men who present with isolated prostate cancer relapse within testicle. Here's one, and here's one right here. Both of these were successfully treated with surgical removal of the testicle. Everyone has heard rumors that prostate biopsies might be capable of spreading prostate cancer. Based on what we've observed in our clinic, we do believe that prostate cancer can occasionally be spread by mechanical manipulation. Here's a patient who experienced prostate cancer relapse in a prostate biopsy site in his perineum. All right. The abdomen and pelvis are actually separated by a thin membrane, kind of like cling wrap. This membrane is referred to as the peritoneal membrane. Here's an example of a prostate cancer relapse growing along the pelvic side of the peritoneal membrane. This line here, that's the peritoneal membrane being invaded by prostate cancer on the pelvic side. The inner walls that define the pelvis can also serve as a site for relapsing prostate cancer. Here's a gentleman who has a significant relapse of his cancer in front of his tailbone in the back wall of his pelvis. That whole thing there. Finally, here's an example of a patient who experienced a tiny rise in PSA 12 years after undergoing initial treatment for his prostate cancer. PET imaging revealed a very tiny recurrence of cancer along a nerve emanating from the sacrum just in front of the tailbone. Invasion of pelvic nerves by prostate cancer can sometimes cause very vague pain in the pelvis, penis, perineum, and legs of individuals experiencing prostate cancer relapse. So now let's talk a little bit about some critical situations that we see in association with relapsing prostate cancer. In general, the bed for the prostate and seminal vesicles encompasses an area that's approximately the size and shape of a silver dollar. Even though this bed is relatively small and thin, it encompasses a number of very vital structures within the pelvis. These structures include the front surface of the rectum, the back surface of the bladder neck, the two ends of the ureters that drain the kidneys, and the two valves or sphincters that control urination and elimination of stool. It's for this reason that prostate cancer relapse must be taken seriously. Relapsing prostate cancer within this small 1.5 by 1.5 inch area can inflict a serious world of hurt if it is not recognized and treated early on. Related to this, virtually any form of localized recurrence of prostate cancer can result in obstruction of one or both kidneys. Obstruction of a kidney is called hydronephrosis. Hydronephrosis can occur without any symptoms at all and can result in total loss of kidney function. Here's a patient who had significant obstruction of his left ureter and kidney due to relapsing prostate cancer in his left seminal vesicle bed. So there's the recurrence, the kidney is blocked, it's blowing up because it can't drain, and it's dying, okay? Regardless of the cause for kidney obstruction, drainage of kidney is typically necessary and sometimes an urgent matter. For some patients, drainage can be provided by placing an internal stent that defeats the cancer blockage to permit urine to drain into the bladder. Unfortunately, for most patients with relapsing localized prostate cancer, drainage of a blocked kidney can only be provided by placing a nephrostomy tube that drains the kidney straight out of the patient's back into a collecting bag. Finally, in extreme cases, relapsing cancer can obstruct everything in the pelvis, including the kidneys, the bladder, and the rectum, as was the case for this patient. His bladder is blocked, both kidneys are blocked, and his rectum's completely blocked. Fortunately, using surgery and immunotherapy, we were able to actually clear this patient's cancer. However, the patient does have a colostomy and an ileostomy to drain his stool and urine. Many of the patients who we see in our clinic have already undergone one or more procedures to treat localized prostate cancer. And many of these men experience in-field failure, which specifically refers to a recurrence of prostate cancer inside of a region that has already been treated with prior radiation therapy. In my opinion, in-field failure represents one of the most challenging forms of prostate cancer to treat. Even worse, patients who experience in-field failure are at enormous risk for developing a fistula. When you examine the pelvis in cross-section, it looks like this, with the pubic bones in front, the neck of the bladder behind the pubic bones, and the rectum directly behind the bladder. A fistula refers to an abnormal connection or tunnel between organs. Men with fistulas typically complain about pain in the pelvis or pain while walking. Oftentimes, a patient might have recently undergone placement of a urinary catheter or cystoscopy in the months just prior to developing a fistula. Fistulas can form as an abnormal connection between the bladder or urethra and the pubic bone. Alternatively, a fistula can form between the rectum and the bladder. Symptoms related to this type of fistula include gas and stool being eliminated during urination or urine being eliminated through the rectum during a bowel movement. In general, a patient with a rectal vesicle fistula will complain of painful urination or vague pain in the pelvis. Sometimes a patient will develop a fistula that connects his rectum to his bladder and his bladder to his pubic bone. Many of these patients develop sepsis, repeated urinary tract infections, and osteomyelitis of the pubic bone. In many of these situations, the osteomyelitis of the pubic bone cannot be cured and can only be suppressed with chronic antibiotic treatment. Some patients will die from chronic infections caused by fistulas. This is a patient who developed a fistula between his bladder and his pubic bones after an attempt by his local urologist to open up a scar that the patient developed following prostatectomy and radiation therapy. Unfortunately, this patient developed sepsis and a fungal infection of his pubic bone. The arrows that you see actually depict the infection spreading out from the pubic bones on PET imaging. So you can see these bluish streaks coming out, which is infection coming from the bone. Here's another patient who developed a large abscess and a fistula during his involving his entire pelvis after undergoing traumatic placement of a catheter in the emergency room. Forceful placement of a catheter resulted in perforation which connected the prostate bed with the rectum. At any rate, once again, I implore you to always make a major effort to find a physician who is specialized and experienced with managing relapsing disease. You don't want to suffer a disaster as you try to treat your relapsing cancer. Remember, virtually anyone can pick up a paintbrush, but very few people can paint the Mona Lisa. You definitely want an expert to be dealing with your prostate cancer relapse. Trust Leonardo. Okay, so here is the final stretch of my presentation, the big final yawn. In recent times, one question pertaining to the management of localized prostate cancer has generated a great deal of debate and discussion. Specifically, the question pertains to what is the best treatment for imaging negative or image negative patients with prostate cancer relapse. Imaging negative or image negative patients refers to men who have undergone prostatectomy for localized prostate cancer who then subsequently experience a rise in PSA after treatment without any documented evidence of cancer relapse on imaging. Historically, men who develop a rising PSA after prostatectomy have been advised by their physicians to undergo some form of radiation therapy for presumed local or regional recurrence of cancer. In fact, current AUA, ASTRO, and SUO guidelines recommend that patients undergo radiation therapy of their prostate fossa or their pelvis when PSA becomes detectable after prostatectomy, even when no cancer is found on imaging. Parenthetically, I'm not sure I feel comfortable listening to guidelines from ASTRO because I thought that ASTRO was George Jetson's dog. At any rate, in support of the current guidelines, there have been published studies that indicate that early radiation of the prostate bed or the whole pelvis improves survival for patients who experience a rise in PSA after prostatectomy. Conversely, there have been some studies that suggest that waiting for radiation targets to appear as PSA rises reduces rates of cure that can be provided by early radiation therapy. Another argument in support of providing early prostate fossa or pelvic radiation therapy for rising PSA after prostatectomy includes published observations that early radiation therapy is beneficial for the management of other forms of cancer, even in the absence of identifiable disease on imaging. At any rate, the current recommendation is to provide radiation treatment after prostatectomy in patients who have a rising PSA, even if a site of cancer can't be identified. Additionally, it's recommended that radiation therapy be provided before PSA achieves a value of 0.50 nanogram per ml. And finally, it has been suggested that the lower the PSA value at the time of radiation, the better the outcome. However, many patients express concerns about having their prostate fossa or entire pelvis irradiated when a site of relapse has not been identified. For many of these patients, this approach simply doesn't make sense, like hunting with a blindfold on. Clearly, with the dramatic evolution of PET and high-quality MR imaging, the rationale for irradiating the prostate fossa or pelvis in the absence of identifiable disease is making less and less sense these days. Also, with increased use of MR and PET imaging, I think that post-prostatectomy patients who have a rising PSA and no findings on imaging represent a shrinking and relatively niche population of patients. For these reasons, I believe that today's population of post-prostatectomy patients with a rising PSA and no findings on imaging is much different than the cohorts of patients who were studied in older radiation trials before PET imaging was available. Thus, results from prior trials that showed survival benefits due to early radiation treatment must be interpreted cautiously in the context of today's population of post-prostatectomy men. Anyway, one of the biggest concerns that I have with the terminology for image-negative relapse seems to be the fact that the definition is nebulous and somewhat open to exploitation. For many patients that we see in our clinic, negative imaging means no imaging was conducted at all. Additionally, for some patients, image-negative disease refers to patients who were declared negative after one single attempt at imaging was made when serum PSA values were ridiculously low. For other patients, image-negative relapse pertains to patients evaluated by CT or bone scans, which are essentially useless for identifying early cancer relapse. Alternatively, some patients have only been evaluated with PET imaging, which by itself is inadequate to assess relapsing disease deep within the pelvis. Specifically, our group recently reported that use of PET imaging alone will miss 1/2 of all recurrences in the prostate or seminal vesicle bed or at the view anastomosis. For this reason, we reported that PET imaging should always be used in combination with MR to identify forms of local relapse that might respond best to radiation therapy. At any rate, it's my feeling that failure to map sites of recurrence before providing any form of therapy can compromise overall treatment. So why are physicians seemingly so obsessed with irradiating the prostate fossa and or the pelvis as soon as possible? Well, before 1986, detection of recurrent disease was essentially based on digital rectal examination. Hence, by definition, it was thought that all recurrences of prostate cancer were local recurrences found in or around the prostate fossa, unless, of course, you had very long fingers. By the way, the reference to digital rectal exam is not the same use of the word digital that drives artificial intelligence, even though many of us physicians have been accused of being very artificially intelligent. Anyway, also in 1980s, everyone embraced the Halstedian model of cancer recurrence, which suggested that all relapses occurred in a stepwise fashion, with local recurrence first, right here, followed by regional spread of disease and then metastatic dissemination of cancer. But much has changed since the 1980s. For instance, surgical prostatectomy has undergone several major advancements that likely diminish rates of local relapse. In addition, we now know for certain that a rise in PSA is not synonymous with local cancer recurrence. In support of this, my colleagues and I previously published this mapping study, which reported contemporary patterns of prostate cancer relapse in patients who experienced a rise in PSA after prostatectomy. Specifically, our study revealed that prostate cancer relapse occurred locally in the prostate and seminal vesicle bed or at the view anastomosis in only 33% of patients after prostatectomy. In contrast, 25% of patients experience a combination of both local as well as metastatic recurrence. And finally, 45% of patients experience some form of metastatic relapse of disease in the absence of any local recurrence. From this, we surmise that at least a third of patients or more will not benefit at all from early irradiation due to relapse of disease outside of the prostate, fossa, or pelvis. So why does it matter that some patients might not benefit at all from early irradiation therapy for image-negative disease? Well, radiation can cause side effects in up to 11 to 26% of patients. Also, a near miss in which a prior radiation field ends up grazing an actual site of disease can complicate subsequent treatment. For instance, here's a patient who is advised to receive whole pelvic radiation by his local physician instead of waiting for a clear site of relapse to appear. During second opinion consultation, we encouraged the patient to wait until a site of relapse was established by imaging. Ultimately, when the patient's PSA achieved a value of 0.17 nanogram per ml, a site of relapse on the front surface of the bladder was identified. SBRT without any hormone therapy was used to eliminate this site of recurrence within 3 sessions. The patient had an excellent response therapy. If treatment was given without imaging, as initially suggested, this site of cancer would have been either missed altogether by the radiation or grazed by radiation, thus warranting additional future treatment. Also, the aggressive push for radiation at PSA levels of 0.5 or even lower worries me, since a percentage of these patients may not necessarily harbor clinically significant forms of cancer recurrence. Performing radiation therapy at extremely low PSA values eliminates opportunities to delineate between clinically aggressive cancer versus more innocuous forms of relapse. For instance, here is an image-negative patient whose PSA has only risen a very tiny bit, from 0.3 to 0.047 over the last 12 years. Likewise, here's a patient whose PSA rose to 1.4 over a 9-year period. Ultimately, however, this patient's rise in PSA was due to median lobe regrowth, a benign prostatic hyperplasia, or BPH or old man's disease, which was resected due to obstructive voiding complaints. No cancer was found in this specimen here, okay? At any rate, most discussions regarding treatment of a small rise in PSA after prostatectomy assume that the rise in PSA always occurs due to clinically significant relapse of cancer. But this may not be the case, since some studies have suggested that up to 30% of low-level PSA relapses after prostatectomy may be due to either residual benign prostatic tissue regrowth or more indolent, non-aggressive forms of cancer recurrence. Anyway, the key question is whether a patient puts himself at risk by waiting to identify sites of prostate cancer relapse. Personally, I do not think so at all. Perhaps the best evidence supporting this supposition is our recent experience with management of oligometastatic prostate cancer. We now know for certain that oligometastatic disease can develop slowly over many years after prostatectomy. We also know that these oligometastatic lesions often respond well and completely to metastasis-directed therapies. If you shoot the spots, they disappear. PSA goes down to nothing. In addition, oligometastatic disease is often seen in the absence of local recurrence, and metastasis-directed therapies frequently do not require any concomitant irradiation of the prostate, fossa, or whole pelvis. From this, one might conclude that an interval of observation does not likely put a patient in harm's way, and that disease recurrence can certainly occur independent of locally relapsing disease. At any rate, I believe that the overall trend is moving towards identification of sites of relapse prior to administering radiation therapy for subjects with a rising PSA after prostatectomy. New studies supporting a vital role for MR and PET imaging in order to guide radiation therapy for patients with a rising PSA after prostatectomy are being published almost every day now. Moreover, the advantages of image-guided therapy versus early radiation treatment of image-negative patients is now being formally studied in a clinical phase 2 trial being run by Doctors Sharma and Phillips here at Mayo in Rochester. So hopefully we will soon know the answer to the question how best to manage imaging negative patients who are experiencing a rise in PSA after prostatectomy. So that concludes today's presentation. Before I finish, I'd like to thank all of my colleagues who helped me put this lecture together. I had a ton of questions that I didn't even understand, and hopefully I've presented this well to all of you. I must say that I'm so fortunate to be surrounded by the absolute masters of treatment, especially in the arena of relapsing prostate cancer. This includes my outstanding colleagues in radiation oncology and urology. These are the salvage surgeons, and our minimally invasive interventional therapy group. If you experience a relapse of prostate cancer, I encourage you to please feel free to reach out to any of these outstanding physicians using the scheduling phone numbers I have provided. And of course, I'd like to thank my very dear friends on the Quan team. I wouldn't be able to survive without you. By the way, aren't you impressed how AI can make me look so much better? And then before we end, I'm just going to click through our previous presentations with the QR codes and links in case you want to follow up on some of our lectures to get a better idea of how to manage advanced prostate cancer. I think I've been giving presentations now since 2011, which is now 15 years. All right, that's it. Thank you.
That was excellent. And, you know, I'm not just saying that because I want to be your friend because you're really famous. Well, partially I'm saying that. But you moved at a good pace. You had a lot of topics. How did you feel about that talk?
I think it's a tedious talk, but I think it's a necessary talk. You know, when I put it all together, as I shared with you before the presentation, I literally, it got up to 360 slides. And then I had to cut a bunch of stuff out. But, you know, I try to put these talks together for patients that are experiencing different circumstances. Not every patient has the same circumstance. And I'm hoping that patients will find what they need in this kind of encyclopedic presentation that deals with relapsing disease.
Well, I think it's great. It's a challenge, though. There's a lot of stuff to cover. The most important question I thought I would ask you, I would just come right out the bat and ask you. All right. Do you know who played in the 2026 National Basketball Championship game a few weeks ago and who won that game? So can you tell me who played the two teams and who won that game and who's the national champion? And I'm going to bet right now that there is no way. I'm going to bet you a free lunch at Outback Steakhouse at Mayo Clinic that you're not going to get this right. So What are your answers to the first and second question?
Well, the answer is that I wish University of Illinois had won and beaten UConn and then kicked the butt of Michigan. Okay.
Okay. Oh my goodness. So who played in the championship game?
But once you get to the championship game, you got to root for the Big Ten. So I rooted for Michigan.
And who won that game?
Michigan won. Big
Thank
time.
you. Thank you. And I now owe you lunch next time I'm at Mayo Clinic. I really thought there was no chance that you would get that correct. You know?
I actually didn't watch the game. I heard about it on the news.
I don't care. I don't care you didn't watch. I bet all the audience. I've asked you sports questions for over 10 years. You never get any of them right, which I think is a testament to the fact that you're just working all the time. So I was convinced. I told all my colleagues that you're not going to get this question right, and you did. So now I'm just going to tell you what your gift's going to be. I'm going to send you an official Michigan hat, national championship hat. Okay, so you got to put that in your office. National champions.
All right.
All right.
Well, if you just spend a little money, maybe you could actually get me a national championship hat.
I will get you a national championship hat.
Oh, okay. All right. It's got to say national champion. Yep.
I mean, I'll ask PCRI to pay for it, but I'm going to send it.
Okay.
All right. You want to talk relapse? Because that, to me, is the word of your talk. All right?
Yep.
Relapse. And I want you to comment on a couple of things I thought about when you said relapse. So when I hear relapse or recurrence, right? What people are often confused about, and you and I have talked about this for years, and I want you to explain it from your standpoint. Some people think of relapse as a sudden return of the cancer. So the cancer was gone, there was no cancer, and boop, it came right back. Or was that cancer always there and it finally showed its face? Can you explain just kind of that physiology of relapse? How should I look at my relapse? Is it that it came back or it was always there? How do you look at it?
So, I think that's a really great question. And I think a lot of patients ask that question. It was always there. So prostate cancer, if you think about the little cancer cells, they have the capacity to basically hibernate or hunker down or protect themselves and go into kind of a quiescent state. Just like seeds out in nature, seeds can be blown everywhere, but until conditions are proper, they may not grow. So many patients that undergo localized treatment, you blast away with radiation, you do your surgery and everything, and all of a sudden you discover that the cancer is coming back later on. It's not that it went away, it was that the seeds or some element of the cancer was there. It was either not detected because it was microscopic and too small, or it was not detected because the cancer cells were sleeping, or is not detected because no one looked in that area. But over time, those things can come to life and they can start to grow again. And it's kind of, when I first came to Mayo, we used to write papers. Well, if you had a prostatectomy 10 years ago, you're never going to have a recurrence. And then all of a sudden, we start seeing recurrences 11 years later. So we wrote a paper. Well, if you had a prostatectomy 11 years ago, you'll never have a recurrence after 11 years. Then here comes a guy with 15 years. So to me, the incredible thing is that these cancer cells can go quiescent and they can pop up down the road at incredibly long intervals, 10, 15, 20 years later, you can see a relapse or a recurrence of the cancer. But it's not that it went away. It's just been sleeping or hiding in the soil of your body.
So you do see, I wouldn't say on a regular basis, but you do see individuals. Like I have a friend who's 15 years out from his radical prostatectomy, and he just had a relapse.
We have tons of those kinds of patients. And so that's why, I tried to make the point that, we used to always tell everyone, well, if you're clean 5 years, you're cured. That's simply not the case.
Yeah. But the advantage, we'll talk about this later, but the advantage with all this great imaging is you can find it earlier now and maybe get a second shot at cure, right? I mean,
Yep.
so can you comment also? I hate to be redundant from your talk, but these are important points. And I never really thought about it. I'll tell you the good thing about your talk. Sometimes I'll look at your talk and go, well, the audience already knows that. That's pretty basic. And then I realize when I think about it, well, no, they don't. I don't think many doctors understand what you're talking about. So I love that you kind of go over the stuff that people already just kind of assume you're supposed to know, but I don't know how they're supposed to know it. Here's something I've never heard anybody say, and I'm kind of paraphrasing what you said your whole talk. Relapse is a specialty. See, that's kind of what I took from your talk. We think of, oh, I need the best surgeon. They have to have done 5,000 radicals. I need the best radiation oncologist. He has to have done 5,000 patients. I need the best blah, blah, blah. But we never talk about if there's a concern about relapse after primary treatment, you should go find people that handle it like a specialty. And now I'll stop talking. What do you think?
I think that's absolutely true. I think that, the assumption is that everyone knows how to handle relapse, and that's simply not the case. And I think that people would be shocked to find out how little familiarity a lot of physicians have with actually handling relapse. I think that, many centers, many fancy places you go to, they do the primary surgery or the primary radiation very well, or the primary minimal invasive procedure. But then when it comes to relapse, people tend to be reflexive. They don't think about it. They just say, oh, hormone therapy, or oh, radiation, or oh, whatever. You have to be incredibly thoughtful to deal with relapse. And unfortunately, the reason that we're seeing so many patients in my clinic, and all of them are relapse patients. I mean, I only see relapsing patients. We see 8,000 to 9,000 patient visits a year, and we're constantly getting bombarded with these patients. And a lot of these patients will go to their physician and they'll say, "Oh, you got a relapse. Go get radiation," and that's it. Or go start taking these hormone therapies, and that's it. That's as deep as the conversation goes.
Yeah.
But it's a terribly complex problem to solve, and the approach has to be extremely thoughtful. And the downside of not being thoughtful is very often you don't treat the problem, you end up with another problem, and then another problem. And as my talk tried to point out, sometimes those problems can become quite catastrophic in terms of side effects or even compromising overall life expectancy.
That's interesting. I never really thought about it, but the fact that the majority of your patients are relapse patients, that makes sense.
Yeah, I mean, that's virtually all we have, I mean, after my prostatectomy, my PSA went up and I got put on this medication, and what the heck's going on? Or after my radiation therapy, my PSA went up and they did this and that, and what the heck's going on? So that's all we handle. And as far as I know, we kind of have a very large experience with dealing with relapsing patients, a very unique experience.
And you also said during your talk that part of the problem in relapse is people are just suddenly giving you radiation, suddenly giving you hormone therapy, suddenly giving you some of the newer medications without giving it thought, right?
Yeah, it's scary to me because the classic example is, a patient says, well, my PSA is going up, and you and I had a little conversation last night. Basically, if that patient says my PSA is going up and he goes to a radiation guy, well, the radiation guy may give radiation. Goes to a medical oncologist, that medical oncologist might put the patient on hormone therapy. Goes to your urologist will look the patient over to see if there's any surgery that can be done. But beyond those steps, there's really no consideration of how to solve the problem. So it's kind of binary. Either they can solve the problem with whatever they do, or they say, well, I don't have a solution for this, or go see my colleague. I was hired at the Mayo Clinic in 2002. The number one indication for an appointment at the Mayo Clinic was not for prostatectomy. It wasn't for radiation therapy. It was for rising PSA after failed primary treatment. So
Yeah.
what that tells you is that the number one form of prostate cancer that we are dealing with in the world is not necessarily the newly diagnosed stuff. It's the iatrogenic results of therapies that didn't work. So this is I call this an iatrogenic epidemic.
Yeah.
This is kind of an epidemic that physicians created where patients have this secondary problem. And I think it's very important to get it handled correctly, you know?
But we went through several decades where many physicians were doing their best. They thought they knew where the cancer was, so they treated. They thought it was localized, and they were basically confined to what they had at the time. The imaging was not that great, and we're only talking about 5-6 years ago.
Yeah.
I mean, so really, that's what's so interesting about your talk. It makes me think about this whole situation of relapse. But can I ask you a couple other questions around relapse before we kind of jump around?
Sure.
Okay. Another message you had about relapse is what you call, and it plays in this area, is imaging negative cancers. Okay, so now we're going to move into the biggest controversy that people are going to deal with when they watch your video on relapse. What you see is not completely what you have, right?
Right.
What I meant by that is that what you're telling people to do is, look, let the PSA get up there. I ideally want to see it on some kind of test, imaging test. Maybe it's choline, maybe it's PSMA, maybe it's MRI. I want to wait to see it. But the problem is half the other world is screaming at the patient going, look, your PSA is getting really high. We're not seeing anything, so we have to drill this sucker now. So this is a many-part question because I want you just to comment on this. The criticism is going to be of what you're saying is that if you want me to wait for my PSA to increase high enough, right? How high is too high before I need to get it treated? Because some people have PSAs, these people, they'll go to 2, 3, 4. You can't find any cancer. So are you telling people just to sit back and be patient and let that thing go up as high as possible? Or are you just saying most of the people eventually have their cancers show up on an imaging test, so just be patient? What exactly are you telling people in terms of how long they should really wait? Because they're being told by the other half of the medical establishment, the longer you wait, the higher the PSA gets, the less likely I can cure your relapse.
Right. So we have to go back about 15 minutes ago.
Yeah.
And we have to talk about cancer coming back. So when a person relapses, the seeds are planted. And you're waiting to see where those seeds of cancer are sprouting. But the seeds have already been distributed. They've already been disseminated in the body. They're there. So you're trying to figure out, where are the seeds going to grow? Treating someone earlier does not change the distribution of the seeds. Okay? So the answer to your question is tricky because for some patients, I have to read the room. Some patients are not going to want to sit on their cancer because they want to do something. They want to do it now because psychologically they feel better having something done right now. Or they've been told by their physicians that the cancer is zooming around their body like a Mazda commercial. Zoom, zoom, zoom. And it's just spreading like wildfire all over the place, which is not true, but that's what they've been told. So if a patient is very, very concerned, I will tell them, of course, we can go ahead and treat you. Actually, to be honest with you, the way that we're dealing with that now is that we're just having our patients enter the randomized phase 3 study, which will randomize them either to early treatment versus PET imaging if they wish to participate in that. But when I do say we can treat it, I also provide the caveat. that there's a chance that what you're having treated is not going to solve your problem, so that they don't come back later and say, why is my PSA going up after I got my whole pelvis irradiated and after I've come off my hormone therapy? So it's very, very different for different patients. We have published papers that clearly show that if you wait as the PSA goes up, you will see the distribution of disease. And for guys that let their PSA go very, very high, 10, 20, 30, 40.
Yeah.
Where you find the cancer is typically in the retroperitoneum and in the chest. And that's not because you waited. That's where it was hiding. And that's what made it so difficult to find in the first place. Okay? Does that make sense?
It does. But you're still happy in that case for letting it go that high?
As long as the patient fully understands and, is in agreement. And ironically, well, you might not find this all that strange, but a lot of our patients that actually let their PSA rise a great deal.
Yeah.
What do you think their vocation is?
What is their vocation?
Physicians.
Interesting.
So they already understand that, this is not something that you can force. This is something that is. This is nature. And the distribution of their disease is determined by nature, not by practice. Okay?
Yeah, yeah.
So the vast majority of our patients that say, hey, look, I don't care if my PSA goes 65, as long as it's not bugging me, I'm okay.
Yeah.
A lot of those people are physicians.
That's really interesting. Because I just relate everything from my background, from preventive medicine standpoint. In the old days when I was trying to tell people it's okay to take a statin, it's okay to take a cholesterol drug, and they said no, it might be dangerous. And I said, the first people who take a cholesterol lowering drug when they need it, it's the cardiologists.
Yeah, right.
So right. So it kind of gives you a hint as when they look at the data, how they feel about it.
But we never coerce or try to force these things upon people. Everyone's got a different comfort level.
Yeah, absolutely.
Like I said, we have patients that come back and say, well, Quan, you and Mark used the word cure for prostate cancer and you guys are wrong. Obviously everyone sees things in different shades of gray, and everyone has different comfort levels and different things that they can tolerate. But perfectly in the world of what I really think is going on, I don't think that you can get a higher cure rate just because you're blasting earlier. Okay?
Okay. And some of the references we can talk about in a little bit, some of the references that you put in your slide deck are some of the newer references that are showing that if you wait, you put in 3 references that I asked, it was still there, I believe. I don't know. You just have to remind me. You put 3 references in that were very recent that shows the benefits of waiting in a couple of clinical studies right now from Europe and the United States. So I encourage people to always also look at Dr. Kwan's references. I was impressed that you put those there, and we can talk about that in a minute. But it makes me think of this. It makes me think of also false positive relapses for a second. Can we talk about that? You mentioned, is this very common? For example, finding benign tissue, someone that's had a prostatectomy, for example, but there's some benign tissue left, and ultimately it starts to make PSA and it grows. Are you seeing relapse, what I call relapse false positives, where something lights up and you're thinking, oh, there's cancer that's back. And then you go looking further and it turns out to be a benign condition that set off the alarm. Is that very common in your practice?
Yeah. So before I go there, the last part of my talk was a byproduct of a debate that I had with a very esteemed radiation oncologist, Dr. Brian Davis here at Mayo.
Yeah,
we recently gave this as debate, and the reality of the matter is the radiation oncologists are keenly aware of the fact that imaging may play a bigger role in managing prostate cancer in the future, and they're not averse to it. As part of that debate, the conversation did come up about biologically insignificant PSA recurrences. And I referenced an article in my presentation today. You were probably in the bathroom while I was talking about it, but that the reference says that some people suspect that 30% of low-level PSA recurrences actually are not clinically significant. And that means that they don't necessarily progress over time, or that might be due to microscopic benign disease that's left at the VU anastomosis that grows over time. Normal prostate tissues make PSA. So if you shave a sliver of normal prostate off so that you don't damage the sphincter or whatever, that's going to pump out a tiny amount of PSA over time. Or sometimes a guy will have recurrence of disease inside the bladder that's the median lobe of the prostate that did not get taken out with the surgery. And the article that one of my residents gave me was basically saying that they think that 30% of these low-level recurrences of PSA don't manifest as clinically significant disease down the road, meaning that some of it's benign or some of it's very indolent in nature. The conflict, though, that comes about is then you have some radiation oncologists or physicians that are saying, well, if you don't irradiate that thing before you hit a PSA of 0.2, you're not going to be cured. Well, that's a huge conflict because you have to watch the PSA over time to know, is this biologically significant or is it biologically insignificant? But then if you have a mandate that says, well, you have to treat everything that hits 0.2, you're going to be treating everyone. So this is why this is a hot debate. This is why it's an interesting debate. The conclusion, in all honesty, is that people think that we need a randomized trial to answer the question definitively. And, that's what I think that people at our institution are trying to do. At the same time, however, I have to say that I do think that this may be a self-fixing problem because more and more relapses are being identified with more and more imaging, which is getting better and better every day. So this may be a problem that resolves itself over time. We'll see.
Well, you're implying a few things. What you're implying, if that resident's correct and you believe that 30%, you may be implying that not too far in the future, or maybe even right now, there's going to be a category of relapse patients who go on active surveillance for relapse.
Basically,
in other words, they'll be just monitored. Is that what you're implying too? Because that's
so. In some regard, I did have that in my talk, where for some patients, I think observation's reasonable. I personally, I didn't explicitly say it in the video or in the presentation, but my opinion is if the PSA ain't moving, and if the relapse spot is tiny and things are stable over time, observation is a reasonable option. Absolutely.
I'm counter Quan now because that's my job. Okay, I hear what you're saying. You make a compelling argument. But what you're also assuming in this argument, which I don't think anyone's ever said to you or the girls and boys at Mayo Clinic, is that if you want to see something on an image and say that's where the cancer is, what you're assuming is that's the limits of the extension of the cancer. In other words, you're saying it's the ultimate that picture is the ultimate telltale sign of how far your cancer has spread. That's also why I'm waiting for it. Do you see what I'm saying? But what if that's not true? Or do we have enough data to counter that? What if the picture you're seeing is just a part of the cancer and the cancer could actually be in a variety of other locations and you're just getting way too excited, Dr. Kwan, about your picture test because you came up with choline, now there's PSMA, now there's MRI, and you're just getting way too excited about imaging tests and what they tell you. What do you say about that?
Yeah, and I agree. I mean, there are times where we don't know. So when we see a profile of disease on some form of imaging, you never know if you're seeing the entirety of the disease or if you're just seeing the tip of the iceberg, right?
Exactly.
So you just never know. So you have to counsel a patient, and we have certain parameters that make us feel better and certain parameters that make us feel worse. If a guy walks in and he has a PSA of 0.35, tiny PSA, and he has a history of Gleason 7 prostate cancer, well-behaved stuff, and the recurrence is this big, and it really hasn't been changing that dramatically over time recently, then a lot of times we'll say, well, that might be the entirety of your disease. Let's see, let's kill it. And then let's watch, okay?
Okay.
However, if you have a guy that walks in the door, and this is going on all over the place now, ever since we talked about oligometastatic disease and treatment and all that, a guy walks in, he's got, two little spots you can barely see on the PET scan. He's got a history of Gleason 10, and he's got a PSA of 15. There is no way that those two little spots represent the entirety of his prostate cancer. And you know that if you treat those two little spots, that guy's going to walk back in the office in 3 months and he's going to be filled with metastatic disease. So, there's a number of things that we try to consider in aggregate to make the right decision regarding management. And that's why this is a specialty. This is a specialty.
Fair enough. Fair enough. What the extension of what I just said, and again, even though we're friends, I got to make sure that everything's on the up and up here. Like I'm coming to see you, and this is how I would act. What you kind of imply in your talk is that you like to use these imaging tests. And so, especially when it comes to relapse, you have to admit, I think one of the most interesting things that I've seen and I deal with and I've heard is that people are looking for relapse everywhere with the PSMA, for example, and then they do an MRI and they realize that the relapse is in the bladder, so that the PSMA had a halo effect and it obscured the ability to see the tumor in the bladder. So what I'm starting to hear from you and others is that everyone, Dr. Kwan, should get a PSMA or a PET CT and an MRI, ideally, to find relapse. It seems the more and more I'm moderating, the more and more some of the top gurus, I'm placing you as a top guru, more and more the top gurus are saying, you know what, ideally, I'd love to have not only a PET CT, but an MRI if I think there's relapse. Is that how you feel?
Absolutely. There's no question. So, everyone has to remember that all of these imaging devices have blind spots. A choline PET scan has a blind spot for certain forms of disease. A PSMA PET scan has a blind spot for certain forms of the disease and certain locations, such as the bladder. An MRI is the best way to look inside the liver, and neither PSMA PET scan nor the choline PET scan is good for looking inside the liver. An MRI is excellent for looking inside the bladder. C11 choline can see it sometimes, PSMA cannot see it. So one of our uniform policies is that we do vary our imaging and we do try to get different angles of view on the disease in order to know comprehensively what's going on with our patients.
When you do those scans, in my brain, I'm thinking that you always want to correlate data with data. And maybe I'm wrong. What that means is that I find that a lot of people go around the country and world and they get a scan done, but they don't know what their PSA was when they got the scan done. Don't you ideally want to know, for example, the PSA right around the time anyone gets a scan of any kind to correlate the data points?
Yeah, there's no question. Yeah, for a number of reasons, people cherry pick testing.
Yeah.
And then you end up with the testing, but it's taken out of context of what's going on. And so, our standard order set is, PSA, testosterone, alkaline phosphatase, liver function tests, and a PET scan, and plus or minus MRI on the day of the visit. On the day of the visit.
Interesting.
Another place that you see this mistake being made a lot is that a guy you'll say, well, this guy has one spot on the PSMA PET scan, and his PSA on the day you found it was 2. And then you send your patient to the radiation guys who, for whatever reason, they can't get the guy into their office for 3 months. And then they treat him that day without repeating the PSA. So then you check the PSA after they've been treated, and it's 3. And you say, oh my God, this is failing. But it's not failing, because what happened in the interim is the PSA went up on the day of treatment, and you didn't know about it. So there's a lot of this kind of, I think, evaluation sloppiness that happens in the medical field. And it always occurs under the auspices of, well, insurance won't permit it, or we're trying to save money, or whatever. But what people don't realize is by being sloppy or by skipping things or cutting corners, ultimately things become more expensive because you have to sort through it,
Yeah. Yeah, that's well said. That's well said. I talked to a guy not that long ago. I have a lot of friends out there. His PSA had always been between 1 and 1.5. He got diagnosed. Anyway, long story short, he gets SBRT, and then the note said, all right, PSA's already dropped from almost 3 to back to 1.5. And I thought, what? He's never had a PSA more than 1.5. Turns out the day before he got his radiation, the radiation oncologist pulled the PSA and he had a jump. He had a jump in his PSA. Had he not pulled that PSA at that time, like I say, of the image, or when you're about to be treated, you're missing out on an important piece of data. However, as your friend, I'm going to once again play devil's advocate. Here we go. Okay, so I hear what you're saying. You're convincing me. This sounds great, but who pays for all this stuff, Dr. Kwan? If you want me to get an MRI, you want me to get a PSMA PET or a choline, you want me to get all these imaging tests and these tests, are you finding that insurance or this gets covered? Or are you finding that the patients get whacked with a huge bill?
Our patients get it covered by insurance at the Mayo Clinic.
So then you're saying Mayo's great, but Mayo's synonymous with 2 things: great medicine and something I put on my Reuben sandwich, right? So what I'm trying to say is, if you're saying Mayo can get it covered, a really good center or a really good practice should be able to get these covered even if they don't go to Mayo. Is that what you're saying?
Yes, and I also think that there's a certain amount of nihilism out there with regards to imaging. So if you say, well, the patient wants a PET scan and I don't fully agree with it, guess what? It ain't going to get covered. If you say, well, it's imperative that this patient receive PSA or receive PET imaging because he's got cancer at a site that's not yet disclosed, and that his entire outcome for therapy, which it could include tons of radiation, tons of hormone therapy, whatnot, are going to be contingent upon finding that spot, well, likelihood is that you're going to get your scan approved. Okay. This is where, once again, there's a difference in terms of the art versus the reflective practice of dealing with relapse. Personally, I feel that a lot of patients, when they go to see their physician with relapse, they're not treated well because they represent some kind of failure or nuisance in the eyes of the doctors. That's why this requires some thoughtful process to
Yeah.
really sit down and say, this is the story, this is what you're dealing with, and this is why it's important.
Yeah, I think that's a good point. What we've learned is many of the insurances, when challenged, even when they reject it, when challenged correctly and and with some thought and data and the backing of the practice, a lot of them get overturned. That's part of one of the videos that your team gave, one of the videos that was another part of that PCRI gave and Alex gave. People need to watch how to challenge insurance. They need to watch those videos. I mean, that's a whole world in and of itself. Anyway,
But I don't think it's all insurance. I mean, I think
no.
it's physicians too. I think that physicians, I do think that there are physicians that you don't need no imaging. You don't need
Yeah.
no, you just take these pills. That's it. And that's not the way to do this.
Yeah, but I hear you saying, but you need your teammates to help get you there to win the national championship, just like Michigan, right? They needed all 5 players. Sorry.
Well, number one, I don't have personal friends like you, so I don't have to worry about that. I never went to a school that has a sports team that, the headline at Grinnell College in my alumni magazine was Grinnell wins its first football game in 1,000 days.
I know. I know. I feel bad for you at Mayo Clinic that you don't have a football team or basketball. But if you did, you would lose every game. But I told you this when we were first friends. I think Mayo should have a new mascot. It should be the calculator, or it should be the Mac computer or something. That's just my suggestion. Okay, I'm going to ask you a question that has to go back to imaging. And this is a little bit left fieldish, but we never talk about it, so I want to know what you think. When you deal with the relapse, this is a two-part question before I go to the weirder question. What we're dealing with a lot is you see these PSAs that were always sort of flat. It could be after a prostatectomy, undetectable. It could be even a 0.009. Some of these will hold at 0.01, and then suddenly after 10 years they'll start to move, and they're getting closer to 0.1, but they're not quite there. Well, that's a large change, and so some people are opting for imaging before waiting for the traditional 0.2 or a higher value. My argument, and tell me if I'm wrong or not, right, some of these people that are pushing for imaging earlier as they see their PSA move, even though it's not within guidelines, I think the one benefit is that if there's something there, that you win potentially. If there's something that they don't find anything there, you win potentially. Don't you think it's better for all these people trying to get their scans and images done earlier, despite the false positives and all this? Don't you think it's better to sometimes just get it earlier in the PSA rise than wait for these larger values? I'm talking about as your initial PET CT scan.
Yeah, I don't think we just published one of our papers just came out recently. 12% of patients that have a PSA of 0 will have metastatic disease. Okay, 12%. And that's for PSMA PET. 12% of patients that have an undetectable PSA will have a positive C11 choline PET. And I happen to know that those two populations don't overlap. So in the ideal world where, everyone gets everything covered all the time, isn't there a movie like that, won an Academy Award? Everywhere, every place, at any rate, if it were available to everyone, I would get the PET ASAP to start with as a baseline. Because if you have a baseline PSA or baseline PET, at least you know what's changing. Because sometimes it's just not binary,
I know.
And
so
sometimes we do, several of the cases I presented, PSA of 0.17, PSA of 0.14, PSA of 0.12. You can see things. So sure.
Yeah. So what you're implying is someone had a flat 0.02 for years and years after a radical. Suddenly over the next year, they get almost up to 0.1. They're getting nervous. Give me a scan. Someone that had radiation, they're hanging out at say 0.7 forever. And suddenly now they're at 1.7. So they're going to ask for a scan. People are going to ask for it. I see the downside is fighting with insurance, and I see the downside is some false positive. But I think what you're saying is that the upside exceeds the downside in those cases.
I think that you're going to pick off disease. And I think you're going to see it. And I think that for patients, especially that are very nervous that something might be happening, it's reasonable. And again, context means a lot. If a guy has a Gleason 10 that didn't produce much PSA to start with, well, hell yes, I would get the PET scan immediately.
Yeah.
For a guy that, is not making much PSA, even that little increment could be a huge change for them. Yep.
Yeah. Okay, here's my left field question. Ready? You're not going to believe I'm throwing this at you. I apologize.
University of Michigan.
This leads me to two questions. Have you ever used a liquid biopsy on a patient with relapse? So you can explain what liquid biopsy is. I know you use them, but have you ever just sought more data and took 2 tubes of blood looking for some cell-free DNA, looking for a mutation, just looking for something in the blood of somebody that's showing up in the scan, metastatic disease or not, or you can't find it and the PSA is going higher and higher? Do you ever lean on liquid biopsy for relapse, or is that just a silly thought?
I think that that's going to be a conversation down the road.
Okay.
We have a huge experience with liquid biopsies. I personally don't think that they're there yet for finding disease that you cannot visualize. I think that if you get a liquid biopsy, you're going to possibly get some readouts that are not very informative or very useful. And I don't think that the sensitivity of this is kind of like circulating tumor cells or whatever, CTCs or whatever. I just don't think that these tests are quite there where they provide the information that you might be looking for to find occult metastases.
So it's more of an exception rather than a rule for you.
Yeah.
Okay. Here's something else you said that's interesting, and I jumped all over it. Dr. Kwan says, keep your radiation plan, the plan that for your personal records, right? And I put, this is rhetorical, I'm sorry. I put, does that include a personal CD copy of your PET CT scan and images, plus the formal report for a second opinion? So,
yes.
So can you explain this? And I'll give you an example of a situation that I had to deal with recently. So can you explain why you say this? And then I'll give you my thought.
So it's really, we see it, like I said, we have a lot of patients that we see that have relapsed either after radiation therapy or prostatectomy followed by radiation. And whenever I have to come up with a strategy to treat these patients, the question rises up, well, what did they irradiate before and how much? And the problem there is that if you don't have the records and if you don't know what was done before, you cannot come up with a plan to treat them moving forward. So our radiation guys, who are outstanding, I mean, it's unbelievable what our radiation guys can treat, but they always have to, send their moles out to find the old plan, to figure out how much radiation the person received. And the really rotten part of this is some centers are very poor at keeping records.
Yeah.
So then you have patients that come in and their centers either don't exist or they've gone out of business or that doctor is retired and you don't know what's been irradiated and what hasn't been irradiated. And because of that, the patient may not be treatable because you don't know what happened in the past. And the other reason that I say this is something that I woke up to because it was explained to me by, Dr. Stish, Dr. Phillips, Dr. Davis at our institution. I was actually shocked at how much variation there is from doctor to doctor to doctor on radiation. So even if Dr. Stish or Dr. Phillips tells their best friend at University of Michigan or University of Rochester or UCLA or UCSF, I want you to treat this area this way, it doesn't necessarily get treated that way. And you have to have the plan. You have to have the records. A lot of times these these patients see us and they say, well, can I get my radiation locally? I say, no, get it here because I know what these guys are doing. The minute you step out the door, you don't know exactly what's going to happen unless you have the record in front of you. So there's a lot of variation. There's a lot of variation in terms of, and same with surgery, even within our corridor here, different surgeons do the surgeries different ways. So basically, I think it's very important. I actually, I said that the original talk was 360 slides. I had a list of all of the reasons why you have to have the plan, and I had a list of all of the reasons you should get the surgical reports and the pathology reports, because these are the things you need to look for. But the talk went long, but it's a very important thing to get those records for your files.
I've talked to a few friends. I would like to throw in the word friends. These are no names. Went and got, these are situations where they went recently around the United States. They got a PET CT done and there was something on it. And the people reading it don't have the experience of someone who's read 10,000 or 20,000 scans. Anyway, the point was, and it shocked me, that they said, well, then they wanted a second opinion on it, or they wanted another doctor at an institution to see it. And they said, well, we'll get it out there in the next several weeks. And they didn't know that when they were there, it's their right under the HIPAA privacy rule. It's their right when they're there to request a CD copy of themselves, of their imaging. So in these cases, they took the CD copy that they got within 24 hours, FedExed it to another opinion, and got an opinion. Sometimes it was a false positive, sometimes a false negative, but they got this expert second opinion within a week because they got a copy of their own disc right after the image was done. So the reason that I loved what you said is that I'm sorry I'm creating a lot of work out there, but I like the idea of they're going to make a bunch of CDs and they're going to send them out. They should make a copy for you and you should take 2 or 3 or whatnot, just in case you have to take the ball and then send that out to the next opinion faster. So anyway, the take-home message is always request the record, always request the CD, because you may be the person that has to get it out to the second opinion very quickly.
Second opinion pathology, same deal.
Yeah.
A lot of times you got to read, you got to get it verified by the experts. The PET imaging, a lot of times, it's worthwhile to get a second opinion at Mayo, because sometimes the scans are faulty, sometimes they're misread, misinterpreted. There's a whole host of reasons that you need to get read. Sometimes I would say that, one of the most common things is a lot of times we'll get outside PET scans or whatnot, and, it's 85% correct, but 85% is not going to cut it when you have to treat a guy for relapse. You have to see all the spots. You have to know what's going on. So, and, I don't want to make it sound like, well, first of all, HIPAA is about protecting patients' privacy.
Yeah.
It's not anything that's done to a patient, anything that's handled medically, it's their right to own it all. It's them.
That's right. That's exactly the point.
So I've been talking to PCRI for 15 years now. And if there's one thing that I've been consistent about every single time is patients have to advocate for themselves, period.
Yeah.
You cannot rely upon anyone else. You can't rely on the secretary. You can't rely on the quant team necessarily, even though I think we're excellent at what we do. You have to own it.
Yeah.
You have to own it. You have to ask the right questions. You have to have your data in front of you. You have to have the information. You have to curate it. And and a lot of our patients actually walk in with folders, radiology, pathology, surgical report, everything in folders. And it accrues over time so they can tell you exactly what's happened. And that's the right way to do it.
Remember you talked about pelvic anatomy? You know what question I've never asked you about pelvic anatomy slide? Hey, just by the way, do you believe the spread of cancer is like a pebble dropped in a pond? You drop a pedal, you can see how tired I'm getting. You
Skipping
drop,
stone.
you,
Skipping stone is the answer.
well, no, but so I'm saying when you drop a pebble in a pond, you see it kind of spread. So it goes from prostate, it goes outside the prostate,
No.
goes.
So that's the Halstedian. That's a Halstedian model for cancer spread, which is it starts locally and then it spreads out. That is not the way that prostate cancer spreads.
So tell me how prostate cancer spreads then if it doesn't spread that way. Is it
It's
you're
it's
saying
a
it can skip areas?
it's stochastic. It can go anywhere at any time, and it can show up anywhere at any time.
But how's it moving from point A to point B? It has to move through the
So
geography.
the way I think of this is I think of Mark Moyad, and you throw him into the river, a raging river with rapids, and where is he going to wash up? He could wash up just 100 yards downstream, or he could survive and wash up 5 miles downstream. Cancer cells spread, and it's not simply that they spread to point A, then to point B, then point C. They have to spread, land, survive, multiply, then throw out additional. Sometimes when a cancer cell is released into the bloodstream or into the lymphatics or whatever, it does not have the tools to be happy in the pelvic lymph nodes. But if it floats around and hits a bone spot, it's going to be happy. Likewise, another cell may not like the bone, it might like a lymph node. So the bottom line is that cancer spreads in a stochastic fashion, and it's not systematic. It's not stepwise like the pebble in the water.
Yeah, that's sort of a hybrid. I think that's a good way of putting it. So it uses the highways and byways, but where it pulls off in the rest area and reveals itself could be anywhere. I want to make a point off a paper. A lot of papers I've always kind of focused on. Very few people have really studied pelvic anatomy and lymph node number. And one of the best papers that I saw was actually done in China. It was actually done in cadavers. Anyway, the point was they did an extensive lymph node dissection in males, and they found out that the number varied in the pelvic areas from as little as 20 to 24 to as high as 60. And so I don't know if you had a comment on that. When you talked about lymph nodes, nobody ever talks about the fact that they're also very individualized. I mean, you're supposed to have a certain number, but some people have a lot more than others. So
yeah, so there's two sources of variability on the lymph node dissection. One is surgeons' preferences. So some surgeons don't like doing pelvic lymph node dissections. On the other hand, back many years ago when I used to do prostatectomies, it is striking because you can have a patient that has a lot of tissue packets or areas of lymph nodes, and then you can have other patients that it's barren, it's empty. And I think that maybe it has to do with kind of how much fatty tissue is down there and how much other tissues are down there. So I think that the lymph nodes a lot of times are there, but they are so microscopic that they're incidental. But then when they become pathologic, they become more evident, or when they become inflamed. But there is a huge amount of variation, a huge amount.
Exactly. And I think
it's really interesting also because you can have patients that have had very excellent pelvic lymph node dissections, but they still manage to have pelvic lymph node recurrence of disease. So you sit there and you go, I thought I stripped out that whole area, and look, something grew back. So there are a lot of things we don't fully understand, but the bottom line is that there's variation,
Yeah, exactly. Because, some surgeons will do pelvic lymph node dissection, take, 7 on this side, 8 on that side, and you go, ooh, that's a lot. Not knowing that, you could have 40 or more individually. So such individual variation. But I'm glad you made that comment. The next thing we jump to is the Phoenix definition, which you love talking about. I'm just gonna tell you my take on it. And this Phoenix definition of when you've been radiated, what's a magical PSA number above your nadir? Now, remember, nadir is the lowest point that your PSA reaches, right, after treatment, right? Not as in immediately after treatment. I'm saying that after you're treated, what's the lowest your PSA becomes? Nadir is actually an Arabic word that comes from meaning basically the opposite of the zenith. So I thought you would find that interesting. So we've kind of taken that word, and nadir is supposed to be something that is very low, and that's the thing you hold on to. So what Phoenix did in the 1990s, we used to say 3 consecutive PSA rises, and they said, no, no, no. Then in 2006, they met in Phoenix. Gee, I wonder where they got the name. They met in Phoenix, and then they said, that was Roach's paper, and he's going to be speaking in the fall. He said a PSA rise by 2 nanogram mil or more above the nadir PSA. But here's my take home from where we are with that. Not only do I agree with you that the game has changed with imaging, but depending on the technology you're using, you need to talk to the experts in the field for what that Phoenix definition really means. So what I mean by that is lately there's a couple big groups doing SBRT, and they're finding lower nadirs than EBRT, and they're finding a lot of bounces, a lot more bounces. So they're coming up with papers from other institutions around the world saying that the Phoenix definition holds some accountability, but there might be too many false positives. So it might have more probability of being accurate 18 or plus more months after you're treated. So the take-home message for nadir, like after radical prostatectomy, we're saying 0.2 or higher. And now there's this Stuttgart definition that is 1.2 or higher after HIFU. Now, it's not universal, but it's trying to be accepted. All I'm trying to tell the audience, and I'll let you have the last word, is this Phoenix definition is okay, but you have to sit down with the expert who's done your treatment and say, well, what's the equivalent of that for me, whether I've had a radical, whether I have SBRT, whether I've had HIFU, because it's not universal amongst all treatments, including that of one type of radiation. Does that help, or did I confuse everybody in the audience?
It's a cluster.
It's a cluster. You can't add the second word. The point is, you need to sit down with your treatment people, your treatment team, and say, how much value should I put in this PSA, meaning relapse? And you have to have the discussion of PSA bounces after radiation. There's a lot of them, especially after SBRT.
Sure, I agree with that. I think that the fact of the matter is, the field is being bombarded with all kinds of technologies, and the definitions are evolving. Yes. And I think that interpretations are changing, and these interpretations are changing based on where practices are located. Are they in Europe? Are they in the United States? There's a whole bunch of stuff going on. So if you really try to wrap your mind around it, I think it's very difficult. I tried to stick with generalities to keep it simple, because I don't think that a normal patient can tackle this without using a Cray computer,
Yeah, but you don't want someone just hugging that Phoenix definition and going, this is binary, this is the end all be all of what it means to have a relapse, without understanding the nuances and having that discussion with their team.
I'm more focused on trying to convey the message that you got to keep your eye on the ball.
Yeah.
You can't just sit there and have a physician tell you, oh, well, you fall under the threshold for relapse based on the Phoenix criteria. Ergo, you shouldn't worry about your prostate cancer. You have to follow up your prostate cancer, and you have to watch the trends.
That's right. That's right. So in this comprehensive paper done by all these different institutions, they were finding a 30% false positive rate, just for example, using SBRT with that definition. And so they've tried to hone it and make it a little bit better and add certain parameters, which you could talk about with your team. So just because a PSA rise happens after radiation doesn't mean relapse. It could be a bounce that eventually comes down again. So I don't know.
But the reason it's so complex, once again, is because every physician treats every patient differently. So some of them will use a little bit of hormone therapy. Some of them will use a higher dose on stereotactic treatment. Some people will treat part of the seminal vesicle. Some will not treat it. What I tried to explain in the talk is everyone's treated differently and everyone treats differently. And when you are following things in general, you want your PSA to stay low.
That's right.
And not rise. Okay, that's simple.
By the way, guess where the Stuttgart definition for HIFU came in terms of 1.2 and higher after treatment? Guess where the Stuttgart definition came from?
Jersey?
Alex was talking about this beforehand. I was talking. I said, no one talk anymore. I'm so excited. I actually made these signs a while ago. Okay, so you have a couple of references that talks about waiting to see on the image where your cancer is before you hit it, suggesting that may be a better approach. So you used a bunch of references on your slides, which I pulled. The one reference that I thought was most compelling was the one from Denmark, where they said by using the PET-CT, it not only, and waiting till you see it, not only was it helpful against the cancer, it improved overall survival. Overall survival, okay? So that led me to make a new sign for you that I have never shown before, and you should talk about it. Dr. Kwan references PSMA PET-CT showed improved survival. Can you comment on the fact that it is a fact today that when you get a PSMA PET, you can comment on choline, you're basically getting a full body scan that in some cases can be accurate. Look, it can pick up at the bladder. It can pick up at the brain. These are papers that I looked at across the board. Breast, colorectal, esophageal. These were case studies. Gastric, kidney, liver, lung, lymphoma, pancreatic, thyroid, and others. So can you mention the fact that the other thing about the PET-CT today, unlike a few years ago with bone scans and these other things, is that you're not just looking, in some cases, it's picking up other adenocarcinomas or other cancers in other places that have helped people get a cancer or find a cancer early that could be very aggressive. Can you comment on the fact that I now believe that a PET-CT scan comes with catches, but it also comes with pros? It may be, for some people, a very good full body scan, a more accurate full body scan. What say you?
PSMA PET scan can definitely pick up other malignancies. We don't know all of the other malignancies that will show up. Definitely some of those will show up.
Yes.
C11 choline PET scan, we had already compiled probably 30 malignancies that show up on C11 choline PET scan. In terms of full body scan, so it depends on what your definition of full body. So we do have patients that have metastatic disease on the tip of their head or down lower by their knees or below, that the disease is cut off because they only scan you from mid-forehead to mid-thigh. So it's not full body scan in the sense of it shows your entire body, but where I've always liked PET, and this is where people have always poo-pooed or minimized it, and I don't know why. It shows soft tissue and bone. It shows organs and it shows virtually everything. And the reason that's important is because the people that are oftentimes arguing against the PET scan are saying, no, you just use a bone scan. And you go, what the heck? A bone scan just looks at bone. Yeah. But that's what we use in our clinical study, and it's only showing bone. So a PET scan will image everything in its field from your forehead down to mid-thigh. And if you request, you can actually get the PET scan to be done. When I put the request in here at Mayo Clinic and people laugh at me, I say from the top of the head to the tippy toes. And that way you get everything on the scan. And that's soft tissues, muscles, tendons, bones, organs, inside and out, top to bottom.
That's the point. It's an all-in-one scan. It doesn't mean it's perfect at those other sites. Like you said, it can pick up cancer in other organs, right? It can pick up something going on in the bone, right? It can pick up something going on the lymph nodes, right? That's what I mean by full body.
And it can pick up things. So we published already. So the original JAMA article that talked about metastatic disease, rising PSA.
Yeah.
So rising PSA, first evidence of metastatic disease, the original papers, Scardino and all those guys, JAMA. 8 years from time of rising PSA to metastasis. Took 8 years using conventional imaging.
It's a classic paper.
With C11 choline PET scan, and we sent it to JAMA and they would not publish it. With a C11 choline PET scan, you can find your first metastasis within, on average, 1.5 years at a PSA of less than, 2. So there is a 7-year lead time advantage in terms of finding metastatic disease or finding recurrent disease using a PET scan compared to conventional imaging. 7 years.
Yeah, I mean, the downside is, I'm not going to talk about the downside today because we don't have time. The downside are some false positives. However, you have to admit,
conventional imaging has false positives.
No, that's true.
Much more than PET scan. More.
I was supposed to get a reaction out of you. I was moving into another topic.
Yeah, well,
No, but what I'm telling you is that if you have a patient, think about it. Now, I want you to think about the nerdy move that I just did, how I have no life. I went back into all the literature so far on the PET CT, including choline, including PSMA. You can even talk about fluciclovine. Anyway, I went through the literature because I have no life, and they are picking up cases. These are the ones that I went through: bladder, brain, breast, colorectal, esophageal, gastric, kidney. I'm not saying it's perfect for these, but incidentally, they were picking up some serious disease and cancers in all these other locations. So that culminates in, if you give someone a PET CT and everything else looks clean and you're comfortable that you're going after the prostate cancer, but everything else, all the organs look clean, do you actually have that discussion with the patient and say, hey, by the way, this is what Moyad calls a full body scan? I know you don't say that's what Moyad says, but this is what Moyad calls a full body scan. And by the way, whether it's, in the skeleton or in the liver or the spleen or the lungs, it's fully clean and you should feel good about that. Do you have that conversation after the scan?
If we treat a patient and we're talking about, where they're at with regards to their disease and their overall health, we do sometimes compliment patients for, oh, your scan's clean, which means that, because that's talking about cancer. We see many other things. Yes. You see inflammatory disease in the lungs. You see inflammatory disease in the abdomen. You see a myriad of other things which, are sometimes worth commenting on. But yeah, I mean, if a patient has a clean scan, we'll comment on it, but you have to be careful.
Yes.
So there are forms of malignancy that can, especially in the liver, you can get burned. And the other thing that people don't recognize is that, we're talking in the context of PSMA positive, there's a lot of malignancies that don't express PSMA on them.
Absolutely.
So just because you don't see something on a scan doesn't mean that something bad isn't happening in that patient.
Yeah, no, it's not foolproof. I'm just saying it's not the shot, but at least it's a snapshot.
So I have a question for you. So how on earth did they, when they scanned the patients for PSMA PET, how did they find breast cancer in women?
You can find breast cancer in a man.
Okay, there you go.
No, I'm saying, I'm just saying that I had a friend who was 83. Yep. I was a friend who was 83 and they thought he might have recurrence. And he actually used your terminology. He said that he had a Gleason, 9 all throughout. Anyway, long story short, he heard the word you said on a PCRI lecture. We said, sometimes you have a smoldering cancer. It's hanging out. It's still there. And so everyone was kind of delaying his PET CT. And he said, you know what? To hell with this. I'm just going to get it. Anyway, PET CT was fine. And the rest of his organs and bones and everything else it could pick up from head to toe as a snapshot seemed perfectly fine. And the physician met with him and said, wow, you're in your 80s and the rest of you looks great. This is not an end all be all foolproof. And I thought to myself, yeah, he's right. The rest of the scan looks pretty amazing for someone in their 80s. It looks really, really healthy. It doesn't mean that you've got a free card and nothing's going to go wrong. It just means that's the ancillary thing that goes on when you get this scan that you should talk to your doctor about because you got the scan anyway. All right. You have developed quite a name lately for actinium. I'm not going to say why. I'm just going to say that lutetium's great, but actinium's going through phase 3 trials right now. There's 2 companies right now moving toward phase 3, looking at castrate-resistant prostate cancer and giving actinium. And they're giving it to some people who have failed Pluvicto or lutetium also. And there's a lot of buzz around actinium potentially getting approved in the United States in the next few years. How do you feel about that buzz? Do you think it's appropriate, or do you think this is just all flair and no fudge, we used to say?
Well, I think that actinium definitely is a very powerful agent, and I think that for some patients it's highly beneficial. I mean, we have patients that failed lutetium and they have responded to actinium, and they've gotten durable and kind of meaningful responses from therapy. But just like any new technology or any form of therapy, there's an upside and a downside, and some of it we haven't even yet figured out. I have had a lot of patients that were treated with actinium as many as 10 years ago now, and a lot of those patients developed sequelae of renal insufficiency because I think actinium as an alpha emitter does put a lot of radiation through the kidneys. And I think that the good news is the patients did very well to survive their prostate cancers after being treated with a dramatic response therapy. The bad news is that some of them developed renal insufficiency,
Yeah.
and for some of them, that's an agonal event.
Right.
So it's just like everything else, and this thing always boggles my mind. And I tell this to every patient that I get. You can have a patient that's failed 8 different things, and they can be down to their last treatment, and you can give it, and even if it's sometimes illogical, sometimes it'll work great. But then for a lot of patients, it won't work. So with actinium, I've only worked with it in the context of fairly severe disease. However, we have had some patients that have early disease that we have treated with it. And I think it's a very powerful agent. No doubt it's stronger than lutetium. I mean, I always talk about paint strippers. The average paint stripper can get the paint off, but if you're really struggling, get the actinium, get the
Yeah.
stronger stuff.
That's interesting. I'll tell you, as these trials launch, Novartis and others have this PSMA action and other trials. You know what I found most interesting before your talk? I found that as these trials launch, one of the exclusions of the trial was grade 2 or higher dry mouth. So if you're already going into the trial with pretty severe dry mouth that is affecting how your diet is handled, it was an exclusion. And so do you want to comment on just that dry mouth side effect? You see a lot of that, right?
Yeah, I have to be honest. I mean, I think that, my clinic sees such sick patients that we don't necessarily we're not necessarily super sensitive of all the side effects of all the therapies because our focus is basically keep our patient alive. But I do see a lot of patients that are receiving radioligand therapies that complain bitterly about the long-term consequences of dry mouth, loss of appetite, they don't enjoy their meals anymore and all of that. And I don't think it's inconsequential. I mean, I think that it's something that we're going to have to tackle or deal with as we move forward. Actinium definitely will be harder on salivary glands than lutetium.
Yeah. But it is moving along. It's moving. People are offering it. I don't know if you heard that. That's my dog. He's obviously back home. He wants to be in the video with you. He always wants to be in the video with you. Last 2. And then it's a softball question at the end. Immunotherapy. You used to be the king of immunotherapy. What happened here? So let me just tell you right now, let me just tell the audience, one of the big immunotherapies out there is Keytruda. It's now approved for 18 different cancers, but not prostate. And now it comes in an injectable form, which is pretty interesting. So I pulled this from the company, and just bear with me a second. Here's where they have indications right now, FDA indications, immune therapy. Melanoma, non-small cell lung cancer, malignant pleural mesothelioma, head and neck squamous cell. Just hold on with me a second. This is impressive. Classical Hodgkin's, urothelial cancer, microsatellite stability, which we can talk about, esophageal, cervical, gastric, liver, biliary tract, Merkel cell, renal cell, endometrial, cutaneous squamous cell I could keep going. Triple negative breast cancer now, right? We didn't think it would work in breast cancer, but triple negative now, ovarian cancer, on and on and on. And you were the king of immune therapy, but we still don't have it in prostate. What is going on, Dr. Kwan, with immune therapy in prostate cancer? We have one out there, Provenge, but that's long ago. Why isn't there more getting approved in the area of prostate cancer?
So I started my career at NCI, NIH, and I had the great fortune of working with probably one of the greatest scientists of contemporary time, Dr. James Allison. No question about it. The guy was brilliant. And he's the one that came up with the idea of checkpoint blockade for the treatment of cancer. He's the one that discovered it. He won the Nobel Prize in part for that. And his first drug that he launched was ipilimumab, which is Yervoy.
Yervoy, yeah.
We started that work. I got to work with him on that back in about 1995. And my contribution to the conversation, aside from getting to carry his luggage and stuff like that, was that I thought that we should try it on prostate cancer, and I pursued that doggedly. And I introduced him to the American Urologic Association and to the Prostate Cancer Research Foundation at that time. And we had prostate cancer in our targets.
Yeah.
And I actually was the PI of one of the trials that got published, one of the first trials of ipilimumab,
Principal investigator.
Yeah, BMS 043 for the treatment of advanced prostate cancer. And we missed the approval point by a fraction of a percentage. And from that point on, every subsequent immunotherapy trial got worse. The outcomes were worse. We could not get any of these things approved for a treatment of cancer. I was involved in the discovery, partially involved in the discovery of Keytruda and of Opdivo. And Jim Allison continued his work with ipilimumab, and we tried to combine these things, nivolumab with ipilimumab, and all of these agents, and they've been tested in various combinations for prostate cancer. And all of the trials are falling short of the point that you need to get approval. Having said that, I've had great opportunity to reflect on this. And I've been watching my clinic very carefully. And what I discovered, I shared this with you last night. Back a couple years ago, we started getting Guardant 360 tests, liquid biopsies for genetics on patients. And one of the readouts on the genetic testing is something called tumor mutation burden. Tumor mutation burden. So in lay language, tumor mutation burden is a readout of how many mutations are present in a cancer cell. So I'd sit there and I'd look at these things, and I noticed the more we treat a prostate cancer patient, the higher that number started to go.
Yeah.
And I sat there and I was thinking, isn't it weird? Because every time we treat someone and they fail therapy and they get another therapy and they fail that therapy, the mutation burden goes up. So then one day I was sitting here and it dawned on me, well, gee, I wonder if and I thought about all the clinical trials that were run. The intuition with the clinical trials was, let's do a clinical trial for really advanced disease. Oh, we failed. BMS 043 failed. And the reason it failed was because the guys were too sick. Let's move this trial to a healthier population. And then we ran a healthier population, BMS 095. We failed even worse.
Yeah, not sick
so
enough.
Actually, the mistake that I believe we made is that we should have been looking at sicker populations.
Yeah.
And the reason why is because as the patient gets sicker, their tumor mutation burden increases. In lay language, the immune system cannot recognize a cancer cell if it looks like a normal cell. But the more mutations it acquires, the more freaky it looks to the immune system, and then the immune system can sniff it out and kill the cancer cell. So then I went back to Garden and I said, show me all of the tumor mutation burdens for every single malignancy you have in the world and rank them. When a guy walks in the door or when a person walks in the door for cancer therapy, what is their tumor mutation burden? And the number one top mutation burden was melanoma, spontaneously. So what that told me, and then renal cell carcinoma, bladder carcinoma, everything. At the very, very bottom, garden variety breast cancer and garden variety prostate cancer. They were at the bottom. The tumor mutation burden of those malignancies, even under stage 4 conditions, metastatic conditions, is relatively mild. So the immune system cannot recognize those advanced forms of cancer until they've failed several therapies. The only difference or the only exception to that is if prostate cancer has MSI high status, microsatellite instability high status. Those patients do respond to immunotherapy. Patients with high mutation burden, exceptionally high, do respond to immunotherapy.
Yeah.
But I think in my heart, and this is unproven, this is just my speculation, and I'm old enough to have looked at this for a long time. My speculation is that the reason prostate cancer hasn't worked thus far is it doesn't acquire mutations at a rate fast enough like the other malignancies where it can signal to the body that it's a foreign predator that needs to be picked off by the immune system.
Yeah, no, I mean, that makes a lot of sense now. But just for the audience, there's a very small percentage of people that do have enough tumor mutation burdens when you do a liquid biopsy or MSI high. Both of those are indications under, for example, the FDA and Keytruda that regardless of the cancer type, indirectly, if you have prostate cancer and you exhibit those features, you can get the drug. And so you've seen some people get the drug who have those characteristics. So, do they respond?
So we always follow our patients, just like with PET scan. We also follow them with Gardens on their follow-up visits if they have recurrent disease. And we're always surveilling our patients for an increase in tumor mutation burden or the acquisition of certain targets, including MHI high or MSI high status. Yeah. And those patients, MSI high status, if a guy has MSI high status, he has a very high probability of responding to checkpoint inhibitor immunotherapy. The tumor mutation burden is more of a graded response. If it's a very high tumor mutation burden, there's a good chance, accompanied by, aggressive phenotypes such as small cell and so forth, they may respond to immunotherapy. But the bottom line is when our patients get a tumor mutation burden of 13 or more mutations per megabase DNA, if needed and if we run out of options for therapy, we can get immunotherapy approved for them.
Yeah, that falls in. Once you hit double-digit mutation per megabase, 10 or greater, you fall into the possibility of getting Keytruda. So there is that segment of the population. That's awesome. I appreciate that. Last two softballs. One's a softball, and the rest is I I'm looking for something profound at the end. I apologize for this question. I wasn't going to ask you. I don't know who I'm scared of. Maybe I'm scared of some people, but AI and prostate cancer. I put, sorry, I just had to ask or I would get in trouble. You know, we just get the question a lot, like AI this, AI that. So I just wanted you, I don't know if you have any general comment on AI.
I tried to tell the joke. So the thing that drives AI platforms is digital technology. Digital technology, and urologists are the innovators of digital technology. Digital rectal exam. Okay? So we invented all this stuff on AI. And everyone accuses us of being artificially intelligent. So we've been there for a long time. All right? Okay?
You got to keep your day job. So I'm going to leave this interview without
digital
you some grand
digital
comment on
technology, artificially intelligent.
Yeah,
we're there. We're there.
We're there.
I think that where artificial intelligence will really be helpful will be hopefully probably looking at PET scans for reading out what's going on with patients.
I agree with that.
For looking at pathology. I think that's going to be I'm kind of hoping that it might be also useful in terms of, we get a blood test, we look at the genetics, and then we sort through this kind of chafe or barrage of genetic information that we might be able to sort out adverse signals that indicate serious disease, not so serious, et cetera, et cetera, et cetera. I don't think that it's going to get to the point where someone comes in and says, here's my PSA and this is me and tell me I hope it doesn't go in that direction, because I think we already do a lot of that, where we just clump people into buckets and just say, this is what you need to do.
Okay. Do you want me to give you the last question that I was contemplating not asking you, but I thought you'd
digital rectal exam. Okay. Digital technology. It's right here. Okay. Just think about that. Try to feel it.
I feel it right now. Well, I felt it last time. That's for sure. Okay. For the audience, I hate to say this again. I think I've written almost 200 papers. I, for over 20 years, had to review a paper every month for doctors to listen to get credit. I just gave that up because I'm trying to slow down and retire from doing too much work. But I still see thousands of papers a month, I would say, because I'm still writing papers. I'm still teaching students. And I came across this paper on March 5th, and I don't know why I thought I need to know what you think of it. But that's what happened. And it was published in JAMA Oncology. And here's the basis of that paper. And I want to know how it applies to your thinking. And we have not rehearsed this. I've never brought this up with Dr. Kwan. Here's the new study from Richardson et al. And it was done with a variety of institutions from the University of North Carolina, Honolulu, Rochester. It was it still is very popular since its publication online March 5th. They looked at patients with tumor types, including solid tumors, and some of them were GU cancers. And they called them older patients if they were 75, 80 and above, whatever you want to use the word for older. Anyway, the take-home message, which surprised a lot of doctors, is that the older patients with advanced cancer, they wanted quality of life over survival when the question was actually posed to them in a session. It didn't mean that they didn't want it. It just meant that walking away from this analysis of this paper was this massive attention toward, look, I really want quality of life, and I'm not so sure we're getting it enough in cancer, but I want you to understand why this paper was published, because it was a way to scream quality of life is really something that patients of all ages, especially as we get older, they really want. And the argument was, we're missing out on that. We're not asking enough. And so I'm not asking you to comment on the paper. I'm asking you about, is that your experience, that when you sit down, there is a tremendous discussion of quality of life, or at least there should be, because you were talking about all these different drugs that are being offered, all these different things right up front. Maybe we're using too many too quickly, and they come with quality of life issues. they're great medications, but there has to be a quality of life discussion. So somewhere in my rambling, there is a question for you, but do you find that a study like that is reflective of your experience in your clinic?
I think that fundamentally, quality of life is a personal parameter that sometimes shifts with patients. I don't think you can just say, it's a binary thing. Here's
No.
you have quality of life, here you don't. We spend a lot of time with our patients, lots of time, a lot more than you would believe. And I feel that I have to read the room every time I go in the room, for whether the guy is 40 years old or whether the guy is 90 years old. And I have to tell you that I've had patients that are older that want to cling to life come hell or high water.
Yeah.
And I have other patients that say, well, this whole thing's getting ridiculous. I don't want to keep going. I think it's an individual decision. And I always tell my patients as much as possible that I'll hit it as hard as you want me to hit it for as long as you want me to hit it, but it's your word, not mine. And I have had patients that, we tell them that we hope we can help them and we hope that they can get better. But after a couple times seeing me, they say, well, Dr. Kwan, you're a disappointment. Your treatments are disappointments. You haven't got me there. I want to quit. And I'm fully respectful of that. At the same time, we have other patients that we're saying, I'm not sure we can give you something anymore because we're scared of what we're going to do to you. And the patient's demanding it. They're demanding it and they're offended if you don't offer it. If you could show me what quality of life means in 3 words and put it into a survey and then say that this metric has been met or has not been met, then I think that that paper has value. Mm-hmm. But I don't think the paper has value in the lives of normal human beings who are constantly faced with different kind of feelings about what's going on with their cancer and different side effects of their therapies and so forth and so on. I think it shifts. Yeah. I really do. And I think you just have to remain very fluid when you manage patients. Again, what I say to patients is, we'll do whatever you want. We'll try as hard as you want, but we'll give up also when you want. And when we run out of options, fully run out of options, we always have the conversation. I think we're at the end of the road,
Yeah. Well, I think you'd agree with the paper in the sense that the last sentence in the abstract was suggesting there's a possible lack. This is a quotation. It's a possible lack of responsiveness of the current oncology care delivery system to patient preference.
I think that hits the nail on the head. I don't think it's about quality of life. I think it's about respect.
Yeah, that's a good point.
I think that fundamentally, every human being, every patient I run into, at their core, they want to be respected. They want you to hear their complaints. They want you to hear about their symptoms. They want you to hear about their struggles and their fears. And I think the difference between a patient that has a good quality of life with their physician is that the physician's either listening or they're not listening to all of these different things. And so we have learned, sometimes the hard way, that patients have fears and things that you have to tease out of them. And you have to create a comfortable environment where they can speak their mind, share their fears, share their insecurities, talk about what their worries are, and get an honest answer of what the hell's going on. If you don't do that, I don't think that you're providing the kind of care that they want. And I'll tell you, that's my greatest fear over AI. AI ain't going to cover that. I think that the things that once made medicine great, the compassion, the sensitivity, the humanity of it, is being washed out by AI. Some of my patients are dying and they're just plain lonely. They haven't faced death and they haven't sat alone in that circumstance. And they want someone to listen. That's all they want. And I think that that's what we offer as physicians, or that's what we should offer. It's not about, did you do the robotic? Did you tie the knot that way? Did you do this? Did you try this agent? I mean, I have patients that walk into their doctor's office and the doctor says, well, your day's done. And it's almost like they're congratulating them that their life is over. That's all of the respect that the patient gets. The patients are shattered. If I knew that, I was walking in a room, someone's going to tell me I'm going to die tomorrow, I'd be scared as hell. I would be just horrified. And being horrified in a moment where, you got a young family, you got, it's just mind-boggling. And then to have the added insult of, well, I can't see you in my office for 3 months, and, oh, your insurance didn't pay for this and all that. I mean, I personally admire my patients because they're dignified, they're brave, they're courageous. Somehow they keep it together. I know for a fact that I would not be able to keep it together like my patients do. I would be oozing all over the office. I would be, a puddle on the floor. I would be disgraceful in terms of my manners and my attitudes if I had faced a lot of things that the patients face. So, I think that papers are fun to write, and, I think I get the point of what they're saying. I agree that you can't just keep, and, we're guilty of it too. We say, well, let's try radiation. And then nothing is worse than having a patient say, well, Dr. Kwan, I did everything that you told me to do and it didn't work. That's a horrible day for me. And it doesn't escape me that it's happened. I feel terrible about it. But, if I won every time, I'd probably be treated better than I am as a urologist, right?
Yeah. Yeah.
So I think that, but, I do think that the paper is basically saying that we as physicians should be more human and more sensitive to what's going on with our patients.
That's a better way of paraphrasing it than I did. But you can see how when I read it, I was excited to get your opinion of it, because I think there's a lot of agreement there when you kind of dig into it that we have to work on patient preference better, and quality of life is a big deal when it comes to prostate cancer. We know that. So you summarized it better than I could have. I'm going to leave it at that. And with that, I know you're probably still thinking, is he really going to send me a hat, a national championship hat? And the answer is, of course. I'm going to keep my end of the bargain, and you have to put that in your office. Otherwise, I would be devastated as a friend of yours that you didn't put that hat in your office.
I'll put it right next to my University of Indiana National Championship football hat. Okay?
Yeah, Big Ten. I love them. People forget. I get stuff from Ohio State fans. I love it. I get stuff from Indiana. See, I'm not one of those that gets just
Big Ten.
Big Ten. Yep. It's all Big Ten. It's all love. I mean, I want us to win, but if we can't win, I want them to win. Anyway, I thought I'd keep with the basketball theme. Total slam dunk. Thanks for being you. Gift is in the mail.
Thank you, Dr. Kwan, and thank you, Dr. Moyad. Now, another quick reminder, please subscribe to this YouTube channel or donate at pcri.org/donate. Those are two great ways to support what we do here at PCRI. We want to get more education like this for free to millions of prostate cancer patients all around the world. Now, the second thing I want to remind you about is you really should come to our in-person conference in September. Now, I know traveling is a lot, but I promise you, It is so worth it. You're not only going to have access to world-renowned experts where we do Q&As for patients, which is awesome because when do you get that many experts in one room to be able to ask questions to after each session? You can also meet the PCRI team, and we can remind you that you're not alone in this journey. And what really reminds you that you're not alone is there's hundreds of other prostate cancer patients there and their caregivers who have their own journey. And the greatest thing that they do is they share their story, and you can share yours too. And you can support other prostate cancer patients and give back to the prostate cancer patient community and to the caregivers who do such an incredible job serving the patients. And so we would just encourage you to come. It's only $30 and it's September 18th through the 20th. We have incredible speakers and you can see it at pcri.org/conference and sign up today. Now, this is the part of the conference that I really love, and I get to basically introduce two of my favorite people that I have served our prostate cancer community with for over 10 years. And what an honor it has been to serve alongside them. They have mentored me, and everything that you see on this channel is because of these two people. So, Dr. Mark Moyad, who's done an incredible job moderating this conference. I love that I love his sense of humor, but I also love the fact that he uses that to help us gain more information and kind of add some lightness to some very intense topics. So I really appreciate that. But I also appreciate just his breadth of knowledge. I mean, he was able to pull out so much from our speakers that had he not asked those questions and gone into those details, we would not know. So I really appreciate him, and most of all, his incredible heart for patients, because he has spent hundreds of volunteer hours on our conferences every year while he's doing his normal day job, which is really amazing. He trains the next generation of doctors. He writes papers. He writes books. I mean, he is just one of those rock stars that you're just like so grateful that you get to know. And I feel that way every day. And I'm very grateful that once again, he signed up with PCRI this year to just donate his time. So please give a shout out to Dr. Moyad because what he does is absolutely incredible. And then he's going to do this extended Q&A with our founder and executive director, Dr. Mark Scholz. Now, he is just somebody who I work with every day. And he, again, has a heart for patients. And he founded the PCRI over 30 years ago. This is our 30th year that we are celebrating the birth of PCRI and the fact that we got to serve our community for 30 years. And it's because of Dr. Scholz's dedication to this process, along with Dr. Mark Moyad. And so today they're going to do an extended Q&A, and they're going to do a recap of everything that we just heard from Dr. Epstein and Dr. Kwan. And without further ado, here is Dr. Mark Moyad and Dr. Mark Scholz.
Hey, here we go. It's my favorite time of the conference. Favorite time of the conference. Why? Because I get to my best friend in California, who I've known for about 50 years. We get to do an overview and we get to have some fun. How you doing?
Excellent. Beautiful morning here in sunny California.
Same in Michigan. I would say more beautiful in Michigan than anything that you've ever seen in California. So that's how
you guys get a real spring out there.
That's right. And behind me, you're going to see a major pop of everything in the leaves in a week. It's too bad, but we're loving life right now. So should we get going? Because I know we have limited time because you become so busy, you hardly have time for your best friend. So we should start when you want to start. And I think this was a fantastic conference because I'm biased. But I think we should start with Dr. Kwan, who is definitely my best friend at Mayo Clinic. And I think you have some thoughts. And how do you want to come out of the gate with Dr. Kwan besides saying, I don't know how he does it. I think he has the record for producing most slides. It's interesting. Every time I ask him to give us 100 slides, he gives me 250. So he comes really close. Every time I ask him to do a 1-hour talk, he does it for 2 hours. So he doesn't come close. But people don't seem to mind. They love him. So I stay out of his way because he's so good.
You know, what I really loved about it, Mark, is, he's a surgeon. He understands pelvic anatomy better than us internal medicine type docs. And he did a beautiful job of showing the complexity of all the things that are going on down in the male pelvis and how important it is. He emphasized that twice throughout the slide, that you need really quality experts if you're going to have someone come in there and fix something or unfix something or salvage something.
Yeah.
So that presentation was very elegant, and it's wonderful that people can start to see inside as to why are there so many different approaches? Why are there so many different opinions? And then you start mixing in the different patterns of relapse. You can have a relapse in the prostate area, in the pelvic lymph nodes, both other parts of the body. So I don't know what an ambitious undertaking to try and cover that whole field of relapse, which is so varied in such a short time period. He did a great job, and he made a number of insightful comments about this very challenging area.
Yeah, and he showed us just when you think you understand relapse, and if you've had surgery or radiation or whatnot for primary therapy, just where you think it's going to relapse, in many cases in studies it relapse in other places. So before we go into it, I asked him this, and I have never asked you this question. And I said, I like your pelvis anatomy slide. That's what I said, okay? I said, but do you think the spread of cancer is like a pebble dropped into a pond where it goes out like this from the center point? Or I said, or is it more like a skipping stone? And he immediately reacted and used the word stochastic. And I thought, wait, did he use the word sarcastic? I'm sarcastic. No, he meant stochastic. And the translating the origin of that word essentially means that there's almost a randomness to it. If you look at the original translation of the word stochastic, and he said, essentially, there's a randomness that sometimes you can explain and you can't, but otherwise it can go here, there, everywhere. How do you feel about what he said about that in terms of how cancer spreads, including prostate cancer?
Sure. So he presented a nice slide on that, showing that you can have a recurrence right where the prostate used to be, or in the prostate from inlet head radiation. You could have it in the region of the pelvic lymph nodes, and that probably is going to encompass about 2/3 to 3/4 of recurrences. But then there is a small subgroup of the skipping stone type that you allude to that can show up in another part of the body. The interesting thing in looking at Dr. Kwan, and I've often characterized Mayo Clinic with this in my mind, because we send people to see Dr. Kwan, and what an amazing resource for people who really are, in many cases, running out of options. And Mayo Clinic will come up with new options, and very talented people. Many of the examples of relapse, and many of them are run by very quickly in Dr. Kwan's slides, were of people who were really in serious trouble. And he even alluded to a case where there was no rise in PSA first, which is interesting. But in 35 years, personally, I've never seen a case without a rising PSA, and I've seen tens of thousands of cases. So the idea of these guys with these rather gruesome patterns of disease, to me, I was thinking, wow, how did these people get neglected so long? How did they get postponed so long before they showed up at Mayo Clinic? I think sometimes no one's watching the storyline, and or maybe not checking PSAs regularly. And then you do see really serious advanced cases like this if someone hasn't been minding the situation. But if you look at with modern PSA monitoring after relapse, the idea that the PSA has to rise a whole point or 2 points after radiation before you call it a relapse, that's an academic standard that is used at universities to try and get uniformity in description of what a relapse is. We would never allow someone's PSA to rise 1 or 2 whole points if they had previous radiation and their PSA peaks up a slight amount.
Yeah.
We get a scan, we get an MRI, we get a PET scan. This idea of waiting for the PSA to rise some huge threshold makes literally no sense at all. So I think that the idea of treating relapse and the complexity of it was really conveyed beautifully by Dr. Kwan. The idea that a relapse represents some Mount Everest of challenge that will create such demanding disasters, fistulas. I've seen like maybe one fistula in my career. Relapses in the prostate. These things are very rare when you solicit really quality, good care up front.
Well, what you're also implying is, okay, this is not just binary. So you're talking about PSA kinetics make a difference, right? And PSA variables. Can you talk about that a little bit? Because I do think that sometimes people get the message that, okay, if you've had surgery and you hit 0.2, then you've crossed the threshold. I understand that's a guideline. We have to have guidelines. They're helpful, but we don't worship the guidelines. They help us steer the ship. but they're not the end all be all of the destination of that ship, right? That's the art of medicine. So can you talk about PSA kinetics, in your opinion, whether it's doubling time, whether it's velocity, in terms of relapse and how it helps you?
In simplistic terms, if the PSA is taking more than a year to double, which we see patients like this, and you could say technically they have a cancer. But if you plot that over time, that patient's going to run into trouble with prostate cancer maybe in about 40 years. So the doubling is so slow.
Yeah.
Then you have people who have very brisk doubling times where the PSA is doubling in every 3 to 4 months. Those are two different types of cancer. PSA doubling time after surgery is a more accurate prognostic finding than Gleason score is. We spent a whole talk with Dr. Epstein on the importance of Gleason score. Wow, is that important? PSA doubling time is more important than Gleason score. So it's not only how much did it go up, but how quickly it goes up. And there's one thing, Dr. Kwan is emphasizing sort of a new thinking about, don't just go, blasting away with radiation at the pelvic region when you can't see anything on a scan. And I really like that he mentions that, because in my view, it's probably somewhere halfway between Dr. Kwan, who was sort of arguing that, don't ever treat anyone until you see it on a scan, whereas the industry is arguing, don't ever wait for a scan, always radiate everybody. Right. And I think the truth is somewhere in between those two, based on the PSA doubling time. If you have people with a more, let's say, I just saw a guy last week, 60-year-old, PSA doubling time of 3 months. PSA is up to 0.13. He had an ultra-sensitive PSA, so it went from 0.02 to 0.07. You could see a trend.
Yeah.
Obviously, the scans are clear, and this man is recovered pretty well after surgery. He's still getting erections. He's not leaking urine. So we sent him to some top flight radiation therapists. And of course, it said radiate where the prostate used to be. And they also said, consider adding some hormone therapy. It'll improve the cure rate about 10%. So this man, with the pattern of Gleason and everything he had a projected cure rate of radiation to the fossa alone of about 60 or 70%. And they know that if you add like 6 months of hormone treatment to that, it'll go up 10% more, maybe 70 to 80%. So we spent a lot of time talking. Do you want that extra 10% cure rate but do you want to pay the price of the side effects of hormone therapy to get it? Especially since you do have Dr. Kwan's plan as a backup. If the first go round doesn't succeed, you obviously the PSA would continue going up, and then you do keep getting scans regularly. And we're finding that some of these men, when you finally do see it, can be cured with spot radiation. So you're getting one chance to cure it with the radiation alone, and you're able to forego the hormone therapy up front. So this is quite a long discussion with this patient. He's a very intelligent man, and we went through the type of side effects that hormone therapy caused. Now, of course, with Orgovyx, we're getting pretty quick recoveries. If people will exercise rigorously, they'll do pretty good. And then the Orgovyx, it wears off quickly when it's done. So, and the other thing with Orgovyx is if you get into it for a month or two and you say, this is more than I bargained for, you could stop it early. You can jump ship. So this, I agree with Dr. Kwan. I detest the cookie cutter pervasive belief throughout the system where everyone gets radiation first. The PSA went up. No. What if someone's a little bit older? What if they have a very slow doubling time? Definitely watch them. But doesn't it sound kind of attractive, though, if this guy's got a 60, 70% chance of being out and out cured, never a new problem, and maybe 10, 15% chance of, a worsening erectile function, 10 to 15% chance of worsening urinary function. So that's one of the downsides of the radiation of the fossa. But getting cured is a thing of beauty. So to wait around to see where the spot's going to be, we know that the cure rates aren't going to be quite as good. That's been proven in studies. So you're a very dispassionate, objective observer in this whole thing, Mark. But that tension between those two different extremes, it's not black and white.
No, it's not. And the word PSA should really mean prostate-specific anxiety, right? Some people look at. I'm a wimp. Some people come in on a scale where it's high anxiety when things start to rise and rise early. That'd probably be me. Other people are more, yeah, I used to always say treatment should fit personality too, right? In terms of what you're doing. Before I move on with my other thought, please define what you mean by fossa. Of course, we know, but when you say we used radiation and we hit the fossa, what's the fossa?
Right. So when the prostate's been surgically removed, there's a virtual space. Dr. Kwan did a beautiful picture of a silver dollar talking about a flat space between the rectum and the bladder, which is normally, if I turn it sideways, would be filled by the prostate. And then after the prostate is surgically removed, that shrinks down. They pull the bladder down right to the urethra. And so that virtual space is what is targeted, because if people have a local recurrence after surgery, the surgeon doesn't quite get it all out, they can cover that with a radiation field in 3 dimensions. And like I said, this patient, his PSA was 0.13, doubling time 3 months. There's been thousands of men that have been through this. We know that 2/3 of them will get cured with zapping it with some radiation.
Yeah, so you take away the prostate, there's the fossa, right? And surgeons will often use the name. It's funny in my lifetime. Half the surgeons will use the name fossa. The other half will call it a prostate bed.
Yes.
So right. So I used to always say, well, here's the pillow. That's your prostate, right? Then you remove the pillow and you're left with the mattress, the bed, and that's the part where you can see recurrence. But you bring up something, we did not address this, and I have not asked you this. Okay, so you think PSA is important before we talk about imaging, PSA doubling time. Look at how much you emphasize PSA doubling time. But for all the people out there who are told you have to pick one or the other, which is an issue, or they're told you can pick, how do you feel about ultrasensitive PSA after surgery? Do you lean more toward you want to know an ultrasensitive PSA that can detect down to about 0.01? Or do you like to go with the regular PSA when someone consults you after surgery and is worried about recurrence? Do you want them to get a regular PSA that detects at 0.1? I've never asked you that. How do you feel about ultrasensitive? Because
I'll
tell you,
this is where it really shines, is after the surgery, because if someone's had radiation, the ultrasensitive PSA won't offer as much utility because there's a lot of background noise left over from the prostate gland. When the gland is removed and you're using an ultrasensitive PSA, you're going to detect a recurrence at a much lower and earlier level. And we know in the cancer world, getting stuff earlier is always advantageous. The other beauty of an ultrasensitive PSA is the detection of trends. Sometimes it's not so much the PSA itself, but if you look at a sequence of rising PSAs on a graph, that means that you're observing something that is growing. The signature of cancer is it grows. And so that signature can be seen. As I mentioned, this patient has a PSA 0.13. Well, there were like 5 data points that led up to 0.13, all in a straight line. I mean, this is guaranteed, even though the PSA is only 0.13, which is lower than the threshold of supposed recurrence, right? 0.2.
Right. 0.2.
100% sure this guy has some active prostate cancer. It's because of the sequence of multiple numbers lining up showing growth.
So this is what's happening now is, the relapse population is getting larger and larger with time, right? What you're seeing a lot of is 0.02, 0.03. They had surgery 10 or 15 years ago, and now it's 0.07. It's closing in on 0.1. But yet, if you look, you're supposed to get the scan. This is moving into the topic of imaging. Believe me, I'm steering you in the right direction, I think, in my mind. Okay, so there's so many of these guys. They're 0.05, 0.06. They've had surgery 10, 15 years ago. Now they're kind of hanging out at 0.07, 0.06. They're moving closer to that 0.1. And then they're told, well, we can't do a scan until 0.2. How do you feel about, in those cases, possibly doing a scan at 0.1 or doing it before 0.2? I mean, how do you juggle that?
Well, I think it's perfectly fine to get a scan. The yield on the scan is going to be very low. And then sometimes you'll get some pushback from some insurance companies, not Medicare, but some of the private insurance companies, and they won't pay for it.
Yeah.
But when people talk about hard cut points in dealing with the human body, you're going to be correct most of the time. But what about the exceptions to the rules? And there are people where you will detect things with PSAs of 0.1 or less. So the urgency to check for these things, especially in the example that you cite, is not that high because remember, the PSA doubling time is a more powerful predictor than Gleason's score is in terms of what the future is going to bring. And so someone that has a PSA of 0.1 or 0.2, 0.5 after 5-10 years after surgery, by definition, they have a slow doubling time or a slow growth rate. And so those people have the luxury of going very, very slow. I've got dozens and dozens of these patients who had surgery 5, 10, 15 years ago. And when you observe a doubling time that's very slow like that, take it to the bank. It's going to stay that way. It's not like other cancers. All of a sudden you wake up one morning and it's exploded or it's gone all over the body or this sort of thing. That doubling time is a very powerful indicator of what the future is going to bring.
What's a doubling time in those scenarios? There's a lot of men out there in those scenarios, but in all situations. But what's a doubling time that makes you a little more nervous that you might want to get a scan? Is it 12 months? Is it 15 months? Is it
12 and above is your kind of golden. Okay. That's great. You start going under 9 months down, and as you go progressively lower below 9 months, it gets more and more concerning.
That's interesting.
One of the reasons we're treating this patient with 0.13, 60 years old, is his doubling time is 3 to 4 months.
Okay.
So this is something that if it was left unchecked could be dead. This guy could be a statistic someday. So curing it, getting rid of it, is a gigantic upside, not only in terms of preserving his longevity, but also preserving his quality of life so that he doesn't have to be on hormone therapy the rest of his life. If this particular intervention isn't successful.
It's interesting you use the word 9 months because you and I know that the second generation anti-androgens have made a business. They've changed lives, but they made a business out of the 9 month doubling time and intervening when there's 9 month or less doubling time and possibly adding that. So that provides a lot. But the last thing I will say to this discussion, which is really positive because there's just by the nature of how many people have been treated over the past 15 years, this is not the common situation, but there's enough guys out there dealing with this. I'll tell you the final thing I want to add to that, and then we can move on to talk about PET scans and a little more about Quan, is there's always going to be what I call the COB, the COB scare. And I want you to address it. We've not talked about this, and if we have, I forgot it because I'm getting old. COB, the cat's out of the bag scare. Like if I wait, if I don't do something now. So let's take an example. Someone's at 0.08, 0.09. You're saying the doubling time is slow, but they're always hearing from another person, if we don't catch this early, then the cat's out of the bag. Then you've missed your chance for a cure. How do you address that?
That's such an important thing. It gives me pause because I want to do justice to this.
Yeah, no, I mean, take your time because I've never asked you. We never rehearse any of this. So
this is the essence of why the word cancer frightens us all. And we've all had family members and friends that something exploded with some type of cancer and now they're gone. I mean, this is a very, very this is something we intrinsically and subconsciously associate with the word cancer. The good news with prostate is that we have all kinds of remedial steps that can address and sometimes even cure people with metastatic disease. And this is as a result of these PSMA PET scans. Before we were really in the dark. If something was showing up on a CAT scan or bone scan, that meant you had spots all over your body. It was almost by definition. Well, not with the PET scans. You're finding now early spread. And I've got an ever elongating list of men that were treated back in 2017, 2018 with PSMA PET scans on an experimental basis who had metastatic sites and now are still in complete remission with recovered testosterone, i.e. cured, proven metastatic disease. So that is kind of cool. We don't want to rely on that and say, no problem. We'll always catch it later because we won't catch all of them. But some of them will. And this is very unexpected when you look at the larger cancer world. Pretty much metastasis equates with mortality. So this is different with prostate cancer for that reason. And also, of course, most people don't know that if people are put on hormone therapy, the average response time, when you give it at these early stages is like 15 to 18 years. So you can keep PSAs low it's an unpleasant treatment, but it does keep you alive. So the risk of metastasis, I don't want to minimize them. You always want to get rid of the primary before they occur.
Right.
But there are ways to determine with Gleason scores, with doubling times, whether metastasis are likely to occur or not. And you don't want to treat everyone like they're likely to have metastasis if they have a very low Gleason score and very low doubling time. This is a sensitive area of the pelvis. You go down there and start radiating and operating, you're going to potentially have permanent damage down there, and possibly unnecessarily with these very low-grade variants of prostate cancer. So there has to be distinctions made between these different things using Gleason score, PSA doubling time. And I want to mention one other thing too. Now that we've got men that are coming in and getting these PSMA PET scans at diagnosis, the idea is, well, oh, thank God, the PET scan doesn't show any Mets right now, so let's get it out while it's still curable. But let's work backwards and think through this a little bit. You can't show up in a doctor's office with a detectable prostate cancer unless it's been in your body for at least 5 years. It starts as a cell, and then it grows. And so when you get a PET scan showing no metastasis at diagnosis, let's say your PSA is 8 and your Gleason score is 7 or 8, something like this, and your PET scan shows no metastasis. That's telling you something perhaps even better than the Gleason score about the likelihood of metastasis. You and I both know there are people that come in with those numbers and they do have metastasis already. So there you've got, on the one hand, a guy that with a PET scan, proven biology of his cancer. It's not, we don't care if it's a Gleason 8, 9, or 10. It's already metastasized. We don't care what the Gleason score is. The Gleason score is to try and predict metastasis. This man already has metastasis.
Yeah.
That's proven 100%. We're not profiling now. We're looking at reality in that individual. But if you look at the other side of it, the man that has the Gleason 8, 9, or 10, and there are no metastasis, that's also telling us something about the metastatic potential of that man's tumor.
Well said.
So this has got to be, that type of thinking has to be factored into the whole risk management process. I've got guys that have been watched for 10, 15 years with high PSAs, but they don't have metastasis.
Yeah, that's why I don't like the Cobb effect. I don't like this idea that if you don't do this on this day at this moment, then you could miss that moment. Because look what we've learned in the past 5 years, that prostate cancer can act very different. Sometimes if you remember the old word, you throw the kitchen sink at it, you throw everything at it. Sometimes we've learned that you throw a kitchen sink at cancer and it throws the house back at you if you're too aggressive, right? But thank you. I just made that up.
I mean, this is
but this is what I mean. Look, when we talk about oligometastatic prostate cancer, right? It's the idea of you hit some of those spots when they need to be hit, but you don't overwhelm the body systemically with treatment unless it has to be overwhelmed. So I don't like when people use fear to motivate, because it doesn't tell the true story of how you're doing. Right. And so I think, anyway, you know how I stand.
No, that's super important, because fearful people aren't able to reason and process normally and calculate risk, look at pros and cons, and make judgments. Right. And the industry is putting pressure on people that, that time is short. We want you to make a decision. And it's just this subliminal message. After all, it's cancer. We got to take this super seriously. A very appropriate approach if it was pancreas cancer, lung cancer, metastatic colon cancer, these sorts of things. I mean, you go pedal to the metal, regardless of what. But prostate's a different world.
Yeah, it's like, look what's happened in thyroid cancer in the past 20 years.
Yeah.
Everyone was getting their thyroid taken out. Now we've woken up in 2026 and we have these things called papillary thyroid tumors. They're even thinking about changing the name. A lot of them just need to be monitored. And so it's completely flipped. I'm not saying it's exactly like prostate cancer, but sometimes fear and being too aggressive can actually be your Achilles heel. Whereas
it causes make mistakes.
Makes mistakes. Okay. Yes. So now we're going to move into imaging. All right. Image negative cancers. So if you go and get a PET CT and you're dealing with possible relapse because of your PSA kinetics, right? I finally said to Dr. Kwan, there are these guys with a PSA going really high and the image is still negative, right? So you touched upon this. And his philosophy, I get it. His philosophy is better to see it than to and do something than potentially not see it and guess where it is. But I thought you could comment on that because I do think for some people out there, there's a point, and again, it might be redundant, but there's a point where you're just not getting something on image, and the
Yep.
PSA doubling time is moving. And what do you do?
You can kind of work backwards. There's only, practically speaking, two things to do. One would be to radiate where the prostate, the fossa, or the bed. The other is to put someone on hormone treatment. It's really nice that careful studies over the last 30 years have shown that postponing treatment and allowing the PSA to rise up, on intermittent therapy, they call it, does not have a negative impact on long-term survival. So there is solid science behind the safety of postponing treatment, or starting hormone therapy. So this situation is much easier in someone who, say, was referred to me and they had surgery and their PSA was rising and someone radiated the prostate bed. Okay, so that question was taken off the table. Now they've got a rising PSA again. They didn't get it. And can we safely allow PSA to rise up while we wait to find out where it is, rather than just sticking them on hormone therapy? And I would definitely wait. I would, in the intermittent studies, they allowed PSAs to rise up 5, 10, 15, 20.
Okay.
And they then put them on hormone therapy, and they had the exact same outcomes 10 years later as men that were on hormone therapy continuously. So it is safe to allow PSA to rise up. And what are the advantages of letting it rise up? You might find a spot that you could spot radiate and possibly even cure. So there's a huge upside to allowing the PSA to rise up. Mayo Clinics has really been on the cutting edge with this sort of thing. So PSMA PET scan is everyone's first go-to. Next layer for us is something called an Aximum PET scan. Works by a different technology. So some of these cancers don't have the biology to work with PSMA, and so you can go on to another type of FDA-approved, insurance-covered scan called Axumin, AXUMIN. Believe it or not, I've been through this many times. Some of the cancers don't show up with either one. You can get an FDG PET scan. This is a third type of PET scan that's FDA approved for lung cancers, pancreas cancers, breast cancers. And that will show sometimes. And then last but not least, and it's certainly not last at Mayo Clinic, is something called C11 choline. And C11 choline is another completely independent independent technology from the previous 3 scans that I mentioned. And the neat thing is, because there's so much heterogeneity, many different types of prostate cancer, what doesn't show up with one type of technology may show up with another. So you can go down this list of getting scans, and as the PSA goes up, 97% of the time you're going to find where it is before the PSA, say, rises above 5 or 10.
And what I said to him is, now when you see something, by the way, Juan just his team presented a paper where choline did a very good job of picking up relapse when the PSA was very high. As the PSA got higher, it really became very accurate. Now you could say that's true of all the scans, but it was exquisitely maybe more sensitive. It was a very interesting paper overall. But
did we emphasize that? Mayo Clinic has definitely got a feather in their cap that they have the only FDA-approved C11 choline in the United States. Yeah. So it's an excellent scan. A bit inconvenient if you have to travel to. There's a Mayo Clinic in Florida. There's one in Rochester, and then there's one in Arizona. Right. I know the Rochester and Florida ones do C11 choline. Not sure that the Arizona people do, but. If you've got a rising PSA and you've tried these other scans and you can't find it, I refer patients to Mayo for a C11 choline.
Yeah, the choline's a really interesting option. I can tell you that, but what I also said to him was, okay, now I'm going to play devil's advocate. It shows up now on the scan. Are you confident that that's the furthest the cancer's traveled? Are you just picking up a cancer midstream and there's another cancer downstream? In other words, are you really picking off the area where the cancer is and the furthest it's spread? How do you feel about that?
Well, your question that's the big question. And you say, well, why is it such a big question? Because the big question is, well, okay, it's obvious we're going to radiate the spot and sterilize it. Thank God for modern radiation technology. It'll 100% cure the spot we can see. Do we need to implement hormone therapy as a precaution against other smaller spots in other parts of the body now?
Right.
Or should we first spot weld the spot and see what the PSA does and use that information to decide whether you need another scan to keep looking or add hormone therapy later. I've been migrating from in the old days, because we were so back on our heels with cancer, so that we would always give hormone therapy with the spot radiation because we were quite afraid of metastatic prostate cancer. But we've kind of gotten away from that, because if you just radiate the spot and hold the hormone therapy, you get to see immediate results as to whether the PSA declines as you would expect if it's the only spot. So if the PSA doesn't decline down to undetectable levels after the radiation, there's other cancer, and you need to keep scanning. Yeah. So this is our thinking has been evolving on this, and we're not routinely giving hormone therapy every time we treat oligometastatic disease with spot radiation.
Yeah, that's really cool, because hormone therapy, as much it's been out there almost as long as I've been alive. That drug has been available, and it's a great drug, but at the same time, for the person who doesn't truly need it, it can create metabolic chaos.
Yes.
Right. That's what I call it, metabolic chaos. It's not fun to be put into menopause within a few weeks. Yes. Nobody wants to be put. So you want to be more selective about that. Just for the audience, he provided in his slides, if you look, 3, because I talked to him beforehand, we talked about these studies. There are 3 fairly new studies suggesting that when you pick it up, you are seeing potentially the edges of where it is. It is a good representation of what is going on versus just a guess. There could be a million. So the early indication, although we don't have a phase 3 trial, is, hey, those scans are pretty powerful in telling you the status of the situation. There's one other thing I want to talk about with Quan. I don't talk about it with you, and then we'll go into some of the other things I talked about, unless you have something else to add. I said, if you had your druthers, not your brothers, if you had your druthers, would everyone get an MRI and a PET scan when you're dealing with relapse? Because sometimes what happens with these PET scans is, there's a number of limitations to them. False positives, we know. A number of them excrete their compound in the bladder, so the bladder has a halo effect. The bladder shines like a bright light. So there could be a cancer near the bladder that you can't see it, because that bright light from the scan doesn't allow you to see it, where an MRI could show you that tumor near the bladder. So the question was, would you want everyone who goes, yeah, I believe I'm to the point where everybody for relapse, ideally, and I think I can get it approved, should get an MRI and a PET scan to determine the extent of relapse? Where are you on that? It's such an interesting question.
Well, if you have to generalize, I'll say yes. There are going to be exceptions. Some people have such slow doubling times and such low PSAs that the concern you raised about getting false positives, say, for example, on PET scans. If someone has a PSA of 0.1 and their doubling time is 12 months, a PET scan that shows something quite possibly is a false positive, because statistically the likelihood of finding something is so tiny. So I don't do routine PET scans in people with really slow doubling times and low PSAs, but the idea of checking the fossa, where half the time that's where the problem lies, with an MRI, which gives you more precision, more clear delineation of that area than a PET scan does, makes a lot of sense.
Yes. I can't tell you how many times in the past year since I talked to you, because I haven't talked to you since the fall conference, because you never call me. We used to be good friends, but now you do weekly videos with Alex, so you have no time for us common people anymore. But that's okay. I handle that with my therapist. I don't need to do that with you. If I had a dime for just in the past year, the number of guys, even I know in California, that had a rising PSA, for example, after surgery, let's just give that example, and they couldn't find it on the scan, and then someone thought, let's just do an MRI, and they found a tumor right there near the bladder that solved the problem, I'd have a lot of dimes. Yes. So for the audience out there, if they're frustrated with they can't find it on the PET CT, you do have to have a discussion about MRI with your clinician. The MRI provides so much more detail than what it's given credit for. Just getting an MRI at screening, people talk about, is it PIRADS 4? Is it PIRADS? That's all fine and dandy. Again, I'm going off on one of my tangents here, but this is
an important tangent. I'm glad you're doing it. It's an important
tangent. It tells you about the seminal vesicles. It tells you about bladder neck invasion. It tells you, for example, the lymph nodes. It can tell you about some of the bones in the area. It picks up It tells you the size of the prostate if you have a size of the prostate, so you could do a PSA density. The last thing you want to do when you're getting an MRI is just look at the PIRADS or just look at cancer. You want to look at whatever else it's telling you in the impression part, because it can be quite instrumental in helping you with your cancer. I'll get off that soapbox. You want to go to my next question? This is
I appreciate that. We may get into this a little bit when we talk about Dr. Epstein's talk, because the pathology approach to monitoring men with prostate cancer, which Dr. Epstein pretty much invented. I mean, let's give him credit. Maybe should get a Nobel Prize, but it works very well. And sometimes when you have something that works really well, people are a little bit slow to move on to something that maybe even works a little better. And what I would contend works a little better than sticking needles in every few years and analyzing it under the microscope is getting a good quality MRI every year. And of course, patients really resonate with that. After they've had a couple of biopsies, they say, "I'll take the MRI." But but in terms of precision and accuracy, nothing to say bad about Dr. Epstein's work and all his marvelous discoveries. The MRIs are more accurate than biopsies, and not in terms of eliciting the Gleason score, maybe eliciting something even more important, and that is whether it's growing or not. Remember, we talked about how PSA going up sequentially is the sign of cancer. Well, on an MRI, you can get annual MRIs, and if you see a spot, they'll put a caliper on that little spot, and they can ascertain whether it's growing or not.
Yeah.
That's more important. The Gleason score is they're trying to profile you and tell you whether it's likely to grow or likely to metastasize. When you're looking at an MRI in a healthy patient with a known relatively low-grade cancer, you can see the spot and whether it's growing. And annual tests are just about perfect, because even fast-growing prostate cancers take a year to be visible in terms of their changes. So this is, I think, an underappreciated aspect of MRI. No, there aren't really any champions for MRI, like we have champions for Gleason score and these sorts of things. And there's a big industry. The biopsy industry is $1 billion industry. It's not going to go away very soon. But in men that have an abnormal MRI or an area of growth, then they don't have to go around the clock with a dozen needles. They can just have an expert needle the area of change and see if the Gleason is getting higher, and then that can trigger whether or not any kind of intervention is necessary. Hopefully at an early enough stage where you can do something called, what did Quan call it? Minimally invasive. I call it focal. The minimally invasive, it didn't seem like he was too excited about I think he's seen a lot of the rough and ready learning curves of the different things that are going on out there. But I've been lucky to find minimally invasive or focal experts that can consistently get rid of spots. And that's a lot more attractive than, nuking the whole prostate or cutting it out in terms of the long-term quality of life outcomes.
I think the theme of this discussion is MRI doesn't get enough love, and that's true. Yes. I mean, I'm starting to monitor studies and papers that suggest the nuances of MRI, because people are getting better at it. This is not a static field. People are getting better every week on it. So now
now we've got artificial intelligence cross-reading these things that is It's addressing one of the most difficult things, which is the interpretation of MRIs. Can't tell you, we get MRIs done in patients all across the country. Half the time we look at the reports and say, yep, another amateur reading this MRI, doesn't know what he's doing. We get the images overread at a place like UCLA or UCSF and get the images are fine. The pictures they're getting are fine, but the doctors reading them don't have enough experience and they need to be double checked.
That's right. People forget that this entire report they see, it's not the picture doing the work. It's the picture is the easy part. It's the person reading it that has to have the experience. That goes back to good pathology.
Yes.
Right. But the MRI is so critical. So what I'm seeing in studies now are the nuances. So when we won't talk about Epstein just yet, because we covered so much with Epstein. We'll cover him in just very little. I talked to Epstein about all the variants that you can see in pathology that get me all excited that we're learning about variants and we're learning, really to try to individualize pathology. But a lot of these variants now that we'll talk about later, the MRI suggests in its PIRAD score and other things if that variant might be there. So the MRI in the hands of someone who's adroit, I love that SAT word, adroit, skillful. I love vocabulary words. they're getting better and better at picking off the nuances. I always find it funny when really the top MRI people in the world, who come to our meeting go, well, I just have to remind you that MRI still misses 10 to 20% of the significant cancers. And I go, wait a second, but that means 80 to 90% they're picking up. And 10 years ago, nobody was talking about MRI. It's completely revolutionized the field. Anyway, all right.
Well, let's address the 10%. So this is a really, really cool aspect of the whole MRI industry. So the MRIs have become established. They're credible. The broader industry believes in them. They use them. And that's all based on studies just looking at a single snapshot. So you look at the PI-RADS, get the biopsy and everything, and wow, that was really helpful. We got that MRI. And there's actually almost nothing in this industry about annual MRIs to look for growth, which is the only thing we care about is the growth.
Right.
And so the power of this in the active surveillance world where we're trying to find, you look at the initials, what the Gleason score, the PSA, the size of the tumor, and you say, okay, I think you're a candidate for watching. Well, it seems like the thinking stops there. The watching is where the power is because prostate cancer is such a relatively friendly sort of cancer that if you were to discover a year later, this one should be treated. It grew. We rebiopsied it and we found a higher Gleason score. Is that patient who had treatment postponed for a year in any specific trouble? No, because you already picked it up at a juncture where you said it's safe to watch it. You have enough room, enough fudge factor that you have the luxury of seeing what kind of a cancer you have personally, not a profile of what other people with similar cancers had, which is what Gleason score is. You get to see what hand you've been dealt, and that is super powerful. And that's because of MRIs.
That's right. And so people need to understand too, this is not just mutually exclusive. This is not just in the prostate world. I talked earlier about what happened in thyroid cancer and how they're watching and waiting. They're being more careful, more selective of who gets treated. Guess what? I had a friend who had a thyroid issue and I went back and they sent me the report. They said, hey, you can read some pathology reports. And I looked and it said TI-RADS. I'm like, TI-RADS? TI-RADS? I'm like, wait a second. TI-RADS is the PI-RADS report for thyroid. Everyone's starting to adopt these MRI, ultrasound-ish, TI-RADS, PI-RADS, right? They're starting to take over cancer. So this is a beautiful thing happening in cancer to, I think, enhance quality and better precision. So I thought you'd find that an interesting story. TI-RADS. Right. I thought that was maybe like a tirade, but it's actually thyroid. It's a way of classifying whether or not to go back in and rebiopsy something in the thyroid. Here's what I said to him, which is also rhetorical, and we'll move on, and I'll move to the other quick questions for him. This was bugging me a lot too, because this is a very important for the audience globally. Dr. Kwan says, keep your radiation plan for your personal records. And I said, hey, does that include a personal CD copy of your PET CT or say MRI, plus your formal report for a second opinion? And I said, listen, Dr. Kwan, you don't even have to answer it. The answer is yes. And then I'm going to get your opinion. If I had a dime for every time in the past 6 months, someone got a PET CT somewhere in California or another place, and they said, well, we can't send your imaging for the second opinion doc for another several weeks. And they didn't realize that when they were imaged, they could have had a personal CD made, several copies, and then just went ahead and sent that to the second opinion. And then they would have had that moving within a day or two rather than waiting a month. It is your HIPAA privacy rule right to walk away. I encourage anyone that gets a PET CT at any center to keep a CD, get a couple CDs and take them for your records, or so that you can send to the second opinion for alacrity. That also means speed. That's an SAT word. I'm just feeling my SAT. So will you comment on that? This makes me wacky that people aren't given a copy of their own CD. Or
two things that I would support. I mean, you're preaching to the choir here. Number one is that the idea of you taking control of your future personally. And then number two is you're giving people an aviso that taking the first information that you get from whatever center it was or whatever imaging, and like that's gospel. Well, this, there's a lymph node here, supposedly. The idea of okay, you're a professional. This is your opinion. Very well could be the case, but the precision in deciding whether that lymph node really is there or not is so important to my future. It makes sense to double check, because you and I have both seen these things where I had a case just last month. We were watching, PSA was 2. All of a sudden, the MRI comes back and he says, oh, the tumor's gotten a lot bigger. Oh, we better get a PET scan. Oh, there's a lymph node. There's spots in the bones. Holy Toledo. How can this be? This guy had a PSA of 2 and a low Gleason score. Well, it turned out that he had one of these prostate arterial embolization procedures for his big prostate, unbeknownst to the other doctors. And the one that was reading the MRI noticed these changes and thought it represented tumor progression. Okay, well, that justifies getting a PET scan. Well, the PET scan said, whoever read it out said, yeah, it looks like a lymph node and some bone mets. So I, following my own advice, go to the top of the department at UCLA. Please look at this. And the initial read actually was at UCLA. So you know, there's some political stuff here, you know. But it comes back as, yeah, you know, it is a little suspicious, but I think we should just watch it, because he was going to get a needle biopsy of the lymph node and the prostate. So this process, for you and I, it's second nature. But for the less experienced, maybe some doctor out there is ordering a PET scan for the first time or something like that, and he's going to take it like gospel. You know, this is always true, instead of contextualizing it in the bigger picture of the patient. You know, because I was suspicious with a PSA of 2. Let's double check at least. And when you tell people, get your scans, get your medical records, they're taking more control. They can get it double checked more easily. And I think it's creating an awareness that medicine is still an art. It's not just black and white science.
Well put. Well, you know, I always say, you know, because I do public health now, you got the big practice. So when I get inundated by people, I instead call them friends now. Everyone's a friend. There's no one that's officially a patient, but they're friends. So I had a friend who essentially, to make a long story short, is a really interesting situation. Got a PET CT after surgery, a rising PSA, and they said, oh, he's got a clavicular, he has a clavicle met, right? They said, well, I want a second opinion. He called me and said, where would you go? I mentioned all the top people, and I clearly mentioned UCSF. You know, UCSF and UCLA kind of got the whole ball rolling on PSMA PET, helped get it approved by the FDA. So they have people that have read 10,000 plus scans, blah, blah, blah. So they tell him, this is just recently, they tell him it's going to be 3 to 4 weeks before we can get that image to your second opinion. And I said, you need to go back, and you didn't ask for your own copy, and then you need to send it to the second opinion people. Here are some of the top names. He walks back the same day, gets a copy, FedExes it. Within a few days, the top people at UCSF read it and go, that's a false positive. Yep. And it turned out that the PSA
totally turns the story.
Totally turned the story, that he got his CD, got a second opinion. And it was surprised me too. I said it's a false positive, and the PSA is kind of settled. And you know, these are the moments. These aren't outliers. These are the moments that people have to gain control of their health. Anyway, I think the message is relapse is a specialty. So that's the important thing I want to talk about there. Can I talk about a couple of emerging things that we didn't get a chance to talk about with Quan, except for 2 seconds? I want to remind the audience that there's lutetium, and Mayo was one of the top recruiters for the lutetium trial that got the actually lutetium approved, Pluvicto. And, you know, now they're moving toward phase 3 of actinium. Novartis, and there's another one called Fusion that I think is fused with AstraZeneca. Anyway, they're moving toward phase 3 of actinium because there's so much excitement for people who might have failed Pluvicto. Can you give us a status update? Because I always like to ask colleagues, hey, what do you think is next coming out in terms of FDA approval? And people get nervous about that. Like it's like they're giving a stock tip or there's a conflict. I'm going, no, I'm not talking about a conflict of interest. I'm not talking about a stock tip. I think it's important to mention not only what's on the horizon, but what could be approved in the next year for me that's different. And actinium.
Well, I think you've nailed it, as you usually do, Mark. The reason I'm excited about actinium, I don't have broad experience with it, maybe a half a dozen patients that have had treatment either on a clinical research basis or have gone outside the country and purchased it. The notable thing when you're treating advanced metastatic hormone refractory disease, especially someone that had been on Pluvicto and it is no longer working, you're talking about very serious, what we would call almost end-stage disease. And in that situation, if you can find something that will buy a respite, buy some remission time, that's a win. That's really exciting. Right. But being in this field for so long, it's not super practical to hold out some hope of a permanent turnaround. It's just so implausible and so unlikely. Not to say that I haven't seen some weird miracles in my life, but typically you're saying get on the treatment. It can slow it down, might reverse it. Maybe it can keep someone going an extra year or two. That's wonderful, and it's pretty well tolerated. Actinium, the dry mouth is an issue. But what I'm leading up to with all this is that of the 6 or 7 patients that have been referred out, 3 or 4 of them not only went into remission after a couple of infusions, they stayed in remission.
Wild, isn't it?
I have never seen that before. So is there an explanation for why this might be different than Pluvicto? Well, it's an alpha emitter, not a beta. Right. Apparently the punch or the intensity of the radiation is like an order of magnitude or 2 orders of magnitude higher than what they can do with Pluvicto. Yeah. And it's in some cases it just knocked the cancer flat. It's Dr. Kwan mentioned that he's seen some problems with kidney problems over time, and the dry mouth, I guess, is even worse than it is with Pluvicto, and that's not a small thing. But yeah, I think it's something we definitely want to keep our eyes on. And if there's a patient out there that's been told that that there's no options, they should be looking for a clinical trial of this, or if they have extra financial resources, there are places outside the country where you can actually buy it.
Yeah, like Turkey, some people have gone to Turkey, sent from the Mayo. And the Turkey clinic, what people don't understand about the Turkey clinic is if you go there, everyone's wearing Johns Hopkins jackets because it's a Johns Hopkins based clinic. So, the one comment that people tell me when they go to Turkey or other places, I went to Turkey and everyone's got on Johns Hopkins. I believe it's Johns Hopkins. My memory is good enough. I'm almost positive. And you have this PSMA action and other phase 3 trials, but you mentioned xerostomia, which is dry mouth that can happen where all your salivary glands start secreting less. What I find most interesting as people start to get involved in actinium is I decided to look at some of these new trials that are springing up. If you have xerostomia or dry mouth grade 2, a lot of the trials won't take you. So it's important to understand that grade 2 is you've had to move toward more liquid-based products for your food. So keep that in mind. But I want to tell you something about xerostomia, and then we'll move on. Which you can watch for it, and then you can tell me because you got the busy clinic. But I got my ear to the railroad track like everybody else globally. I put my stock in there after 35 years. In head and neck cancer, dry mouth is not uncommon. Well, a lot of radiation oncologists, a good deal now, have learned acupuncture as a potential treatment for dry mouth. And so if you look in head and neck cancer, you'll see that some radiation oncologists have now been certified in acupuncture if you have that side effect. So I went to look, are they doing acupuncture now, clinical trials in people on Pluvicto and actinium? And the answer is they're starting to do some. I don't know if it'll be a solution. All I know is they still do ice packs in some of these locations. Maybe acupuncture doesn't end up helping. Maybe it helps. But it'll be interesting in the next year or two whether or not we hear that acupuncture, they're studying Botox, they're studying a number of things here. And I find that fascinating. But that's actinium. Anything else on that? That is perfect.
But I appreciate those ideas because I had not heard of them. And we've been pretty much at a loss what to do about the dry mouth problem.
Yeah, if you take a look at head and neck and dry and xerostomia, acupuncture still kind of, hey, maybe, why not? It relaxes people. It's helped some people. We don't have a phase 3. I'm not saying it's going to be the solution, but people should keep in mind, or if they go to Turkey or another place that's doing a lot of actinium, I try to keep up with what are they doing, but they're still doing ice packs, right? So they're not necessarily recommending anything else, which is interesting because they do so much of it, but it seems like they're still doing ice packs. Well, we only have about 25 minutes to go, and I wanted to try to cover one other thing with Quan, if you don't mind. Do you mind?
No, jump right in.
This was the one that we didn't get enough time to cover. And I've asked Alex to cover this in a different way at the fall meeting. I'll explain that later because we're now to the point where mentoring, I want to make sure she's doing one topic that's a consumer topic. And I'll talk about that with companies where you can get discounts on medication or you can find ways to appeal to the company. But that's a preview for the fall meeting, which we're going to have some incredible people there, including Dr. Klotz, who, is going to talk about focal therapy and active surveillance, a 2-in-1 talk, which we've never had. All right. I want to read you the prescribing information for a drug. All right. Ready? I'm just going to read this. Right now, here are some of the indications for this drug. Not that many indications this drug has FDA approval for. Only melanoma, non-small cell lung cancer, head and neck squamous cell cancer, classic Hodgkin's lymphoma, let's see, urothelial cancer, MSI high, gastric cancer, esophageal cancer, cervical cancer, I'm not done yet, liver cancer, biliary tract cancer, Merkel cell carcinoma, this is one drug, renal cell carcinoma, endometrial carcinoma, cutaneous squamous cell carcinoma. Let me take a break and have lunch, come back. Okay, triple negative breast cancer now. Wow. Ovarian cancer. And I'm just going to stop there because I'm getting exhausted and I'm wasting the audience's and your time. FDA approval for 18 different cancers, but not prostate cancer unless, anyway, this is Keytruda. No, don't work with the company. I've actually never met anyone at the company. And what I was trying to get Quan to do, but we ran out of time, was we have Provenge. You could talk about that for a moment, but immunotherapy hasn't taken off in prostate like it has with most other cancers, except when you get a liquid biopsy, which you can talk about. I want you to cover where are we with immunotherapy and why, if there's all these cancers that have approval, why not prostate?
Thanks you for bringing this up, because I think there's a gold nugget in this for patients out there that are casting around for an alternative. We mentioned these people that have rising PSAs, maybe they have metastatic lesions, maybe there's too many for them to be spot welded with radiation, and they're thinking of going on hormone treatment. Well, what about some immune therapy in those people? If you could just juice up the immune system and keep the disease steady, they would be able to postpone starting hormone therapy.
Right.
Well, Keytruda is a natural thing to consider because of the long list of diseases that it's effective in. And the studies that have been done where you just shotgunned it at a lot of people with prostate cancer, it didn't work frequently enough. It worked in some people, but it didn't work frequently enough to get over the threshold for FDA approval. So this is why it's not considered a treatment for prostate cancer. However, there were some patients that did respond. And people that are in this category that, that are looking at maybe using immune therapy as an alternative to being on long-term hormone treatment should look up a company called MIRDX, MIRDX. They have developed an assay for prostate cancer or any kind of patients that can look at your immune system and tell you in advance of taking the Keytruda whether, number one, it's likely to help the cancer, and number two, whether you're likely to tolerate it well. So you don't have to just shotgun it at every patient. You can do this test, they call it Previotox, to determine in advance if you're likely to respond and you're likely to tolerate it well. If you check both of those boxes, there's another thing, a very exciting thing that Merck Pharmaceuticals, and I don't have any connection with Merck Pharmaceuticals, but they have a compassionate use protocol that has been very generous for patients with prostate cancer that want to take Keytruda. And if your doctor petitions Merck, they will actually give your doctor free Keytruda. And this is like $10,000 a month retail stuff. It's really expensive for free. And so there's kind of a two-step process now in terms of bringing this type of immune therapy into a day-to-day usage. Number one is find out if you're a good candidate for it, tolerate it well, likely to respond, and then have your doctor approach Merck Pharmaceuticals to get the medicine to you. There's some other immune medicines from Bristol Myers, Opdivo and Yervoy, which also can be tested for in advance. And Bristol Myers also has a generous compassionate use program and is willing to give these same very expensive immune therapies away. So that gives you actually two different types of immune therapy. You mentioned Provenge. I think Provenge is an old standby. The trouble is it got FDA approved only for a very narrow segment of people, and it's very expensive. So the people that have a rising PSA with a low testosterone, these are hormone-resistant patients, can get Provenge covered by their insurance. But many of those patients are in sort of a dynamic, the cancer's out of control situation, and people put them on Pluvicto or Taxotere chemotherapy, and they're not thinking in terms of an immune treatment at that point. It's a little bit misplaced in the payment schema, unfortunately. It's a great product. I definitely use Provenge, but finding the patients that can get it that can get it covered by insurance is difficult.
So with Keytruda, you've seen patients that qualify based on a test. And
yes, and I've had patients in that very category that would staying on Keytruda for like 2 years with stable PSAs, not having any side effects. The inconvenience, you have to go to a doctor and get an infusion every 3 to 6 weeks. Yeah, but it's definitely a lot better than being on Lupron and Zytiga.
But it's a small number that actually qualify because they call prostate in general a cold tumor. It doesn't generate a whole lot of big immune response. But there's that small segment of patients that do qualify for Keytruda, or maybe they don't even know it. And in your case,
oh yeah, the MSI patients, yes.
Yeah, the MSI patients. So you get a test that says MSI high, or you can get a tumor mutation burden test. Anyway, you qualify, you get Keytruda, right? But I always ask the same question.
Now this is different from what I'm talking about.
No, it's different from what, yeah.
What you're talking about is patients in whom their insurance will pay for Keytruda because they're almost guaranteed to respond.
That's
this
right.
is based on a genetic test. You have MSI high, and 90% of those people will get an amazing response to Keytruda. I've only seen 2 of them in my career. They're rare, but this is a different category. I'm talking about a broader category of people.
I know.
Yeah. So go ahead.
But it's important. You're specifying you could qualify in a lot of scenarios. The scenario that the FDA has agreed on is if you're MSI high, but you have to have the test to see if you are. But I always ask the oncologists who are seeing a lot of patients, or if I talk to Mayo or other people, and they say, well, it's a small number. And I say, okay, fine. But in that small number, what kind of responses do you see? And they go, we see really good responses. And I'm going, well, then why aren't we pursuing more aggressively who else might possibly respond? And I'll give you an analogy of hope here. They told me years ago that breast cancer will not respond to immunotherapy. It's like prostate. And guess what now is FDA approved? Triple negative. Anyone who knows the breast cancer world knows triple negative is, that's an aggressive tumor. That's the downside. The upside, though, is it can generate an immune response to Keytruda. It gets approved. I guarantee you somewhere out there, I don't know if it's Gleason 9 and 10, I don't know if it's some of the pathology we'll talk about in a minute called intraductal carcinoma or aggressive cribriform, somewhere out there, we're going to find out that a subset of prostate patients are really likely to respond to immune therapy because of some test. I'm just chomping at the bit.
There's two tests, 3 tests now. So one is the Previotox I mentioned. That's
the first.
Identified. Then the MS high was the other way. And then Dr. Kwan mentioned it in passing in his talk. And when you get a cell-free DNA genetic test, like Garden 360 Foundation 1, there's several others, these will count up how many mutations there are in your tumor cells.
DMBs.
So when you start getting above 10, he said 13, which is kind of
10.
I was a little discouraged. I say 10.
It's 10.
Yes, there you go. So those patients are much, much more likely to respond to immune therapy.
That's right. So if you look at the prescribing information, we will give you the drug if your tumor mutation burden high, TMB high, greater or equal to 10 mutations per megabase. It's right here in the indication. I always encourage people to look at those indications exactly. So what we're painting is a picture. So as a quick advertisement for the fall, so Alex and our assignment, she's going to deliver. We're going to talk about companies, how to appeal to companies and get these things that are at no cost or covered by insurance. And that is a talk that has to be given. Okay, but what I'm saying is I'm going to leave this topic. There is a subset of patients out there. Maybe they're BRCA2. I don't know. Maybe they're Lynch syndrome. But I feel like if they're tested, they might end up being TMB high. We'll see. Because if you would have told me 10 years ago triple negative breast cancer was going to be approved for Keytruda, I would have said, no, that's a cold tumor. That's not going to. that's my hope in prostate. Anyway, I'll get
So
off
the,
my high
so the
horse.
take-home message for this is number one, make sure you get a cell-free DNA genetic testing
Like
test.
Garden 360, liquid
Yes,
biopsy. Yeah.
exactly.
And ask
and
about
then
it.
and then you can also Google Miradex and ask them about their Previotox test.
Yes.
And then of course you really score the lottery if you happen to have the MSI high mutation, and almost everyone responds to Keytruda to that.
We have to tell more and more people with aggressive disease, the downside you have aggressive disease, but the up possible side is all these aggressive diseases, a number of them have Achilles heels. And if they can be exploited, you could possibly get a dramatic response. We have to find the Achilles heel. There's one more take-home message from immune therapy. Sorry, but this is my soapbox. MD Anderson and others are launching a trial where they give patients about 30 grams of dietary fiber along with their immune therapy. Why would they do that? Because they've found retrospectively in all these melanoma and other patients, there has been a hint, and this is published, that people getting more dietary fiber in their diet, then essentially their microbiome changes and they produce these things called short chain fatty acids. Those go into the bloodstream and may enhance their immune response. So they've seen greater immune responses potentially in people that get a regular amount of dietary fiber. So now it's moved to a clinical trial. And look, if it doesn't work, you'll be more regular, you'll be more heart healthy, you'll have all these benefits. But man, if they show some hint, and even Michigan's doing a trial with a product that's called inulin. So a lot of people are jumping on board in these trials of adding a dietary fiber or a fiber-based supplemental source to the immune therapy. And that's exciting. And then my final point is,
what's your favorite source for fiber? What do you?
I like dietary sources. I like when you go through all the plant-based sources. I love the lentils. I love the beans. I love the nuts. I love the seeds. I love the whole grains. I still am a fan of psyllium. Psyllium is Metamucil. You can buy a year's supply at Costco for virtually no money. It's also found in the strongest cereal-based fibers, all brand buds. I usually carry it with me up here. Not all brand, but all brand buds. But these are very potent sources of fiber. Now, let's say none of that works for you. And you want to do another type of fiber. You want to do inulin. You want to do pectin. That's my dog, by the way. My dog's very excited about fiber. I don't mind. It's just find a place. There's a commercial on TV right now with a gastroenterologist. It's very popular. I think it's very well done. It's done by Metamucil. And she says, I just kind of didn't have a pick-me-up, and I decided to do the Metamucil challenge. It's psyllium. So you can buy psyllium also generic. You don't have to buy Metamucil. She says, I took it for 2 weeks, and I feel better. It's a 2-week challenge. You take it every day with an extra amount of water because you need water to make it work well. Anyway, long story short is, she does a really good commercial. I know she's getting paid, but it's true. I mean, people that give it several weeks and they go into it slowly. If you go into it dramatically, you're going to feel terrible. You're going to have that bloated kind of locked in effect. But what I love about the message, I don't care where you get it as long as it's a clean source, but I like the dietary sources first and foremost. Man, lentils and beans, powerhouses in terms of nutrient dense, powerhouses for protein in the area of GLP-1s, right? We talk about GLP-1s, powerhouse for fiber, powerhouse for potassium, powerhouse for magnesium. So it gives you all these extra benefits. Anyway, I'll get off that horse. But the other reason is, if you pick up a bottle of Metamucil or another bottle, it says basically that it's heart healthy. It says it may promote healthy glucose levels. And right now they're studying the area of blood pressure. It is a heart healthy, proven product that the FDA has allowed that kind of advertising because they have the data. So when you see this on the label, there's a reason they can be heart healthy. It helps promote a healthy blood sugar. They're probably going to get a blood pressure indication. It may help you feel more full to lose weight. But I like when a recommendation is given, whereas the downside is if it doesn't work for what I'm selling you, it still makes you heart healthy, right? And so I don't know if it will work in immune health. I don't know if it will work with Keytruda in the trial of melanoma patients, but I do know it's heart healthy. And as we age, and we want to be more regular, it should be a regular part of your routine. There's no question that any man or woman that comes to your office that starts doing fiber regularly and safely will come back and hug you later and say, you know what? My train is on time now. It's not too slow. It's not too fast. My train always runs on time. And the other thing that you don't get enough credit for when you do this is not only do you go, but you go quickly. See, the old thought that you should sit there and strain, we realize causes a lot of pressure. That can increase the risk of diverticulosis, maybe even diverticulitis. It causes hemorrhoids. It causes all these problems the longer you go. So what we've learned in the animal world and the human world is the faster you go naturally, the healthier it is for you. So you shouldn't be reading the newspaper when you go. You should barely have time to check if you've received a new text, and then you're off and gone. All right. So that's a whole other lecture that maybe I'll give one time. And then there's a lecture about men and women and bidets, which are very healthy as we age. But that's my dietary sales point on fiber. Should we finish up here in the last 10 minutes and talk about Epstein?
Well, let's just say thank you, Dr. Epstein, for all that you've done and bringing clarity. I mean, we're talking about designing. He talked about that 5-stage, instead of using 6 through 10 for Gleason score, he designed this 1 through 5, much more intuitive, much easier to understand. Ones are totally safe. 2s, you think about watching or you think about treating. 3s, 4s, and 5s are going to have treatment unless you're 85 years old. And I mean that just if someone just brought that one thing in their whole lifetime to the earth, you would say, what an accomplishment. Of course, he's got an incredible CV of amazing things that he's done. He originally designed the initial active surveillance methodology in terms of when everyone was so afraid of even starting, he said, look, if you just pick the 3+3s, no more than 2 cores, PSA under 10, I think we'll be okay. I remember I attended the meeting where that was reviewed as a potential way to kick off active surveillance back in 2005. A couple hundred experts were there, and there was a show of hands. Does everyone agree that we need to migrate from treating everybody to watching people with this profile? Every hand in the room went up to support Dr. Epstein's initial thought of where we should begin with active surveillance. Now it's moved on to where we're now starting to watch some men with 3+4 as well, thank God, that expands this much greater. We're so fortunate to have a man of that caliber that can come on and educate us about arguably the most important prognostic factor, your Gleason score.
I'm not going to put this in words. Often you and I finish each other's sentences and correct each other because we're brothers from another mother. We've worked a long time together. But maybe you can say one more thing that I can say. When I say he's the Michael Jordan of our time, or he's the LeBron James, people don't understand it. In many fields, you have a lot of top surgeons. You have a lot of good radiation oncologists. You have some good oncologists. But the reality is he is so far above in the field that he is sort of Michael Jordan and LeBron James at once. And nothing against other people. They're great in catching up. Right. But it's why if I wanted a second opinion, to say I wouldn't hesitate, I would walk it to his office. You have to explain to the audience that he is literally in a category by himself. I'll tell you how much. A friend yesterday came to me and said, I don't understand this pathology report. And by the way, Michigan did a study that was published in JAMA last year, and I know the authors. They had people at the VA and other places read their report, and a large percentage of them didn't even know they had cancer. The report made no sense. So they're not very friendly. So they're trying to work on making pathology reports friendly. Well, now the terminology is getting tougher and tougher. He said, well, I've got this and this and this. Should I send to Epstein? And I said, this, and this. He created the definition for it. He's the person who decides whether or not you have this, and this. Yeah. That's why I'm trying to put in words not very well how important it is to seek out people like him if you need a second opinion. Or if he's your first opinion, then you're fine. The other thing, so I want you to comment on how in a special category he is first and foremost. And the second tip I gave, this is a secret tip for the audience. When someone has a pathology report, I ask them to Google the pathologist. And if they Google the pathologist and it says, which I did yesterday, it said expert in OBGYN pathology. Mm-hmm. And this person's reading the prostate slides. It doesn't mean they're not competent. It just means that's our expertise. I did another one last week. It said expert in general and anatomic pathology. It doesn't say that their practice is primarily prostate. Those are the ones that, God bless them. They're probably just fine. But I want the person who's focusing on prostate who's seen over 100,000. So there's pathologists that just focus on prostate and what we call GU pathology, bladder, kidney, prostate. But a lot of them that are reading them do general pathology. And nothing against them, but I think we should
think what the problem is with this. So someone does a little prostate on the side, and they know, generally speaking, how it needs to be aligned. But if that doctor's looking under the microscope and he sees something a little ambiguous,
that's right.
And he knows that if he talks about it and puts it in the report, and it turns out later that the patient did have a bad outcome, well, he warned him. On the other hand, if there's something a little bit ambiguous and he decides to say, well, it doesn't look that serious, I won't mention it, and the patient later has a problem, they go back to that report. Look, this idiot doctor missed the fact that this actionable cancer. So the doctors that are less experienced tend to upgrade their path reports to protect themselves against that type of mistake. Someone of Dr. Epstein's caliber, who basically wrote the textbooks, calls them as he sees them. And when I get these things overread, I'd say 25, 30% of the time, no exaggeration, I get Gleason scores downgraded to some degree. And that can be the difference between we should treat it versus we can watch it. And what a new lease on life for these patients.
So I gave Epstein my top 5 reasons why everyone should consider me 100% correct. Here are my top 5 reasons. Gleason grading, what we're saying, is subjective. It's subjective. It's not some machine right now. It's based on experience. That was number 1. Number 2, we're learning about more. Number 1B is we're learning about more and more variants, which we talked about, cribriform, intraductal, that you have to have really good experience to call them or not, otherwise it gets confused for something benign. Number 2 is it's a primary predictor. This was the sign I held of current or future treatment. Number 3, people don't realize, he said insurance almost always covers it. He hardly ever has a case where it doesn't. Almost every single case. And then I ask him, well, how much do you charge if it doesn't? It's a couple $100s. And I go, that's how much it costs to go out in Marina Del Rey to get a sandwich. But seriously, I know a couple $100s is still a lot of money, but you're talking about one of the most important pieces of information in your cancer history ever, right? Number 4, he turns it around within a couple days. So, and I always encourage people, don't just send your positive slides, send the negative slides. He will read them all. He's actually seen some cases where there were benign glands. He said it benign, and it turned out to be cancer. He's seen cancer where it said, this is not cancer, it's benign. Send all your slides, not just the positive ones that most institutions do. And then number 5 is peace of mind. You can't put a price on that, because the other thing he does, and I set him up for the greatest softball, you got to watch this. I said, you can get on the phone and talk with him and he'll walk you through what he found. He takes your phone call if you set up an appointment. And he said, yes, I do that all the time. I love it. And I said, how much do you charge for that extra? This is total softball. He goes, well, I don't. And I go, exactly. Exactly. You don't charge. Get your money's worth. Get him on the phone and have him explain your results. These 5 reasons, it's become a no-brainer. Look, there's a lot of other good pathologists out there, and PCRI is going to have a couple of speakers who are good friends, but I'm just saying he's the GOAT.
Amen.
He's the greatest of all time. And I don't know why he did this. He gave his email. So I've asked Alex to put it up during the Q&A. He said, look, if you're ever having problems with the doctor or getting your slides to me, this is patient-driven. He said, just email me. I'll tell you what to do, even though the instructions are on the website. What you should know is that we did a master class for Q&A. We just didn't do Q&A. We did 7 parts. That's why for the audience here today, we're not covering much of Dr. Epstein, because we did a 7-part coverage. It was one of the longest interviews he's done. He said to me, this is the most I've ever covered pathology in my life. And I was happy about that, because I had a background in pathology. I was supposed to get a PhD in pathology, and I bailed out to get my MD. And but I learned enough to be dangerous, and I love pathology so much that I just wanted to go hardcore into pathology, and that's what we did. You have to leave in 4 minutes. Can I share a couple more things we did? I also quizzed him. and I should quiz you. So here's the quiz I gave him. All right, ready? So pathology masterclass. Here was my first quiz. Who played in the 2026 national championship basketball game a few weeks ago? What were the two teams and what team won? And he got it right, and so did Quan. Immense pressure on you. None of the doctors ever get these questions right. What were the two teams that just played in the national championship, and who won the national championship? Do you have any idea?
Haven't the slightest idea.
You're disappointing. You work too much. Michigan won the national title. They beat Connecticut. So you will be getting a hat. Every speaker, including you, will be getting a hat and has to take a picture with the Michigan hat on there. Okay, that was quiz number one. Also, we got him a gift from PCRI, the best pathologist ever, and even better father, because living in New York now, he had to leave our Q&A after an hour and a half because he had to go see his son at swim practice. I thought that was awesome because he now has a life. He leaves academics, he has a life. Ooh, what a beautiful message. Here's the quiz I want to leave the audience with, and then if you want to say something else, it's great. Oh, there's one question I asked him that he thought would be amazing. I said, what's the impact of the GLP-1s? Because there's periprostatic fat. People don't understand that. The prostate is enveloped in anywhere from 30 to 50% of it by fat. And I said, what's the impact of someone losing a lot of weight? Because people that have a higher BMI tend to have more periprostatic fat. I said, is that a benefit? And I think it's a benefit in terms of prostate cancer. We'll see. He said, no one studied that. That would be an incredible pathology experiment. So here's my final quiz. I've never done a quiz with him. Dr. Moyad, first time, I called the Donald F. Gleason quiz. Are you ready for it? Number one, Dr. Gleason moved to Paris because he really wanted to be a painter instead of a doctor. True or false?
Well, he should have known that, right? But I haven't the slightest idea.
He didn't know, but he guessed correctly.
Huh?
What do you want to guess?
Oh, well, I've got a 50-50 chance. So
true or false?
I'll say that he was not planning to be a painter.
The answer, he was. He moved to Paris, wanted to become a painter. His wife said, let's move back. But think about the implications of that, because he ended up drawing out the Gleason patterns.
Yes.
Right? And so, so the reason that Epstein loved the question is he said, you know what, there's one thing about all the best pathologists, they're visuals. They have visuals beyond what I've ever seen. They visualize things. They see things in their brains.
Yeah.
And so he said that makes sense. Number two, Dr. Gleason moved across the street from his medical office in Minnesota so he could work all day and night and just come home for dinner. True or false?
I'll go with true this time.
It's true. Finally, the most important point of the day from the Moyad standpoint. Dr. Gleason died at the age of 88 in 2008 in Edina, Minnesota. He died from prostate cancer. True or false? Gleason died from...
It's a common malady in the elderly like that, so I'll go with true.
He died of a myocardial infarction. He had cardiovascular disease, and the only reason I wasn't expecting to get these, I didn't know them until I Googled them and researched them. And the only reason I thought this was a great take-home point is I'm always trying to say heart healthy is prostate's healthy. So on the one hand, the emperor of prostate cancer, I mean, he lived a long, wonderful life, but the reality was always look out for heart disease too, because it's the number one cause of death. It's the number one cause of side effects. Are you really in prostate cancer? And so I also gave him extra credit. I said, it's Donald F. Gleason, the F standard for Floyd, and he was a big-time cook and a big-time sailor. That was what I wanted to finally finish with you. He was not only a master sort of clinician and a great teacher, he loved sailing. Does that ring a bell, Dr. Scholz?
Well, my dad, yeah, I'm involved in boats because my father, I mean, when I was growing up at one time, he owned 6 different boats in partnerships with other people at the same time. So that was, a heritage that continues on into our generation and probably many more. Anyway, I do have to run, but Mark, thank you for always keeping this on topic and entertaining and yes, and you get a lot of credit for tracking down these spectacular speakers that we're so blessed to have.
Thank you.
And we've both gotten so busy. We do need to meet a little bit on the side, and your delightful humor is always so much fun in our relationships. Although I'm usually end up on the short end of the stick, but I can.
No. Well, people always say you joke a lot. I try to be serious, but every time I'm serious, people laugh at me. So I just decided just to always try to be funny. But if you don't find some humor here, for those of you who haven't heard my story, we riddled in cancer in my background, riddled, and of all types, breast, prostate, you name it. And, and just dealing with what you deal with, you've got to find some kind of humor. It's important to laugh, and but it's also important to look at the glass half full. It's not to belittle anything. It's just how you survive and how you can potentially thrive. And I always thought the message was, it should be humor. There should be humor in our Q&A, but it also should be about hope. It should be about, we do believe the glass is half full. We do believe it's 70% full. We do believe if you empower yourself, if you learn more, if you watch the videos, you read the books, you hear from the experts, that essentially that glass is half full can become 90% full, that you can take advantage of the technology, you can take advantage of the brain power, you can take advantage of the information to create the best possible outcome for you. And that's what patient empowerment is all about. So it's always an honor being with you. It's an honor being with the team at PCRI, Peter, Mark, the others, Alex, the people who run it. They'll see us in the fall. And I really hope this fall we have a full plate again. We even have someone coming from Australia to talk about treatment, cutting edge treatment. I don't know if you want to make a comment before we leave.
Dr. Lenzo, who's,
tell us who that is.
Carried the flag for the development of PSMA, of lutetium, of actinium. These one of the probably the most prominent researchers, and who's practically brought this into the commercial space. Just a very, very talented, So this is really, you could say, the most dynamic. That and immune therapy, I would say, are the two most dynamic areas of prostate cancer progress. But anyway, I'm going to run. But
you got to go. That's my medal from the New York City Marathon. Okay, so I'm not being humble. I was 60 when I just ran it. It hurt. It was horrible. I don't recommend it. No, I do. I'm just saying, this is my badge of courage. They asked me again. They're like, "Oh, you want to run it again?" I said, "I would rather hang out with Scholz all day long playing tennis, which I don't even like tennis, than make me run that again."
Yeah, no, that's an accomplishment.
All right, I love you, man. Thanks for all you do. Thank you. I'll see you soon.
All righty. Bye-bye.
What a perfect ending to an awesome day. So much education, so much information, but thank you so much to Dr. Scholz, to Dr. Moyad for all of his incredible moderating. Thank you to Dr. Epstein and to Dr. Kwan. You guys are just incredible to spend so much time writing these talks and answering these questions and going over this information for us. And thank you to all of you who watched. Thank you to our sponsors, Bayer and Dendreon, who made this possible, and to my entire team, our video editor, our graphic designer, our admin, our helpline, our volunteers. I mean, everybody, just our admin team. I mean, you guys do an incredible job of just making this content available to so many people. So I really appreciate you. And to all of our other prostate cancer advocates and caregivers, we see you, we appreciate you, and we know that it is not an easy journey, but we're so honored to be here with you. Now, the most important thing I could possibly leave you with is what we say every single week here at PCRI, and that is that you are not alone. I understand that this is intense, not just from an emotional level, a mental level, a physical level, a spiritual level, but I promise you, think about this conference, think about PCRI, think about all these doctors volunteering their time, think about the support group leaders, the PCRI team, the advocacy groups that we work with, the volunteers, everybody who comes together as a prostate cancer community. Use all of that as proof that you are not alone. So reach out if you have questions, speak up if you're going through something, and know that when we say you're not alone, we're not saying it just to say it, we're saying it knowing that we can back it up. Reach out to these other advocacy groups, call our helpline, or email us us at pcri.org/helpline and get the help you need. We want to be there for you. We're built this way for a reason. Subscribe to our channel. Speak out and share your story. Talk about your experiences on the comment section. Help other people and comment on other people's comments, because the community is the most powerful thing about PCRI. Now, we would love to see you in person in September, because we want our community together and we want to be able to experience each other together. So if you can do so, visit pcri.org/conference and sign up, because it'd be great to see you. And also join us for our Men's Health Conference, because prostate cancer is not just the only thing going on in your body, and we want to be able to help in other areas as well. We are looking forward to sharing that information in June, so please join us there as well, and you can sign up on pcri.org. Now, without further anything else, I just want to remind you, my last statement to you is you are not alone.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing, and that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, this is not a dull conference. This is, I don't want to use the word entertaining, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.